also, and microcephaly. If you can show my slide. So this is a summary of the sessions for today, and I really hope you enjoy this course very much. And we are going to start our session on the fetal neurosonography in the NGS era with my dear friend Roy Birnbaum, that's going to speak about brain pattern recognition and when the phenotype and the genotype correlates. So which are the patterns that will allow us to suspect on specific disease. Roy is a senior consultant in our group in LIS in Tel Aviv. Please, you can start, Roy.
Hi everyone. First of all, I wish to thank the organizers and Extempore for the invitation to be with you again in our neurosonography course, and my good friends and colleagues Nina and Gregor for moderating and organizing this fantastic meeting. We have amazing speakers and I'm sure you're going to enjoy it very much. I was asked to give this talk, which was called Brain Pattern Recognition when Phenotype and Genotype Correlate. Now, I wish to take the liberty and challenge this topic and challenge the name of this talk and try to convince you why this talk today should be called differently and to suggest to call my talk Brain Pattern Recognition, does phenotype and genotype correlate, with a big question mark. And I think it's time for us, the neurosonographers, to change, to shift the paradigm. The geneticists know it already, it's common knowledge for them, but we as neurosonographers, the people who produce the phenotype, should change the paradigm. Now, as you all know, I'm not a geneticist, I'm a neurosonographer, and I'm going to try to take you through this talk in the eyes of the neurosonographer. Now, I think everyone today knows that the introduction of next generation sequencing technologies has significantly increased our detection rate and our understanding of the genetic etiologies of brain conditions. Now, I'm not going to talk about all these new papers that describe the detection rate of exome sequencing because it's a quite common knowledge, I think, today. But there is this paper that the study that came from our group a few years ago, led by our genetic institute by Professor Yuval Yaron and our team, and in which we performed exome sequencing for fetuses that underwent termination of pregnancy due to significant or major CNS anomalies. And what Yuval found is that if you just perform a chromosomal array, the detection rate for pathogenic or likely pathogenic copy number variants is around 10%, and this is quite in good correlation with what has been already described in the literature. However, the detection rate for exome sequencing was almost 4 times more higher. It was around 44% of cases. In a subgroup analysis of fetuses with complex brain abnormalities, it reached almost 60% of the cases. So it's a very high detection rate for exome sequencing in brain malformations. However, recently there has been this meta-analysis and systematic review of the literature has been described published in the BJOG just a few years ago, and this meta-analysis found that a quite lower detection rates for exome sequencing and for the chromosomal array for any brain abnormalities the exome sequencing detection rate was at around 26%, and chromosomal array only 3 to 4% of the cases. And I think it's quite clear that the difference between these two papers results from the selection bias. If you take a general term like brain abnormalities and you include everything inside it, the detection rate will drop. However, both of these studies show you that the exome sequencing and the is the method of choice in terms of genetics. However, if you think of it, if you take the original title of my talk, it means that we should be able to look at the phenotype and then recognize the genotype. So why do we need exome sequencing? Why do we need genetic studies? If we know the phenotype, we used to think that we know the genotype. Now, the use of exome sequencing and sometimes genome sequencing enables us to shed much bigger perspective and much bigger light on the genetic etiologies. And what we learned in the last, I think, 2 or 3 or 4 years is that what we think we knew the gene, we were surprised again and again to see how much the spectrum of the genetic etiologies is much broader, and which made me come to the conclusion that this talk should be to put a question mark on this genotype-phenotype correlation. Now, I would like to start with an example and show you this clip of a neurosonographic examination of a fetus in a routine mid-pregnancy scan, 22 weeks I performed a few years ago, and I go slowly on the coronal images, and you can quite clearly see that there are a few brain malformations in the fetus. And to make a long story short, because I cannot interact with the audience now, but to make a long story short, if I would ask you what is the genetic diagnosis of this fetus, I hope that most of you will give me the correct answer. It is a fetus with a tubulinopathy. And I'm going to use the tubulinopathy group and to use it as a model to convince you how tricky and how complicated is genetics and how careful you should be when you're using the term genotype-phenotype correlations. So in order to understand it, we need to dive a little bit deeper into what are the tubulinopathies. Now, in order to understand the tubulinopathies, you need to ask yourself, what is the cytoskeleton? The cytoskeleton is a big framework or meshwork of protein and filaments inside the eukaryotic cells. Now, this big chain of filaments and tubules, they are responsible for maintaining the shape and the structural integrity of the cell. They organize the localization of various inner cell organelles, which should be moving around from one area to another. They facilitate cell movements, and as you know, neurons have to move a lot during brain development. They have a key role in mitosis and meiosis because the spindle fibers, they separate the sister chromatids in the process of mitosis, in cellular proliferation, which is another important step in neurogenesis. And they are involved in cell signaling and communication between cells. And the most important or the largest cytoskeletal filaments are the microtubules. Now, in order to understand a little bit better what are the tubulinopathies, look at this short video clip, this very nice illustration. And what you're having here is an inner look into the cavity of one cell, and you can see here in the background and here a lot of spindles and a lot of tubules spread around the cavity of the cell. And what you can see here, for example, is this vesicle that being moved by this very funny looking character walking on this filament, moving around stuff. So you have this big mesh work of filaments, which is the cytoskeleton. Most of it are the microtubules. Now, how do you create a microtubule? What is it made of? So the microtubules are composed of these heterodimers. As you can see here, the heterodimers are composed of the combination of two globular subunits. One of them is the tubulin A or tubulin alpha, and the other one is the tubulin beta, as you can see here, and they are joined together to create this heterodimer. And the heterodimers are like a small Lego blocks, the small building blocks of the tubule, of the microtubule. Now, the properties of the microtubules are they can either elongate and growth by the combination of a lot of heterodimers, or they can disintegrate, or they undergo a catastrophe in which they are separating from each other when you need to break down the microtubules. So these are the basic elements of the microtubules of the cytoskeleton. However, you need to remember that it's not only about building like a Lego blocks of a long chain of a polymer, but these microtubules have to interact with additional molecules that are attached to them. One of them is the family of the microtubule associated proteins. These proteins are responsible for stabilizing and destabilizing the tubule to give it its strength, but also to weaken it if you want to break it down. And another family of proteins are the motors, as you saw in the video clip, and also you can see here in the illustration, the small molecules that know how to jump from one building block to another and to have movements inside the cell. So all of these small molecules has to interact with the small heterodimers of the microtubules. Now, with respect to cell development, the microtubules are involved in many different important stages of brain development, because brain development is a very complex cascade of events. So the microtubules are crucial for maintaining the shape of the neuron. They are crucial in proliferation, and you know that in order to build a brain, you need a very large pool of neurons. So they are involved in proliferation, as I mentioned earlier, in mitosis and separation of the sister chromatids. They are highly involved in migration. Migration is something that involves movement of cells and elongations of cells, and exactly the same goes for the axon guidance. If you want to create a very long commissural fiber, this axon has to navigate and find its way. Transporting cargoes along the axon, as I showed you before, and the formation of synapse. So many steps along the way of brain formation, as you can see here in the illustration, are involved with microtubules. And as a result of that, it is not surprising that there are many mutations which affect the genes, both the alpha, the beta, and the gamma tubulin, called tube A, tube B, and tube G genes, and all of these mutations are associated or involved in the wide range of malformations of cortical development, which results from various errors along the pathways, as I just showed you. Now, since today we know these different genes and we know their different effect on the brain, we came up with a term called the tubulinopathies phenotype. So it's a phenotype, a combination of different brain malformations that gives rise to the tubulinopathies. Now, the first gene that has been described for the tubulinopathies was the tube A, the tube A1A, which was classically associated with the lissencephaly, the typical lissencephaly like LIS1, or the lissencephaly plus cerebellar hypoplasia. There are also high rate of abnormalities of corpus callosum and basal ganglia and internal capsule malformations, because as you know, the internal capsule is associated or is a result of axon pathway and axon guidance. So if you have abnormal with axon guidance, it's not surprising that you're going to have various abnormalities in fiber tracts along the brain, both the commissuration, the corpus callosum, and the internal capsule, which affects also the shape of the basal ganglia. It creates a fusion-like appearance of the basal ganglia. Let me show you a fetus with a tubulinopathy, and these images, they are quite old images that shared with me by Professor Malinger. So this is a fetus with a Lisens. You see the typical lissencephaly. It's a almost smooth brain. At some areas, it has a dysgenetic corpus callosum, a ventriculomegaly, as you may see here, a microcephaly. So the head circumference was below -2 standard deviations. If you look at the sulcation, it's not completely lissencephalic all over. There are areas of disorganized sulci, and hence the term dysgyria, which is highly associated with the tubulinopathies. Also, the vermis and the brainstem, as you can see here, are involved. And there's a very typical feature that you should be recognizing, is this very typical deviated midline. We call it an interdigitation of the midline, which it looks like one of the hemispheres is trying to overgrowth or to push into one and the other hemisphere. So this combination of findings is a typical appearance of a fetus with a tubulinopathy associated with tube A. And as you can see, the MRI images confirm or highly correlate with our ultrasound images. However, let me show you a fetus that was referred at 26 weeks due to only asymmetric ventricles without ventriculomegaly. And when you perform a neurosonography, you see again there's a combination of very different findings, but they are all correlated together. There's a small cerebellum in the range of almost hypoplasia or a smallish cerebellum. The sulcation is not smooth, it's not a lissencephalic brain, but it's not also not polymicrogyria. You see here very disorganized, very weird looking gyri. So these are a form of a dysgyria. You see that there's an asymmetry along the basal, along the brain hemispheres. The hemispheres look different. So one of the characteristics is asymmetric brain. You can also see that this brain also is microcephalic. The basal ganglia are different, and again, milder but still present irregular interdigitation of the interhemispheric fissure. So you can see that it looks quite like the previous case of the tubulinopathy, the tube A that I showed you, but it's not exactly the same. It has the same pattern but in a different scale along the same spectrum, and this fetus had a tube B mutation. So we had a pattern with various phenotypes or the various spectrum. Now, let's continue on, and I mentioned the lissencephaly because tube A is associated with lissencephaly, but I'm sure you all heard about these two genes, the DCX and LIS1 genes. These were the first two genes to describe, to be found to be associated with lissencephaly. And these are well-known genes many years ago, and they are highly, we know a lot about these genes. Now, if you ask yourself, what are these genes? What do they do? What are their properties? And you look deeper, you see that what DCX and LIS1 are actually the microtubule associated protein, as I mentioned earlier. These are the proteins that are associated with stabilizing the building and the fragmenting of the microtubule. So you can ask yourself, maybe LIS1 is a tubulinopathy? No, it's not a tubulinopathy because it is not associated with the tubulin genes, but they are related to the phenotype, they are related to the malformation which gives rise to what we know as the tubulin phenotype or the lissencephaly phenotype. So you see that they are highly related together, and it's quite difficult to say whether this phenotype is this genotype or that genotype, because we see even on the molecular basis they are highly related. Now, you remember this nice video clip that I showed you earlier, and we were talking about the microtubules, but now let's focus on this funny person that carries this vesicle and doing this walking in communication between the legs of this person and the building blocks. So you see this is a kind of a motor that moves around the vesicles with the interaction between the legs of the motor and the microtubules. So this is another related family that are called the molecular motor genes, and one of them is the KIF, the KIF gene, which is highly related to the tubulinopathy. Because of this relation, it has a phenocopy of the tubulinopathy, but this is not a tubulinopathy because this is not a tubulin gene, this is a KIF gene. And actually, recently we published this paper in which we described two consecutive fetuses with two missense variants in KIF14. Again, the KIF is the engine that communicates with the tubulinopathies. And if you look at the phenotype of these fetuses, you see again they had this genetic corpus callosum, they had this plastic cerebellum, an abnormal sulcation, and a small head. So it has a huge overlap with the tubulinopathies, and also a molecular or functional overlap with the tubulinopathies, but it is not a tubulinopathy. We cannot call this a tubulinopathy. So again, the phenotype and the genotype, they are in a sense related, but they do not overlap. Now, from once we had this understanding, we had and we came up with a more experience in the tubulinopathies. This is a very important paper published a few years ago, and it's a large collaboration between our group and the French group by Catherine Galel and other colleagues from Israel, Professor Tali Sagi and Zvika Leibovich and Professor Ben Sira, and of course Professor Malinger and Dr. Kreidel from our group, and the group from Catherine Galel. And what this paper shows is if you take fetuses that are confirmed to have a tubulinopathy, but you take out all the severe cases, the one you exclude the lissencephaly and you exclude the microlissencephaly, and you come up with those that has not such a severe tubulinopathy, we call them the mild tubulinopathies, you can see that over 70% of those fetuses had this pattern of midline distortion, ventricular asymmetry, dysmorphic antefrontal horns, and abnormal sulcation. And in 50 to 70%, you have a distortion, again, the distortion or this very strong phenotype of asymmetry and distortion of one side toward another, also involved in the cavum septopellucidity, callosal anomalies, absence or asymmetry of the olfactory sulci, again, this asymmetry between the hemispheres, basal ganglia anomalies. As I told you before, it is related to the fact that the internal capsule is hypoplastic and it gives rise to the fusion of the caudate and the neighboring basal ganglia, and the ventriculomegaly. So you see here, again, these are all tubulinopathies, but they have different there are different ends of the spectrum, of different locations along the spectrum of severity. So remember that the tubulinopathy is a wider range. Now, not surprisingly, among this group of fetuses, most of the associated genes were related to the tube B family, and less popular were the tube A genes. However, 17% of them still were the tube A, and as I mentioned earlier, the tube A is the more severe end of the spectrum. It is a lissencephalic, but here we see 70% of those with the tube A actually are not lissencephalic because we ruled them out, and are not microcephalic. They have share spectrum, and although they are a tube A and not tube B malformation. So remember, again, I'm trying to show you that this genotype-phenotype correlation that we used to think in the older school is now becoming less evident. And even more interesting is that among this cohort, 10 families, one of the parents has had exactly the same MRI findings, abnormal findings as we discussed here, and as a result of that, they underwent genetic examinations, and they were also were found to be positive tubulinopathy, and they were completely normally developing people. They didn't understand what we are talking about. What do we want from them? They have a perfect normal life, but they have a tubulinopathy. So you see, again, this is the very mild end of the spectrum, because otherwise these people would never have been examined. Only because they are pregnant, they came up to have an MRI and then genetic assessment. So this shows you how problematic it is, this counseling of these cases. If you have tubulinopathy and the parent have a tubulinopathy, what does it mean if the father and the child had the fetus had the same phenotype? Is he going to have the same phenotype, the same neurodevelopmental outcome? It's a big question mark, which again puts the whole concept of phenotype genotype correlation in a big question mark. Now, if you conclude whatever I said up until now, you have to be aware of this phenotype, of the tubulinopathy phenotype. It includes asymmetry of the brain, cortical dysgenesis, callosal involvement, basal ganglia involvement with dysmorphic and asymmetric, and also midbrain, hindbrain, which may involve the brainstem with kinking of the brainstem, for example, or abnormalities of the vermis and the cerebellum, as you can see here in these examples. So once you have in mind this phenotype, let's try to challenge that. And let me show you a case. This is a fetus just recently. I scanned this fetus just recently, 22 weeks anatomy scan. And if you start with the normal screening view, the axial view of the brain, you can see here already there is an asymmetry between the brains. If you look at it, I will stop the clip here. You look at this line here, the interhemispheric fissure is abnormal, and you can see here that although you think that the brain is symmetric, now the cerebellum has become asymmetric. You see one hemisphere is bigger than the other one, so if you want to have a symmetric image, you have to tilt the probe. So something is asymmetric in this brain. So I had a feeling that this is about to be an abnormal brain, and I performed the neurosonography, and you look at the images, you can see clearly that there's an asymmetric brain, an interdigitation of the brain, the funny looking or suspected corpus callosum. On one side, you can see here this very abnormal sulci. So we have, again, all the phenotype in mind, and I was quite positive to tell the patient that there is a brain abnormality, and it is most probably genotype. This phenotype correlates with the genotype of tubulinopathy. So probably from the milder spectrum, as I showed you in our previous paper, but this is a tubulinopathy. Now the question is, are we sure It isn't tubulinopathy. What I didn't mention is this patient already had a chromosomal array, and the chromosomal array was normal, but they mentioned that there's an area of loss of heterozygosity. And due to the fact that we had these findings and the loss of heterozygosity, we continued to perform a methylation examination, which came back positive for Angelman syndrome. And as you all know, Angelman syndrome is a severe condition which is associated with ataxia, intellectual disability, speech impairment, seizures, autistic spectrum behavior, hyperactivity, and frequent laughter. And you all remember that Angelman syndrome results from loss of function or loss of expression of the maternal allele, the maternal inherited allele of the UBE3A gene. So there are various genetic pathomechanisms which may lead to Angelman syndrome. Most of them are deletions in the maternal allele or specific point mutation in the maternal allele, but in the minority of cases, there is also uniparental disomy, in a scenario in which the fetus inherits both parental alleles of the gene, and he does not have any maternal allele, and eventually give rise to the phenotype of Angelman syndrome. Okay, but does this Angelman syndrome, what does it have to do with the phenotype of the tubulinopathy that our fetus has? So is it a tubulinopathy? Is it Angelman? We look to the literature, there's no description of tubulinopathy-related Angelman syndrome or something like that. So performed an exome sequencing, and what we found is that this fetus has a mutation in a gene that I'm sure you all heard of, is the PIK3CA gene, and it is in a mosaic form in 50% of the cells. So now, does this tubulinopathy, which by now we know it's not a tubulinopathy phenotype, corresponds with this gene? This is an Angelman, maybe it's both. And furthermore, to complicate things, the head circumference was exactly within normal limits. It was not even slightly large. And we know that PIK3CA is associated with the phenotype of megalencephaly or hemimegalencephaly. But now, if you look closer at this fetus at 22 weeks, this features corresponds to hemimegalencephaly. And what we assume is that there is a somatic mosaicism in which in the amniocentesis we found the mutation only in 15% of the cells, but probably if we would have performed biopsy, brain biopsy at various areas in these brain hemispheres, there's a good chance that we would find a higher rate of mosaicism of mutated cells with the PIK3A that may explain these focal areas of brain overgrowth and this symmetric picture. Now, the PIK3A, as you all know, is highly associated, is part of the mTOR pathway, the mTOR signaling pathway, which is the most common or most known pathway associated with the syndromic megalencephaly, because this pathway is associated, or mutation in this pathway are associated with the hyperactivation or gain of function in the whole chain and the whole pathway, which gives rise to abnormal proliferation, cellular proliferation, abnormal apoptosis, abnormal metabolism, and angiogenesis, and eventually associated with the full spectrum phenotypes of syndromic megalencephaly with capillary malformation or polydactyly, and etc., which is beyond the scope of this talk. But we started with a fetus that I was sure that it has a tubulinopathy. Now, why do we think that this fetus that had only 50% of the cells mosaicism with the PIK3A, if we would have performed the brain biopsy? Let me show you this case. This is a fantastic case that was examined by Karina, my good friend and colleague, Dr. Kreiden. She's also my boss. And this is a fantastic case that this fetus had in his mid-pregnancy scan lateral ventricles of 10 millimeters, but when the referring physician followed up on this fetus, he saw that there's an increase, there's an acceleration of head biometry, and at 35 weeks it reached +3 standard deviation, beginning from 1.8, climbing all the way to +3 standard deviation of the head circumference. So Karina examined this fetus, and she noticed there's, in addition to the fact that the head is huge, it has a very abnormal sulcation patterns suspected to be over-sulcation or polymicrogyria, and we performed the MRI. As you can see here on the MRI, you can see the images that the MRI confirmed that the very big head, 3+ standard deviation, and you can clearly see there's a very abnormal opercular angle, there's an abnormal closure of the operculization, and the most striking finding are the overfolding and this polymicrogyria pattern of especially the anterior gradient of very overfolded cortex, and together with hypertelorism and megalencephaly, this was we were sure this is a syndromic megalencephaly. And we performed the exome sequencing, and what we found is the fetus is heterozygous, again for a variant in PIK3 PIK3R2, but from the amniotic fluid, it was positive only in 8% of the readings, which was a little bit low. So what we did, led by Dr. Kreiden and our pathologist, Professor Kirdon, is we took biopsies from various areas of the brain, and we found that in the brain it was a 20% mutation. So this was the proof that this fetus has an overgrowth hemimegalencephaly, a megalencephalic syndromic megalencephaly due to a somatic mosaicism in the mTOR pathway. Now, actually, we knew that, and we were encouraged and enthusiastic to do that because we knew about this fantastic paper by Ritsuko Poo, and you're going to hear a great, brilliant lecture from her, which is a good friend and colleague of us. And she published this paper in which they showed exactly the same thing. This was a fetus with hemimegalencephaly. You see that both sides of the hemispheres are abnormal. There's an asymmetry of the brain, irregularities of ventricular wall. There's a very large ganglionic eminence, hypertrophic ganglionic eminences, and left-sided hemimegalencephaly. This fetus also had a short middle phalanx of the fifth finger. And what they did is that they performed exome sequencing from various biopsies from both hemispheres, and they confirmed the mutation on both hemispheres, but it was not detected on the hard biopsies, and also it was not detected on the blood. So again, this was the first our first lesson regarding somatic mosaicism, which was confirmed in this beautiful paper by Ritsuko. Also, they show the nice heterotopia and the migration abnormality with the subcortical heterotopia. And you can see here in the histologic examinations this overfolded cortex, irregular cortex corresponding to the polymicrogyria, and everything corresponds to the fantastic images by Ritsuko on the neurosonography. So again, we started with a suspected tubulopathy. We ended up with a somatic mosaicism in the brain of a hemimegalencephaly. So genotype and phenotype, be careful, they not always correlate. Now let me show you another case. This is a fetus that we scanned that was referred to us at 16 weeks because of a brain cyst. And the cyst that this fetus was referred was an interhemispheric cyst, as you can see here between the hemispheres. But when you look closer on the brain, in addition to the fact that there is actually a large interhemispheric cyst, there are also cavitations here of the ganglionic eminences. So this fetus has ganglionic eminence cavitation and a large interhemispheric cyst at 16 gestational weeks. So whenever we have these kind of fetuses, we perform a complete anatomic assessment by transvaginal ultrasound, and what we also found in the fetus is something very, very particular and very, very rare. If you look at the upper lip of this fetus, you can see here there are two pits along the lips. It looks like teeth, but actually these are not teeth. These are additional tissue connected to the upper lip. So we asked ourselves, we went to the literature, we were looking for this phenotype, and we asked ourselves, what is it? And what we came up with, there's a possibility that maybe this fetus has what is a term called a double lip. We were not sure, but this was a differential diagnosis. And if you look for a double lip, one of the syndromes is called this Usher syndrome, which is associated with a double lip, blepharocholasis, and also euthyroid goiter, non-toxic goiter. So we ask ourselves, and there's no genetic background for this Usher syndrome, and we ask, very misleading as I showed you, what we once viewed as a classic phenotype for specific genetic conditions may only be looking through the keyhole and looking for a very narrow window which we must widen. And your main objective today is to provide accurate ultra phenotyping for the geneticists, which require good pattern recognition skills. So you need to ask yourself, do I understand the full scope of the phenotype, or just I see just a ventriculomegaly? If you have just a ventriculomegaly, look carefully, because you may have also polymicrogyria or this genetic corpus callosum. So the phenotype for the geneticists has to be ultra phenotypic. It changes completely the way that they analyze the genetic variants. And you must inform your patients, and the patient should be informed by you and by your geneticist that you have today. We have a very wide arsenal, wide tools, genetic tools to perform much beyond the chromosomal array, and you should be informing your patients about the possibility to perform this, because this might also help them to understand the full magnitude. Open the classroom for the geneticists. We must have a very good knowledge regarding the developmental anatomy, both from the anatomical point of view and from the genetic and the molecular point of view. We must have a very good fetal MRI specialist today with sophisticated tools, like I'm sure you're going to hear from Gregor, and of course the pediatric neurologist, because as I showed you, if we thought that the genotype phenotype is complex, but the outcome is even more complex, so you must have a good pediatric neurologist on your team. And I wish to thank you very much for your listening, and I hope you enjoy the remaining of this fantastic meeting. Bye-bye.
Hello, everyone. I want to apologize first for our technical problem. And just for you to know that in the recordings, this lecture will be provided with the full correction and also with the minutes that were missed due to the technical problems of transmission. So you are all going to be able to recall the lecture and see it in full screening, and you're not going to miss anything. Thank you, Roy, for this brilliant introduction to this very complex topic. And I want to introduce and to welcome my dear friend Ritsuko from Osaka, Japan. And she's an amazing expert and well-known into the field of fetal neurosonography. And she also runs a lab on genetics. So from us all, she's the most experienced one into also fetal genetics. And we are going to hear her talk about the ever-changing brain and the developing phenotypes in fetal neurosonography. Thank you, Ritsuko.
Hello, everyone. Who from Japan? First of all, I'd like to thank Ravi and all staff of Extempore for inviting me to this enthusiastic event. I'm going to share with you challenges in fetal brain phenotyping. This is my COI disclosure. And I have been challenging the investigation of the brain morphological assessment for about 30 years. And I discovered several signs contributing to fetal brain phenotyping. Today's my talk is mainly about brain morphological abnormalities on the coronal plane. But first of all, I would like to share my recent challenge of early sign of Joubert syndrome in the first trimester. This article was published last December. Joubert syndrome and the Moratus sign are used as a pair of terms. Here is the actual image from the pediatric MRI in normal and Joubert syndrome. Here is a Moratus sign. What is a Moratus sign? The Moratus sign, the roots of Moratus represent angle shifted and maloriented and elongated superior cerebral peduncles, SCPs. And Joubert syndrome has 40 subtypes with different causal genes. However, Moratus sign as a hallmark brain feature in all subtypes. My concerns were is there a common functional feature in the all 40 Joubert responsible genes? Now, the prenatal diagnosis of the Joubert syndrome remains challenging because in the late pregnancy, the bilateral cerebral hemisphere develops typically and are kissing each other medially due to the Birmingham hypoplasia. And it's also difficult to diagnose Joubert syndrome in early gestation because SCPs are not yet formed in early pregnancy. We have the 5 cases of Joubert syndrome, and those are images of the first 3 cases, the lateral views of the fetal head and sagittal and coronal images. The changing brain morphology between 16 and 20 weeks of gestation in case 4, the dashed line through the aqueduct and fourth ventricle are drawn in the sagittal plane, and coronal plane, the coronal section cut by the dashed line is shown here. Further, the line becomes gradually from vertical to the horizontal as gestation. We did autopsy of the case 5 after termination at 21 weeks of gestation, and axial section showed baby molar 2 sign. And here you can see the premature, the tissue of the superior cerebellar peduncle. And at this stage, SCP is not yet completely created. Here is a summary of 5 RE-Juber syndrome cases. All cases had the common findings isthmus open and lambda sign. What is a lambda sign? I would like to share the omega and lambda. In normal cases, isthmus, here this is called isthmus, and isthmus is closed in very early pregnancy before 8 weeks of gestation, and the mesencephalon and the rhombic lips in the coronal image show the omega-like appearance, and we call that omega sign. In Juber syndrome, however, the isthmus is open. Therefore, in the coronal image, you can see the lambda appearance, and we call that lambda sign. Again, the closed isthmus and omega sign in normal, and the open isthmus and the lambda sign in Juber syndrome. How about this case? This is the fourth ventricle, very wide, and here you can see the closed isthmus and omega sign. So this is not the Juber syndrome. This is the collagen 1 alpha 2 gene variant case. In Juber, it all started with the open isthmus. The superior cerebral peduncle, this is a normal SCP, but in Juber syndrome, SCP is elongated and maloriented. As the cerebellum develops as gestation, and SCP elongate gradually becomes horizontal and eventually forms the molar 2 sign in the actual image of MRI. Now, the next topic, in the second trimester, it is challenging to predict MCD, malformations of cortical development, because no gellification yet at this time. As shown here, the Sylvian fissure is changing its appearance, and Sylvian fissure is representative of cortical sulci, and MCD is cortical gellification abnormalities. So we designed to predict the MCD by quantifying the changing Sylvian fissure in the second trimester. We published 2 papers on Sylvian fissure angle in 2018. And for the Sylvian fissure angle measurement, there are 3 steps. The step 1 is the acquisition. Step 2 is setting the consistent plane. And the step 3, the measurement. The step 1, the 3D neurosonography acquisition via anterior fontanelle. And then the 3 orthogonal view A, B, C views correspond the coronal, sagittal, and axial sections, respectively. The first on the view B, the sagittal section, the mid-sagittal section was visualized by manual rotation, and it was ensured that frontal lobe was on the left of image, and set the corpus callosum as lower portion of the genu and the splenium are horizontal. And on the sagittal image of B plane, put the dot on the tip of the telocoroidea, the third ventricle choroid plexus. Then the dot indicate exactly the same point on the coronal image of A plane. Then magnify the A plane. Subsequently, the right and left Sylvian fissure angles were measured between the horizontal reference line, 0 degree, and the second lines drawn along the right and the left upper side of Sylvian fissure, like this. After 25 weeks, the Sylvian fissure angle becomes opposite do as the same way to measure the Sylvian-Fisher angle, but the second lines are different angle from them before 25 weeks of gestation. The first Sylvian-Fisher angle is positive, but later on it becomes a negative angle. When the Sylvian-Fisher angle is 0 degrees, that means when the Sylvian-Fisher is rectangular, it is 25 weeks. So now you can notice abnormal Sylvian-Fishers here in the MCD at 25 weeks of gestation. It is quite easy to have the suspicion of the MCD around 25 weeks of gestation, even if you don't measure the SFA. Now I'd like to share several cases. This is a case at 18 and 20 weeks of gestation, and you can see the Sylvian-Fisher angle is out of the normal reference, and this is a de novo 20p microdeletion. And this is a case at 27 weeks of gestation. After 25 weeks of gestation, still this is very premature Sylvian-Fisher. And here, this is a graph, and this is the chromosome abnormality in this case. And 26 weeks of gestation, we didn't find any chromosome abnormality, and as well as exome sequencing resulted in negative. But this case, postnatal outcome prognosis was bad. The severe epilepsy occurred. And this is a graph of the Sylvian-Fisher angle. Now, sometimes, we have the difficult case. Here, this is at 19 weeks of gestation, the brain appears normal and no ventriculomegaly, and Sylvian-Fisher seems to be normal, but we measure the SFA. The left SFA is outside of the normal range, and the right SFA is on the line of the 90 percentile. Because of the facial expression and other the complication, we suspected the genetic abnormality, offered the exome sequencing, and while waiting for the exome sequencing results, we repeated the weekly transvaginal 3D neurosonography. Sylvian-Fisher does not appear to change much between 19 and 21 weeks of gestation compared to the normal case shown here. However, it is quite challenging if you just observe the Sylvian-Fisher structure every week. How about the Sylvian-Fisher measurement? Here you can see the graph shows the SFA was gradually getting out of the normal range week by week. In this case, the FOXC2 gene variant. Now this is another case, 26 weeks of gestation, the microcephaly. And this case, the very abnormal Sylvian-Fisher. And after that, we followed up every 2 weeks. But brain development was extremely slow compared to the normal case. And SFA remains virtually unchanged and moved farther away from the normal range. This is a case of the BAB1B gene variant, compound heterozygous. So the SFA measurement in the second trimester assists a prediction of MCD. Now, the next one is the CATIA line. We published the CATIA line in 2022 in JUM. I've noticed the diagonal, the echogenic lines outside of the lateral ventricles in the anterior coronal planes of the fetal brain in the beginning of 2000s. With advances of ultrasound, those lines have been much more clearer. In addition, we noticed missing linear structure or different shape in some cases of MCD. As you need to know, the layers of the brain can be seen in the coronal plane as shown here. Here, this is the substrate, and here, this is the intermediate zone plus outer subventricular zone. And here, this is the definition of CL. CL was defined hyperechogenic lines through the substrate and the intermediate zone. And the line that exists only in the substrate was named pre-CL. CL is formed rapidly before 20 weeks of gestation. At 16 weeks of gestation, the 20% of the cases had no visible CL and 80% were pre-CL. At 17 weeks, most cases had pre-CL, but pre-CL is changing into CL during the next 2 weeks. And after 19 weeks, almost all cases had CL. So this is a schematic illustration showing how and when the CLs are visible in normal cases. We compared control and the MCD groups, and the pre-CL was 60% in MCD groups, while only 2% in control group. In addition, abnormal CL is seen only in the CL, the MCD group. This slide shows representative images of maldeveloped CLs and the schematic illustration in MCD cases. Here you can see this is a pre-CL and the abnormal CLs. This case, persistent pre-CL after 19 weeks of gestation. And here, this is the abnormal CL. And this is a summary slide of our speculation of the normal and abnormal CL development. And CL plays a role in assisting the MCD diagnosis. We found that CLs appears always perpendicular to the ultrasound beam. Therefore, on the transabdominal neurosonography with convex probe, the lines exist more like horizontally on both sides. So the Katia lines are serial radial lines that exist continuously on the coronal section, like here. Interestingly, the CL is never visualized in histology nor MRI. Obviously, CL is an ultrasound-specific finding. The observation of CL is an additional indicator that can help predict MCD. So, what CL represent? I believe that CLs may represent medullary veins. And here you can see those are medullary veins demonstrated by 3D slow flow at 21 and 25 weeks of gestation. And from our study, we believe that pre-CL represents a superficial medullary vein, and the CL represent the medullary veins, more specifically the veins where superficial, anastomostic, and deep medullary vein all merged. However, there is a time lag of neurosonography depiction between CL and medullary vein. Those are 3D images at 23 weeks of gestation without and with slow flow Doppler angiogram. And CL is already observed throughout substrate and in intermediate zone, but most of medullary veins are visualized only in the substrate. So this delay may be due to the limitation of Doppler resolution to delineate the peripheral fine vessels. Lastly, most recent challenge to Down syndrome brain. How many participants here have recognized Down syndrome in the second trimester from just looking at the brain morphology. We discovered the dual features of Down's brain in the second trimester, the Seeger sign and thin substrate. But before that, in the 1990s to 2000s, many articles were published regarding the brain biometry in Down syndrome, concluded the frontal lobe hypoplasia and cerebellar hypoplasia. And recent MR studies of fetal and child brain with Down syndrome showed reduced brain volume. We did the retrospective case control study. We had the control, the euploid cases of 772 cases, and Down syndromes, the 76 cases, including the 3 mosaics. And all cases, the transvaginal 3D neurosonography between 17 and 30 weeks of gestation was done. The first, we did brain biometry using extracted sections from 3D neurosonography dataset and calculated intracranial cavity volume by using the vocal software. Those are the results of brain biometry. We found the intracranial cavity volume and the frontal, the thalamic distance and atrial width have a significant difference between Down and control groups. And TCD tends to be smaller in Downs. However, there are many genetic syndromes and other diseases with ventriculomegaly, and also the small brain or small cerebellum. From my experience with the neurosonography for many years, I recognized characteristic phenotype of Down syndrome brain, the Seeger sign and thin substrate. The Seeger sign indicates our cerebral hemisphere configuration like a seagull with its wings spread. Those dual features can be recognizable with just a glance. However, we did quantitative evaluation of those features. The Seeger ratio is significantly higher than that of normal control. This tendency was obviously elucidated between 17 and 21 weeks of gestation. And substrate is significantly thinner and constantly thin before 30 weeks of gestation. But intermediate zone plus outer subventricular zone, this thickness is the almost normal. And those are representative neurosonography images of Downs compared to the controls at 17 to 21 weeks of gestation. Note the Seeger sign and thin substrate across the Downs cases. And also we did the sequential measurements showing in 9 cases and showing a spontaneous decline in Seeger ratio during the late second and early third trimester, while thin substrate remains thinner than control. Now, the quiz. Is this the Down syndrome brain? Yes or no? Yes. This is the Seeger sign with high Seeger ratio. However, the substrate is thick, not thin, while the intermediate zone is quite thin. This is the opposite to the Down's brain. So this is not the Down's brain pattern. As a result, this case is a case of the GLI2 gene variant, and Seagal sign is occasionally seen in MCD cases other than Down syndrome. But check out, I always check out the same time whether the substrate is thin or not. So why I say dual features is to emphasize that the Down syndrome brain has both of those features present at the same time. Recent study from Japan, published 10 days ago, showed artificial trisomic rescue of trisomy 21 cells. They successfully excluded one chromosome 21 from trisomic cell by CRISPR-Cas9. In the United States, NIH launched INCLUDE project, that is an investigation of co-occurring the conditions across the lifespan to the understanding Down syndrome. And this project was launched in 2018 and has invested in research project of fetal therapy for Down syndrome, FTDS, and early intervention. While ethical concerns remained regarding human application, this research could significantly benefit children with Down syndrome, their families, and society at large. However, there are currently no markers to evaluate FTDS efficacy during pregnancy. Since recently Down syndrome can be detected in early pregnancy due to NIPT or the FTS, first trimester screening. And our study results have the potential to make a meaningful contribution to this important field. Today, you could understand how important the coronal image of the fetal brain is. And fetal brain phenotyping is still challenging. However, if you observe the fetal brain closely and carefully and keep going, you may discover some new findings. Thank you very much. Hi everybody. Thank you very much for listening my talk and also Roy's talk. And next is the big professor from Israel, and the Karina Harat. You know, she is the best friend of mine, and also, you know, she is pursuing the fetal brain for many years with Gustavo Maringel and Roy and other staffs, and she has always amazing lectures. So, you know, please be watching her lecture. Thank you, Karina.
Thank you, Ritsuko, for your kind words and for being here with me today. And we are going to have opportunity to discuss after the present lecture all these interesting topics. Thank you for your amazing lecture. And we are going to discuss the final topic on this session about the overlapping and discordant phenotypes in fetal CNS syndromes that Roy and Ritsuko have already introduced a little bit of the challenges of this very, very important topic. And I'm going to start with a summary of that study that Roy has already presented on the exome sequencing as a first-year test for severe CNS anomalies. And we have developed this SPIN study, checking on the phenotypes of the fetuses that we have found abnormal genetic findings in the investigation. And then we have checked whether the presentation during fetal life was concordant to the most classic described phenotype into the literature. So probably we compared to the known postnatal presentation of the abnormalities in order to check whether, okay, I see this fetus and this is a tubulinopathy, and how certain I can be of that. So we have classified these patients into like 4 groups with full agreement, which would be that the phenotypes corresponds to the phenotype described for a specific syndrome or a variant in specific gene. Agreement whenever the imaging phenotype corresponds to a broader group of known abnormalities, but not a specific syndrome. So it is a lissencephaly, but we cannot say which gene it is. Partial agreement whenever it presented features of the described phenotype, but the presentation was either partial or the findings did not correspond for the ones described before. And disagreement when the phenotype would be completely different from the expected. And we are going to describe and discuss in this lecture the partial agreement and the disagreement cases regarding their pathophysiology, regarding why does it occur, how can we be aware of these abnormalities. And these findings are very important, especially in countries in which whole exome sequencing is not a tool available. So many places we have either panels or clinical exome or very restricted possibilities of investigation. So by one hand, whenever we have a phenotype which is quite characteristic of a specific abnormality, the chances that a restricted panel will find the cause are higher. But as Roy has already started to introduce, many times, although the phenotype is quite characteristic of a specific abnormality, it is related to something else, and we are going to try to understand why. So in our group, in this first study that we are now broadening also for non-severe abnormalities, we had 2 cases of disagreement. Okay, one case of agenesis of corpus callosum. I'm not sure if you see my pointer, but I'm going to manage to do that. Okay, so one case of complete agenesis of corpus callosum with all the stigmata of agenesis of corpus callosum, a female fetus with asymmetric brain and signs of malformations of cortical development and interhemispheric cyst, quite characteristic of what we know as classic presentation of Aicardi syndrome. But as a matter of fact, it was a mutation in a collagen 4 gene, so-called 4A1 variant, and then where we expect to see brain damage. And the other case that presented with dysgenesis of the corpus callosum, delayed sulcation, and vermion hypoplasia with a small TCD, and we expected to find something related to a lissencephaly with cerebellar hypoplasia syndrome gene, but we found a variant in PAX2 gene, which is a metabolic disease, Zellweger syndrome. So why do these things happen? And why is it important whenever we have the chance to use exome sequencing and have a broader investigation of these cases? So first, understanding not only the molecular process, but also the CNS developmental processes involved in the brain development is very important. So we start for the closure of the neural tube and the neurulation. Then we have the brain patterning, the anteroposterior, the dorsoventral patterning, the development of the forebrain and the midbrain and hindbrain. Growth and apoptosis, the stopping of the growth, neuronal migration, and then post-migration development, and also axonal guidance. So not only the neurons migrate, but also these axons need to go to their specific places. And Roy has already also spoken a little bit about it, and Ritsuko about the development of the cortex, and also in parallel, the cerebrovascular development. So this brain needs to have adequate blood supply in order to perform all these processes together. Whenever we understand that, and then when we go to the molecular basis, we understand the overlap of the processes that rule this development. So whenever we see here in the prosencephalic development, we have genes that they are concurrent to the development of the prosencephalum and to the development of the midbrain and the hindbrain structures. And that's why sometimes in some syndromes, we will have also the corpus callosum and the brainstem and the cortex of the supratentorium affected. So the understanding of this complex net of development is very important for us not to panic whenever we see a case, and we try to think on the underlying mechanism of disease. So this is what we are going to speak about. There are many challenges in the phenotype-genotype correlation. I will try to be the most didactic that I can during this lecture in order to make you some order, because these topics are quite frightening in the first place. So our phenotype is based mainly on morphology. Okay, we don't have the patient to check on the clinical manifestation, and not always we are going to be able during fetal life to say the final diagnosis only based on imaging. We need high technical and clinical expertise in order even to suspect on the differential diagnosis of different entities, and that's why you are here today. We have many diagnostic misconceptions or preconceptions, and also, like Ritsuko, need to have her decisions in Japan mainly up to 20 weeks, I think. Please correct me later if I am wrong. And here in Israel, we have more freedom in order to see the late development in order to take decisions into the management of the pregnancy. And the evolving phenotypes. So Joubert syndrome at 12 weeks, at 15 weeks, at 30 weeks, and at 35 weeks may look different. And we need to understand these patterns. The early pattern of postnatally known, there are many diseases that they have a specific phenotype in the postnatal life, but how do they look at 12 weeks, at 20 weeks? Overlapping imaging presentation of different entities. So sometimes we have known entities presenting atypically. Sometimes we have an impairment of similar developmental processes. So very different diseases, but they affect the brain at 7 weeks. So there will be similar processes that were impaired into these two diseases, and we are going to see it in the imaging basis. Brain insults may mimic developmental abnormalities. We have a genetic variants that have different penetrance, especially in dominant diseases, and will lead to different phenotypic presentation. Female presentation of X-linked anomalies that we previously thought that was only for males. Missense variants with normal RNA splicing and VUSs. Sometimes the patient comes with an abnormal genetic variant, but the fetus does not manifest the abnormalities expected. So it is because some types of variants, they do not impair the final protein, speaking in very easy language. Fetal phenotype of abnormalities may have mild postnatal symptoms. So they are not very well known postnatally. Only the severe cases go to the doctor. But as we screen all fetuses, so sometimes we see in fetal life things that are not even checked in postnatal life, and the lack of HPO terms for fetal findings. So these are the main challenges that we are going to discuss. So let's start. These are the reasons that we propose that exome sequencing would be used as first tier in the analysis of CNS anomalies, especially of major CNS anomalies, because our capability to predict prognosis is quite limited. And we're going to start digging into these topics, speaking that what is common and you should remember. So Ritsuko just presented Down syndrome and showed how complex it could be, but Down syndrome is common. So instead of thinking, okay, first maybe this is a lissencephaly, probably it would be Down syndrome first. But what is common not always presents itself as expected. So this is a 30-week fetus male with hypospadias. Okay, and then we see either in ultrasound and in MR that the sulcation is quite impaired. There is, although the morphology of the cerebellum is normal, but there is cerebellar hypoplasia, there is a genesis of the corpus callosum and a severe malformation of cortical development. Checking in OBIM, which is the first place that we check about the possible phenotypes. So it really could fit ARX lissencephaly, which is LIS2, in male, X-linked related facial dysmorphism, and many factors that can relate to this topic. But it is actually a trisomy 18. So this is not a classic presentation of the trisomy 18 with severe IUGR and Dandy-Walker-like cerebellar hypoplasia and other very, very severe features. But trisomy 18, and this is not a mosaic, but can present not classically. And what is common will be always common. That's why we still need to do CMA together with exome sequencing, although exome sequencing will cover like 95% of cases. So this is one important take-home message. Another aspect, so understanding the mechanism of disease, as we have shown before, would be the key for the diagnosis, but also the reason for the overlapping phenotype. So let's see some cases. And I'm going to start with a chapter that will be discussed later on about macrocephaly, and we are going to speak, Gustavo is going to address this very interesting topic, and we are just going to publish an interesting paper on this topic, but this is a fetal mesencephaly and brain overfolding independently of the gestational age. This pattern that you guys see is abnormal. But what is the histological translation? Would it be polymicrogyria? Would it be polygyria? Would it be aberrant deep convoluted sulci? Of course that it depends on the gestational age, and we need to understand that polymicrogyria is sometimes hard to differ from polygyria because it would be on a microscopic basis. The cortex will look very thick also in polymicrogyria using imaging, but in the microscope is very thin, and in other conditions it would be very, very thick. But what we already know, that the irregular ventricular walls and this very aberrant pattern of sulcation, this is abnormal independent of the gestational age. Okay, in the prenatal life we have limitation in access of cortical thickness, lack of myelin, it's very important, and we have low resolution. So let's see some cases. Here we have 3 cases with abnormal overfolding of the brain, and I will tell you that this is a 15 weeks, 23 weeks, and 32 week fetus. Okay, in all cases, the pattern of the sulcation is quite aberrant, overdeveloped, overfolded, and abnormal. But in the first case, it is a thanatophoric dysplasia, which is a skeletal dysplasia. In the second case, we have a ciliopathy, which is a X-linked ciliopathy, Joubert 10. And in the third case, it's a macrocephaly syndrome with a variant in PIK3CA malformation, macrocephaly capillary malformation syndrome, which is an mTORopathy. So they are completely different diseases. How come they can present with similar phenotypic patterns? So let's go to the most common. So whenever I see a brain like this, I would first think, and if I have a macrocephaly, I will first think of brain overgrowth. Okay, and it would be my beginning, my start point. And if you understand the brain overgrowth syndromes, and especially around the mTOR pathway, we have different genes that are related to specific disease. And here we have our PIK gene related to the overgrowth and lack of apoptosis of these brains. We have what we call the PROS syndrome, which is the PIK3CA overgrowth syndrome, that we have different presentations depending on the variants. And the overgrowth will occur also in the muscle, in the adipose tissue, in the nerve, in the skeletal tissue, and also in the vascular basis, and also in the skin. So many of them are known as neurocutaneous syndrome, because they will affect also the brain and also the CNS. Okay, and how come Joubert syndrome can be related to brain overgrowth? So, of course, that the diagnosis should be confirmed by the genetic analysis of these mutations. And we must remember that sometimes these mutations are located within the tissue and would not be catched into the amniocytes, into the fibroblasts. So we are not going to be able to diagnose them by amniocentesis. But how come a ciliopathy may be related to the overgrowth? And how come a skeletal dysplasia will be related to the overgrowth? And here in these 2 publications, we see the relation with the mTOR pathway to the FGR membrane receptor and also to the OFD gene in the development of the cilia. So the mTOR will regulate the autophage G and the apoptosis at the level of the cilia, and the FGR genes here are going to be a membrane receptor that are going to regulate the activity of the mTOR, and that's why in different mutations we can have overlapping of these phenotypes, and this is an important thing to be remembered. Okay, but how can we deal with overlapping phenotypic presentations? So we need to find for associated findings that would be more classic of this or that disease. We need to follow up this fetus during pregnancy. And of course, that exome sequencing, whenever available, will help us. Okay, and this is my word for the people that live in countries that don't have WES available as we do. We see you. We know your struggle, and that's why we are discussing these topics today. So in this case of a thanatophoric dysplasia, of course, that we are going to see signs of a lethal skeletal dysplasia with severe shortening of the limbs and with severe implication of the thorax and the facial frontal bossing and the other abnormalities. Some other mutations of the FGFR3 are milder than the variant of the thanatophoric dysplasia Joe, but this is a very important reason for checking on the associations when we are suggesting genetic investigation. This is the 23-week case is the case for the OFD1 gene, so the ciliopathy. Whenever we checked on the legs, we saw a polydactyly of the first toe and heptadactyly of the hands. And this is not the classic post-axial polydactyly of Joubert syndrome. But whenever we check on the cerebellum and the midbrain, so we are going to see molar tooth sign and the classic features of Joubert syndrome. So this is the reason that they appear together, and they should not be overseen. So the presence of the molar tooth sign here is a game changer in the differential diagnosis. And the last case, it's 32-week fetus with +3 standard deviation of head circumference, a lot of fluid around the fetal head, facial dysmorphism, hypertelorism. It has an overlap with Noonan syndromes and other syndromes that also present with severe macrocephaly, with a lot of fluid around the brain, but they should relate more to the real brain overgrowth, which is the enteropathy. So another group that we are going to discuss, delayed sulcation equals disencephaly, and Roy has discussed about it. So not every sparkling wine is a champagne. And although the postnatal literature really classifies, this is good, is clear. We have very specific phenotypic patterns of imaging. We can speak about gradient and severity of the migration in different gene-related lysencephalies. And for the postnatal neuroradiologists, it is quite clear-cut in many cases. Not that there are not challenges, but they really clarify nicely. What happens in fetal life? We just can't. Okay, here I show you LIS1, Relin, Ankyrin B1, ARX, and DCX, and here compared to what is expected from coronavirus. And here we have a challenge because our phenotypes are not very characteristic. Maybe here in the DCX we can I just spotted the subcortical banded teratopia, which is super rare to be depicted also in MRI. But whenever we do so, we can suspect on double cortine. But we will probably think it's an artifact before we even believe that it's really a subcortical banded teratopia. So during fetal life, these translations in lysencephalies cannot be performed into a very deep genotyping thing as they are in the postnatal life. And this is something that we really need to remember and to understand. Roy has spoken about the tubulinopathies and the tubulinopathies pattern, so I will allow myself to jump over to the next topic. But the tubulinopathies are also part of the delayed sulcation, so not all the classic lysencephalies, and there are many other abnormalities. But the tubulinopathies, although there is overlapping diagnosis, on one hand, we have a lot of very specific patterns that we can use them to suspect. So if we see the asymmetry of the brain, asymmetric anterior horns with a square shape anterior horns, and you only have panel at your place, try the tubulinopathies, because the chances that you are going to find the answer are very high. So the phenotypic correlation with the tubulinopathies is high, although you must remember, as Roy showed, that there is a possibility of lack of concordation, and we need to remember that. Another topic which is important: what you see is what you get. Okay, so many times is of corpus callosum, but what is the mechanism that led into callosal genesis? So insults may mimic developmental disorders, and we must remember. And this is our case of the agenesis of corpus callosum. And again, many overlapping features with Aicardi syndrome. And here I like to stress the topic of corpus callosum callosal abnormalities, they are the tip of the iceberg, not less than ventriculomegaly. Okay, and if you have the possibility to check with Wes all cases of corpus callosum, even when the corpus callosum is complete, but it's a little short, a little thin, there is a contribution of exome sequencing. So there is this quote that says that no acts of kindness will remain unpunished. So even when we think, okay, this is a corpus that we can pass under the radar, there is a significant chance that exome sequencing will find a reason for the abnormalities of the corpus callosum. So remember that, especially when speaking about ACC. Aicardi syndrome, it's a problem because I could say and I could sell to you that the previous case was Aicardi. Why? Because Aicardi has no gene. Okay, so we have here are the comparisons with the features, dysgenesis of corpus callosum or agenesis, cortical malformation, interhemispheric cyst, distortion of the interhemispheric fissure, and facial dysmorphic features, that they do overlap. And because I cannot say for sure that it is not Aicardi, because I cannot rule out Aicardi gene, so it poses a problem. But it's the reason to do so, even when we suspect on that, is because we have overlapping, and this is a COL4A1 syndrome. So what are the variants in the COL4A gene? They are very important because they are one of the main genetic reasons of intracranial hemorrhage and intracranial damage. So whenever you see intracranial hemorrhage, remember the possibility, and again, if you have only panel, check the COL4 genes, because they may be a reason of dominant, inherited, with variant penetrance disease within the family. So sometimes you have 10 people, some of them, they bleed throughout the whole life. So knowing it's important, even if you have family that do not have clinical features, and this is the work of our amazing Moran Kedem, showing the fetal presentations of the COL4 during pregnancy. This is another case. So in COL, whenever we have full agreement, because whenever we see brain damage, we know that it can always be related to the COL4A gene on one hand. But if the damage, because COL4 will make a change in the microvascular structure. So sometimes the insult is so early in pregnancy that it will affect development. And you are not going to see macroscopic bleeding, you are going to see lack of brain structures. And in this case, it has affected migration, and it has affected development of the corpus callosum as well. Another chapter, which is important, we only see what we know. So unknown fetal presentations of syndromes that are known postnatally can be spotted by us in screening. And this is 21-week fetus. She has a previous termination for agenesis of corpus callosum. And here, even in axial views, we already see the abnormal anterior complex and the abnormal Sylvian fissure, even for 21 weeks. Okay, in sagittal, we see a very small corpus callosum, a very thick massa intermedia, stigmata of agenesis of corpus callosum. And this is a male fetus with adducted thumb, and this is an L1 CAM variant. So although it really presents as a callosal syndrome, we need to remember that L1 variants may be responsible for the dysgenesis or agenesis of corpus callosum spectrum. And this is another fetus, a female fetus, 30 weeks, with a ventriculomegaly, irregular ventricular walls, irregular interhemispheric fissure, and normal midbrain and hindbrain structures, and very dysgyric pattern. And this is also, this patient has 3 previous terminations of male fetus with the hydrocephalus, and this is another L1 CAM variant, both inherited from the mothers. So we have the classic phenotypes of entities, and here especially remembering the X-linked entity So they sometimes may present in female fetuses within a spectrum. Normally, the female patients will have a milder phenotype, but they can present clinical implication of the abnormalities. And this is very, very important to be remembered by us. And why does this occur? So we have the correlation of the axonal guidance, so the molecules that will explain the migration of the axons may be overlapping with other cytoskeletal molecules. And you already have heard about cytoskeleton today by Roy. So I'm going to show you this case, 34 weeks, female. And you see here the irregular interhemispheric fissure, like the previous case of the female with the L1 syndrome, mild ventriculomegaly, this gyrate pattern of sulcation, mild impairment of the corpus callosum. So corpus callosum is thin and short, and the brainstem is kept. And this is a case of tubulinopathy. This is a mild tubulinopathy, TAB-B3. Most of the individuals are completely normal, clinically speaking. So knowing the axonal guidance processes will help us to understand why L1 syndrome and tubulinopathies may have overlapped features, because they are these variants are related into the axonal guidance and the axonal development, and the overlapping of these processes will lead to overlapping phenotypical morphological features. Time is gold. So shared phenotypes, many times they have in common the timing when the genetic impairment affected the brain at first. Okay, so do you remember in the first trimester that the brainstem is Z-shaped, and in the end of the first trimester, as magic, this brainstem need to straighten up. The aqueduct, which is huge in the first trimester, will be thin. The cerebellum will undergo very, very rapid growth, and we need to see the disappearance of this kinking of the brainstem. And what happens when it does not happen? Okay, so the most classic disease that we remember whenever we see a Z-shaped brainstem is Walker-Warburg syndrome, which is part of dystroglycanopathies, a severe brain abnormality that lead to cobblestone malformation, but affects the whole brain. And we have a very hypoplastic brainstem, but it has it's a spectrum of severity of these hypoplasia and brainstem Z shape. But other abnormalities, Möbius syndrome, that can be acquired with a severe insult in the first trimester, or genetic, and here you see the Z shape, very hypoplastic. It shares many features with Walker-Warburg, because also the supratentorium is super thin, and there is hydrocephalus as well. L1 syndrome with aqueductal stenosis. So all this severe impairment of the brainstem will lead to malformation of the midbrain, closing the aqueduct and dilating the supratentorium. And the tuba A1A as well. So these diseases, they affect the brain so early in such basic abnormality, such basic developmental processes, that they lead to abnormalities that appear the same morphologically speaking. Whenever we understand that, we are going to be able to suspect on the differential diagnosis. And I'm going to end with the Dr. Seuss quote, which is better to know how to learn than to know, because I'm probably leaving you with more questions than answers in this lecture. But I hope you have taken some take-home message on how to deal in the workup of your next CNS cases. Thank you very much, and we are now going to open for discussion. Hello, everyone. And we are now open for discussion. I'm here with Ritsuko, and we are going to answer a couple of questions from the audience and discuss some important topics. So I would like to start with Cindy Su. I'm sorry if I'm not spelling your name well. To Ritsuko. So are the variants from the PIK, AKT, mTOR having full penetration? And is it possible to be inherited from asymptomatic parents? So Ritsuko, if you can speak a little bit about the mTORopathies, how we can check on them, and about the penetrance issue.
Okay. Actually, the first, the PI3K, AKT mTOR pathway, it is a very, very complex pathway. And sometimes, that we have the megalencephaly, or, the hemimegalencephaly, or some kind of the big head with the asymmetrical structure. The Roy's presentation. And we have the suspicion of the mTOR abnormality. However, the mTOR, the AKT or PIK3CA, they have the somatic mutation, and somatic mutation is completely different. The somatic mutation after the fertilization of the sperm and egg, and suddenly, the mutation, the variant occurs, the inside of the baby's, especially, the brain. And in that case, that there's no genetic variants in sperm and egg. And so I think, in that case, that is a de novo. And also, sometimes, that we have I have the case with the AKT3 variant, that is not the somatic mutation. That is that is the de novo. However, that there is maybe, something occurs in the sperm or egg, therefore, the parents, that we have the parental examination, but, that there's nothing, the negative result, and only the baby has the AKT3 gene variant. However, that is from the amniocentesis, the somatic mutation usually, only from the brain, or the very low mosaicism in the amniotic cells. However, it is not the somatic mutation, that is from the variant from the sperm or egg. Maybe, we do the amniocentesis, and the result of the fully, not the mosaicism, that is the variant, the completely, in the amniotic cells. So maybe, that we need to know such kind of things, Therefore, do you add something, Nina?
Something that is very important what you explain, because people not always understand how come we cannot catch these variants, and how we can have different amount of abnormalities in different tissues. So this explanation is important. And we have the feeling that, I don't want to make panic, but this is our experience, that the rate of these cases is higher in IVF processes and in micromanipulation processes. And here in Israel, we have a lot of IVF cycles, and we are starting to see a significant number of cases, especially when we have ICSI and other types of manipulation. So I'm very aware with my statement right now, but I think there is a chance that the artificial reproduction techniques may raise, by some mechanism that we still don't really understand, the chances that these abnormalities occur, especially regarding the overgrowth syndromes. We are seeing many of our cases have underwent assisted reproduction technique.
Oh, really? That is the big issue, in the IVF society, right? So, however, sometimes, that we think about, the artificial technology. I'm not quite sure, the mechanism, because, the IVF patients, the patient with ART, they initially they have the risk, right? So maybe that is one of the reasons, usually IVF people are insistent that if we say that the incidence is higher in the IVF group or ICSI group, maybe they said that originally the patient have the risk, the potential of the risks. So I'm not quite sure, no evidence, yet, about the relationship between the ART technology and the and also, the two of my patients, that they have the spontaneous pregnancy. So I'm not quite sure, but maybe you feel that maybe from the Israeli there are many IVF programs, right?
Yes.
So yeah,
Yes.
therefore I'm not quite sure the ratio of the spontaneous pregnancy and IVF, the ART pregnancy, the ratio is 50 is 50. 50 is more, the spontaneous is more in Israel.
In our case, no, we have a series, and Gustavo, in the end of the day, Gustavo is going to address that. And we have more cases with ART than spontaneous pregnancy with syndromic macrocephaly, most of them with an enteropathy. Still, the numbers are small, so I don't want to make panic, but I think if we are on a scientific meeting, so there are some spots to think about them. And also, this population, normally they have other embryos frozen. So one of the main reasons that I wanted to discuss with you this topic, Ritsuko, is that why is it important for us to diagnose? This for two main reasons. First, to manage the pregnancy well, and second, to assess the risk of recurrence in a further pregnancy. So, because even when we see a severe malformation, the family opts for termination wherever possible at 20 weeks. For this pregnancy, it's terminated, but what happens next? What are the chances that these abnormalities, they recur? So that's why ultraphenotyping is very important, and trying to get the answer. So how do you do in Japan? Whenever you have a referral for an abnormality, how do you check these patients? Do you recall them after? Can you speak about your experience, how you counsel them to the next pregnancy?
I actually know that if they have the genetic origin already, it is not so difficult. But they have the previous pregnancy, they have the anomalous baby, and then that they are worrying about the next. What is next? And then I usually the please show me the picture of the previous baby, and they usually they have the picture of the aborted or the dead baby or something, and also in Japan, very very special country, and because everyone, even there is a termination of the pregnancy or the live birth, they preserve the some part of the umbilical cord, in the special box, And actually, I have 3 kids, and I have all of the umbilical cord. And then I asked them to bring that to us, and then extract the DNA and test that. And some of the cases, so far we found the causal gene. And then the next pregnancy, we do the Sanger sequencing, and then we can solve the pregnancy, the problem.
This is an amazing thing, because indeed many times we don't have the DNA of the previous pregnancy in order to check and to compare. And sometimes the phenotype is so close. So and how is this cord stored? The patient keeps the cord. How is it stored?
Yeah, the patient, the parents, usually mother, keeps that, in the drawer or somewhere, and that is just, in the wooden box. And so, that is the very dry, and that is not that is a very dry, and the color is almost black or brown. However, we successfully extracted DNA for, I don't remember the case number, but the around 5 or 6.
Amazing.
Yeah. So maybe I will comply with those, and then the report that to somewhere. But anyway, that is one of the solution. Yeah.
Yes, no, but sometimes it's a very cheap solution, especially for places that they have no other means of having that. But I think it could be also an interesting idea for places, so they do not require specific storage, laboratories, or freezing, anything. And whenever it happens in previous pregnancies, it's a very nice tip, I think, from places that cannot obtain DNA in another fashion, because we constantly struggle with the recurrence.
Yeah, right. There's always. So because especially we didn't know the previous course, of the pregnancy, and there's no picture, no ultrasound images or nothing, right? So we just hear the story, and just the looking at the picture, and then we cannot tell what is going on, and so therefore. And also, I think, the many of the audience thought that, our talks, they would show many genetic variants could be identified by looking at the phenotype, right? So maybe, however, the behind those cases, that there are many, many cases with the negative result of the exome sequencing, right? So of course, you have Roy has, and I have a lot of cases, if we have the strong suspicion of the specific genetic variant, and most probably, this is some kind of the lissencephaly or taurinopathy or something, and but that we have the negative result, and that is the very, very frustrating and irritating, right? So in that case, maybe that we have to counsel the patient with only the evidence of the image, right? So I think I try to hear from you that your management or counseling to the patient with the only evidence of the imaging phenotyping.
Yeah, so we are finishing also this data to publish. We tried also to classify it into like which types of malformation they have higher chances to get a positive exome sequencing result, and what are the types that have less. because then we already know also how to tell the patients. But I think the highest percentage will be in the best scenario 60%, not more than that. And so in most cases, at least half of the cases won't have a response, and this is very frustrating also for us, but especially for the family, because they are very stressed, they are very worried what happens next. And this is also an opportunity to say, so in our hospital, like we have the follow-up clinic. So whenever a patient terminates, then we do the DNA assessment. Whenever they agree, they send for a pathology. Then we have the post-mortem examination. Sometimes we have a negative exome. Then the post-mortem assessment shows, oh, okay, but there is also a dysplastic kidney and something, a syndactyly in the foot or something like that, that we couldn't see. Then we go back to checking again, and sometimes then these new HPO terms help the bioinformatic to find the gene. And then whenever we don't have the answer, we invite the patient for the next pregnancy to early scans. So we begin very early in pregnancy, and then we have dedicated scans in order to, if we catch something that resembles a recurrence, then we can have early investigation, either CVS or amniocentesis. And whenever we have the DNA from the previous, then we do quattro. So we check also the previous patient in order to try to find. So Roy showed the case of the KIF 14, and so the patient had a first termination with callosal abnormalities and MCD, and it was normal. Then only in the next pregnancy, they checked, and then they found, also we didn't speak about the VUSes, but the variants of unknown significant, that they are many times not reported. Whenever you have a recurrence, then sometimes they are upgraded, and then they do report. So multidisciplinary work is very important. The ping pong with the geneticist, with the pathologist, with the radiologist, and with us all together all the time, doing this Sherlock Holmes investigation, trying to solve these questions, because these families, they are very stressed and it's hard for them.
Yeah, I completely agree with you. And actually, these discrepancies between the phenotypes and genetic variations are very, very, we often experience, but, the one by one, one evidence by one evidence, that we can correct. And actually, you said that, ping pong, between the geneticist and the clinician, that it is quite important things, that is one of the pitfalls of the genetic era. Sometimes, that we are waiting for, many of the doctors are waiting for the results of the exome sequencing. But, sometimes, you are talking about the HPO, and sometimes, that they didn't talk about, the phenomenon, the phenotypes, or, that they misunderstood the phenotypes. Maybe, the filtering of the WES, the filtered everything, and then the answer is negative. Sometimes, it happens. And also, there is the VUS you said, and 1 point up, it is going to the likely pathogenic, but without 1 point, that is one of the there are many pitfalls, in the very upgraded the exome sequencing. Yeah.
and I'm going to end our session only also to speak about the medical legal question. I don't know if you have a lot of SU in Japan, but like sometimes the lawyers say, okay, but here the phenotype is very clear for this lissencephaly, whatever, and the literature knows how to diagnose. How come you didn't diagnose this entity in pregnancy? So also understanding what we have discussed has also medical legal aspect, because whenever we need to defend ourselves on how come we didn't catch this disease, is because the fetal presentation is far away from what is known from the postnatal literature, and it's also important that we should be aware of that, because sometimes the nasty lawyers, they use it against us, and this is not good.
Yeah, actually, the medical standard, that is updating, the every week, every year, so I think, it is the quite difficult, if we are talking about those things, the very upgrade lecture, but I think, we need to discuss about, medical legal more about, if we have time. Thank you.
Okay, thank you, Ritsuko, and we will proceed then into our next session. Tatiana, let me know if I can announce already our next lectures, please, or we have a couple of minutes. Hello there, and thank you for being with us until now, and I hope you have survived the genetic session. Now we're going to speak about a lighter topic, but not less important, because it's another tip of the iceberg, and we're going to discuss ventriculomegaly in depth. And I'm very happy to present my dear friend Elisenda Ishar from Barcelona, from the team of VC Barcelona, and she's going to present the workup on cases of ventriculomegaly. As you well know, diagnosis ventriculomegaly is not enough anymore, but we need to refer the patients, and we need to go some steps further. Please, Elisenda.
In the next 30 minutes, I will be talking about the workup on fetal ventriculomegaly. But let's start from the beginning. Ventriculomegaly is the most common fetal central nervous system anomaly that we are going to identify during fetal life. Indeed, it is the most sensitive marker of brain anomalies, but it has a low specificity since it's a common sign of different brain anomalies. We have to bear in mind that more than half of cases will be not isolated. Therefore, it's essential to identify the cause in order to establish the prognosis. In order to unravel which is the cause behind the fetal ventriculomegaly and to classify between isolated and non-isolated, we need to perform a systematic approach, including neurosonography, anatomical ultrasound, infection evaluation, genetics investigation, and fetal MRI. The first and most important step is the multiplanar neurosonography to perform a dedicated evaluation of the fetal brain. Transvaginal approach is essential, and despite we can obtain the 3 orthogonal planes transabdominally, the image quality is poorer, and this will especially hamper the evaluation of parenchyma and cortex. Neurosonography will provide information about the size of the ventricles, then we can classify ventriculomegaly as mild, moderate, or severe. Also, evaluation of the laterality. We can see if the dilation is uni or bilateral. Also, the presence of dilation in other ventricular regions apart the occipital horn. And finally, some specific ultrasound characteristics that have some pathological conditions. Combining this information, we will have a possible diagnosis. Let's see how these characteristics of the ultrasound can be evaluated in a systematic manner. Let's start with a simple measurement, the head circumference. If we identify a head circumference below 3 standard deviations, we are in front of a microcephaly that is one of the causes that can be associated with ventriculomegaly, and we have to investigate if this is a primary or acquired microcephaly. We will follow with the evaluation of the posterior fossa. We will see here a case of ventriculomegaly. You can see here mild ventriculomegaly that is associated with this banana sign with obliteration of posterior fossa. Is a case of open neural tube defect. So when we identify a ventriculomegaly, we have to evaluate posterior fossa in order to discard the presence of open neural tube defect. We will follow with evaluation of the anterior complex. In this video, we will see mild ventriculomegaly with an absent cavum sepsi pellucidi, a teardrop-shaped lateral ventricles that also show these parallel anterior horns. These are high suspicious of complete agenesis of corpus callosum, and we can also confirm this with the coronal planes with these beaking helmet-shaped anterior horns. But even when this cavum septum pellucidi is present, can give us information. You can see here we have a present cavum septum pellucidi that has an abnormal shape with anterior horns that are also parallel, but especially the most interesting information here is this abnormal shape of the cavum septum pellucidi, that is a white cavum that is corresponding to a degenesis of corpus callosum that we can clearly see in this sagittal plane. We will move to the periventricular area. Why is it important to evaluate periventricular area? Because it can give us information about several conditions that are related with ventriculomegaly. For example, this periventricular halus that can affect that occipital, anterior, and temporal horns. That is a periventricular halus that is high suggestive of cytomegalovirus infection. Periventricular area can provide also information about the existence of periventricular cyst. As we can see here in this video, we can see subependymal cyst affecting both sides with thick and hyperechogenic walls that we can also see here in the sagittal plane that extends further than the caudothalamic growth. These are very suspicious cysts. If we further evaluate this fetus, it has a hypoplastic Burmese together with enlarged kidneys, with no difference between the cortex and the medulla, that is also associated with oligoaniravios, and in this case it was a metabolic disease that was diagnosed through the identification of fetal ventriculomegaly. Still evaluating periventricular area, the shape of the anterior horns can provide also interesting information. Here in the coronal plane, we can see square-shaped anterior horns together with irregular walls along the whole ventricle. It's easy to identify through the coronal plane. You can see the irregularities that we can identify in the wall. We can also identify these irregularities in the sagittal plane. And in this case, it was associated with a megacisterna magna and is a case of high suspicion of filamin A mutation. Still in the periventricular area, we can identify signs of intraventricular hemorrhage. In this case, we have the suspicion in the axial plane, in which we can see this heterogeneous mass that is starting here from the supraependymal region. And when we go through the sagittal plane, we can identify this heterogeneous mass that rolls into the lateral ventricle, and we can see this hyperintensity in the posterior part of the ventricle. So this is a suspicion or image of a grade 2 intraventricular hemorrhage. Still talking about hemorrhage, but in this case we have a grade 3 hemorrhage that has a severe dilation, but still we can identify the supraependymal and heterogeneous mass that gets into the lateral ventricle. You can see here the blood very well, and that comes from this heterogeneous mass. But again, it's not this dilation and the blood inside the lateral ventricle. We also have here an associated porencephalic lesion that is secondary to a venous infarction. We can see also the blood inside the lateral ventricle here in the sagittal plane, and also in the axial plane. So these three signs are signs of a grade 3 of intraventricular hemorrhage. We will move to the evaluation of the supraagnoid space. In this video, we can see a huge increase of the supraagnoid space due to the presence of brain atrophy. We can see in the coronal or in the sagittal plane. This can be related to some acquired or to some conditions, such as metabolic conditions that evolves as a brain atrophy. We will move to the evaluation of the midbrain structures and some of the conditions that can be associated with ventriculomegaly have different signs that we can see at this level. First, we have this diencephalic mesencephalic junction dysplasia type A that has two main signs in the axial plane. That is the enlarged midbrain, as we can see here with the asterisks, and also this ventral cleft that is clearly identified with this arrowhead. In the sagittal plane, we can not clearly identify the difference between the thalami and the midbrain, and this is a case of the encephalic mesencephalic junction dysplasia type A that we have to suspect when we are in front of fetal ventriculomegaly. And we also have the type B, in which the axial plane do not have clear signs. We can see this moderate ventriculomegaly, but with marked dilation of the anterior horns. And it's not easy to identify the anomaly in the midbrain structures in the axial plane. So it's very important to go to the sagittal plane, in which we will identify the incomplete cleavage between the thalami and the midbrain. So this is a case of this diencephalic mesencephalic junction dysplasia type B that can be suspected with the presence of this ventriculomegaly and confirmed in the sagittal plane. We will follow with the evaluation of the parenchyma. This is a very big tumor and is a very clear case, but this is important to know that not all the tumors will be as big as this one. So here we have a heterogeneous mass that is producing this huge ventriculomegaly. So it's important to evaluate the parenchyma in order to find this type of lesions. And finally, we have the cortical development that is very important to assess. Here we have a case of 31 weeks of pregnancy in which we can see that the Sabian fissure and perioccipital fissure has a delay as expected with normality. We can see the same here, the cingulate sulci that is not present, and neither the calcarine fissure. So it's very important to evaluate the cortical development in the cases of fetal ventriculomegaly because it can be a sign of cortical malformation. So with all these characteristics, we will have this possible diagnosis, and this is the systematic of the characteristics that you have to evaluate. We will remember head circumference, posterior fossa, anterior complex, periventricular area, interventricular area, supraagnoid space, midbrain structures, parenchyma, and cortical development. Once we have this evaluation, we will follow with the complementary study to have the final diagnosis. Anatomical evaluation is important because 30% of ventriculomegalies will present extra brain malformations. 40% of cases will be congenital heart disease, and other malformations are present in kidney, extremities. But it's important to bear in mind that these external extracranial malformations will be more frequently present in severe cases, in 50% of severe cases versus 10% in the mild to moderate. Infection rate in ventriculomegaly occurs from 5 to 10%. Again, it's a higher rate in the most severe cases. And the most important thing is that we will have other ultrasound signs in the evolved case as we have seen previously. The conditions that are mostly associated to ventriculomegaly are cytomegalovirus, toxoplasma, and Zika in epidemiological risk cases, of course. So we can do serology to investigate the infection, and in case of there are ultrasound signs, or if GG is positive, then perform PCR in the amniotic fluid to investigate the presence of this infection. Regarding genetics, we have to consider that chromosomal abnormalities are present in 3 to 10%. And of course, again, if this percentage is higher, if there are associated malformations, if we compare those without associated malformation, they have like around 4% compared with around 12% in those with associated malformations. We have investigated the presence of abnormal array CGH in our population in more than 160 ventriculomegalies. We evaluate the rate of abnormal array that was around 8.4%. There were 5 aneuploidies and no dilations, duplications. The most important thing is that 50% of these cases were not detectable by karyotype. So it's very important to perform array CGH in these cases, because if not, we are not going to identify this anomalies. And an important information is that abnormal array has a different distribution according to the size of the ventricle. So the bigger the ventricle, the higher the ventricle, the higher the proportion of abnormal array. But the most interesting information is this one, that the presence of associated anomalies are associated with higher abnormal array, as previously described. So they end up with this information that is very useful for the clinical management. If we have isolated and mild ventriculomegaly, the proportion of abnormal array will be around 4%. If this mild ventriculomegaly is non-isolated, the proportion increase up to 12%. And finally, if it is non-isolated and the ventriculomegaly is moderate to severe, this proportion increased to up to 34%. So important information for the clinical management of our patients. And what about exome sequencing in ventriculomegaly? So I'm pretty sure that Ravi Chawi is going to talk about this in his presentation, but we'll take some minutes to talk about this. And there are some reports that showed an added value of exome sequencing, especially in severe ventriculomegaly, but not in mild to moderate. But recent meta-analysis has shown that maybe exome sequencing has some benefit in these isolated severe ventriculomegalies. As we can see here, there is a 35% incremental exome sequencing diagnostic yield in these cases of isolated, increasing up to 50% of incremental yield in non-isolated severe ventriculomegaly. So we maybe can discuss that further. About the use of magnetic resonance in ventriculomegaly, Gregor Kaspren is going to do a talk about that, but I will give very brief information that I think that is useful for the clinical management. The rate of additional findings after dedicated neurosonography, and this is important, after dedicated neurosonography is different depending on the type of ventriculomegaly. First, in the case of non-severe isolated ventriculomegaly, these additional findings are around 5%, as you can see here, and these are more frequent in moderate ventriculomegalies when compared with mild ventriculomegalies. However, if we focus on severe ventriculomegaly that has been classified as isolated after dedicated neurosonography, we will detect an increase of 18% of additional findings when we perform MRI. However, we have to bear in mind that even though we are doing neurosonography and MRI, there is a 4% of conditions that are only detected postnatally. And this is important also to explain to our patients that even though we have done all these examinations, there is a small proportion of cases that will show something in the development after birth. So here we have like the summary of what we have to do when we diagnose a fetal ventriculomegaly. The first is the neurosonography to assess all the characteristics that we have reviewed, anatomical ultrasound to explore the presence of extracranial malformations, the investigation of infection, first with serology and if positive, then performing an amniocentesis, offering genetic studies to all the patients, and performing array, and we can further discuss if exome sequencing is necessary or not. And finally, the performing MRI in selected cases. If we perform all these, we will be able to classify our ventriculomegaly as isolated or non-isolated. However, we have to bear in mind that even when we are classifying our ventriculomegaly as isolated, in a small proportion of cases, between 5 to 10%, we will be misclassifying as isolated, and some things will appear later in pregnancy or after birth, and will be a case of non-isolated that we are not able to identify as this. How we are going to do the follow-up of these patients. So the first important information is to know which is the progression of these cases. So as you can see here, in mild cases, the progression occurs only in 10% of cases, while in the moderate, this increases up to 30%. So this is important to know in order to adapt our follow-up, and also to explain to the patients which are the probabilities of this ventriculomegaly is going to progress or not. How we are going to follow up. So when we identify ventriculomegaly, the first evaluation is going to be performed after 2 weeks. If this ventriculomegaly is non-progressive, so we can be pretty sure about that this ventriculomegaly is not going to progress anymore, so we can follow this patient in 4 weeks. On the contrary, if this ventriculomegaly progresses, we will do the next control in 2 weeks to see if it's progressive or not. But it's very important to highlight that in these controls, apart to evaluate and measure the ventricular dilation, we should perform a dedicated examination and looking for associated anomalies that can appear late in pregnancy. And this is very important because there are some conditions that are not going to be identified, especially if the ventriculomegaly is identified at 20 weeks of pregnancy. So please pay attention, because ventriculomegaly, remember that this is the most sensitive sign that something is occurring in the brain. So please, even if you have classified this as isolated, please keep an eye on this patient and follow very carefully along the pregnancy. What about the prognosis? So in the cases of non-isolated ventriculomegaly, the prognosis depends on the associated condition, of course. So if you have a neural tube defect, an hemorrhage, myelomeningocele, so it will depend on that. In the cases of isolated ventriculomegaly, the prognosis will depend mainly on the size or in the progression. So if we can see here, if it's a severe or progressive ventriculomegaly, good prognosis will occur in less than 40% of cases. If it's moderate and stable, the prognosis will increase up to 80%. And in case of ventriculomegaly, mild and stable, prognosis will be up to 90% of cases. However, I will present some data about these cases because you will see that the literature is not very extensive. So here I present you the proportion of adverse outcome that have been evaluated in these cases of non-severe ventriculomegaly. And as you can see here, more or less the adverse outcome has been reported as around 8% of cases. However, most studies did not include genetics or the time that, so they are very heterogeneous. So we decided to perform a study to evaluate comprehensively the evaluation of these ventriculomegalies. We include 40 ventriculomegaly cases, isolated and non-severe, and 40 controls. We follow them up through all the pregnancy, performing neurosonography, magnetic resonance, and also postnatal evaluation with different neurodevelopmental tests. The first thing that we found was that ventriculomegaly, remember they are mild and non-progressive and isolated, they have differential cortical development with decreased sulcal depth in sylvian, calcarine, and parieto-occipital, and also decreased proportion of development as expressed with decreased grading following Pistorius score. It also was confirmed when we performed magnetic resonance with decrease in specific sulci and fissures depth, and also with a global decrease in the grading of left-right hemisphere in the total cortex. And also we found an increase in the cortical volume, confirming previous reports, and also that this increase in cortical volume was not an homogeneous increase, that was specifically increased in the cingulate frontal and parietal cortex. When we evaluated the neurodevelopment of these babies after birth, we first performed the Vineland-3, that is a standard neurodevelopmental test that is performed in neurology. And we found that the mean values of ventriculomegaly group did not reach the normality, that is 100 in this score. And in some areas, fetal ventriculomegaly cases were close to the 1 standard deviation. So we confirm our suspicion that these babies with fetal ventriculomegaly, even when isolated and non-severe and non-progressive, have some effects in its development. We confirm also this compared with our cohort of controls using the Bailey 3 test at 18 months of age. And as we can see here, in almost all the scales, isolated non-severe ventriculomegaly scored less than controls, and this reached significance in the language and adaptive behavior that were significantly different between the both cohorts, the controls and isolated non-severe ventriculomegaly, and especially in the adaptive behavior was below 1 standard deviation. We can summarize that if we compare those children with poor performance in more than one area, this occurs in 40% of isolated non-severe ventriculomegaly cases compared to 12% of controls. After these results, we wonder if we will be able to associate some prenatal factors with this poor performance in the neurodevelopmental outcome after birth. And we evaluate first clinical parameters such as ventricular width, and was not associated to this poorer performance, neither the laterality or evolution of this dilation. But when we evaluate the added value of including these cortical parameters, we saw that these parameters were associated with this poorer performance. So it could be that this maybe can help us in identifying those cases of ventriculomegaly that will have poorer performance and that can be treated with early intervention after birth. To conclude, I would say that once we have diagnosed fetal ventriculomegaly, the essential thing is to identify the cause, because identifying the cause, we will be able to establish the prognosis. For identifying this cause, the first step will be to perform this dedicated multiplanar neurosonography that ideally will be done transvaginally in order to identify these ultrasound signs of the different conditions that can be associated with ventriculomegaly. As a second step, the complementary study and follow-up will improve the diagnosis of these conditions, so it's essential to perform in all cases. And finally, once we have discarded all the associated conditions and we have classified our cases as isolated and non-severe, we will be pretty sure that most of them will have a good prognosis. Thank you very much for your attention.
Thank you, Elisenda, for this very comprehensive, brilliant talk. And I will be happy to present another friend, Gregor Kasprian, professor from University of Vienna, and he's going to enlighten us on the contributions of the MR. Of course, it is important for us to remember that this work together with the radiologist is very important. The contribution of the MR will be higher the poorer our neurosonographic capabilities. And I'm sure that Gregor is going to show to us all the options, also from the mild to the very, very expert contributions of the MR whenever working up with a case of fetal ventriculomegaly. Thank you very much, Gregor.
Hello, it is a great pleasure again to see you at this course, and I think this is an excellent opportunity to bring people together also from other disciplines. I am myself a radiologist working on fetal MRI, and I would like to add the fetal MR perspective to fetal neurosonography today. my task is to talk a little bit about ventriculomegaly and fetal MRI in ventriculomegaly, and that's what I'm going to do in the next 30 minutes. That's the place where I'm currently working. It's the Medical University of Vienna, in the beautiful city of Vienna. Now, when we're talking about ventriculomegaly, I would like to approach the topic a little bit through a philosophical perspective. What we are doing in prenatal medicine is we're trying to detect abnormalities. These abnormalities do not necessarily mean to be disorders. So we have to be aware about the definition, what is a disorder or a disease. And philosophers have thought about it a lot. And if you look at the current ongoing debates on diseases and their definitions, you see that these are the terms used to define a disease. Undesirability, suffering, harm, treatability, and being beyond the control and or responsibility of the affected person. That is certainly for sure in this condition of ventriculomegaly in the fetus. However, many of these definitions do not apply for what we are seeing in prenatal medicine. We do not know if the condition of ventriculomegaly is undesirable for the fetus or human being to be. So we have to be aware that we're talking about findings, and what we want to do is more to think about, is this really a disease or disorder? And I think fetal MR can help in this transition between findings and defining a disease or disorder. You all know the anatomical drawings of Leonardo da Vinci. He was already aware of the fact how ventricles are looking like there. He was filling up ventricles with wax and visualizing them three-dimensionally. What I would like to do here is talk a little bit first about the normal development, because the normal development of ventricles is still, I think, a very important topic, and I would like to make some very essential points here, and then talk about ventriculomegaly, of course, and MR phenotyping. Now, when you're talking about the ventricles, you can actually not only talk about ventricles in isolation. It's not a good idea. You always have to include the whole system, and the whole system includes the external CSF spaces. And therefore, I would like to include that. Again, this is one of the main, let's say, teaching points of this talk today. Thinking back in history, the great physician Galen was already thinking about how CSF is circulating in and around the brain. He was already having the idea that it was formed inside the ventricles, and it was kind of flowing then to the outside. What he actually assumed was that there is a basically exchange of CSF at the frontal base of the brain and here in the pituitary area. This is not quite correct, but as you can see, the concept changed over the centuries. This was a more modern concept where we believe that the choroid plexus is producing CSF, and it's basically producing quite a bit of 170 milliliters a day, even in the fetus. And this amount of CSF is then produced, flowing into the fourth ventricle, leaving the fourth ventricle here, circulating also down to the C-spine. Never forget that we also have CSF spaces around the cord as well. And then it's basically, in the end, resorbed, and that was the so far modern concept, by arachnoid granulations. And this, we can say, is most likely wrong, as we know by very, very current papers. We know that we have even a more complex system, as we have believed so far. One factor was coming in the past years, and this is the so-called glymphatic system. The glymphatic system is a lymph system of the brain. You can regard it as that. These are small spaces around tiny vessels within the brain, and these spaces are basically taking away all the trash which is accumulated in the brain, bringing it to the CSF, and sometimes also directly to vessels in the subarachnoid space. So the perivascular space is a very important site of CSF, physiology. And another point is this, which I would like to bring you to your attention. These are the bridging veins. These are veins which are sitting in the subarachnoid space around the brain, and they are leading to the sinus and to the large venous vessels of the brain. And those bridging veins, they have something called the arachnoid cuff exit points, and these are basically sites at the side of the vein where CSF can actively be resorbed. And this is a very big change to the concept of arachnoids granulations. It just shows that the perivascular spaces, including the bridging veins, have an important function in CSF reabsorption, and that is probably also true for the fetus, however, we do not know a lot about that currently. So, this is the important point here. Never look at the ventricles in isolation. Take into account the entire system, which includes the inner CSF spaces, which are the ventricles, but also the outer CSF spaces. Never assess one without the other. This is basically how the system is looking on MRI. You see these large or outer CSF spaces and the inner CSF spaces. Now, with MRI, you can do, as you know, a lot of research. You can segment the brain, and you can also segment the outer CSF spaces. You can look at their development and also visualize the CSF spaces in 3D, in 3 dimensions. This is a visualization of the ventricles by MRI of a fetus at 26 weeks in 3D. And what you can see is the lateral ventricles. They are connected here through the foramen of Monroy to the third ventricle. Third ventricle is connected to the fourth ventricle through the aqueduct. And the fourth ventricle basically has some openings where the CSF is basically circulating out. This is the normal morphology of a fetal ventricular system. Be aware that this morphology changes over time. There are components where we have spatial changes. You see that a lot is going on in the posterior or occipital horns of the lateral ventricles here. They are basically decreasing in size. And also, if you look at the temporal component, you can see where some parts are expanding or also decreasing. So ventricles are indeed a dynamic system. You have to be aware of that, even if the measurements are quite constant over pregnancy. The form and shape of the ventricles are slightly changing through our observational period, particularly in the second and third trimester, but also, of course, in the first trimester. So this is just to make a point, a comparison between a normal fetal brain and the Chiari-2 post-surgery brain. Even if you do intrauterine surgery in a Chiari-2 malformation, you will realize that the enlargement of the ventricles, which often is seen in this condition, remains in this original shape. So you're not really changing that through the surgery. So the shape of the ventricles also give us a lot of information. And here is the lateral view, and you can realize how these ventricles are really different from a normal age-matched brain. Now, let's go to the external CSF spaces, because they are really important also, because we have been focusing a lot onto the ventricles, but not looking a lot on the external CSF spaces. Over pregnancy, they are growing in size. That's natural, that's understandable and expectable, because the brain and the head are growing. However, what we have to be aware is that in relation to the brain, the overall surrounding CSF spaces are indeed decreasing in size. While the brain is growing, the outer CSF spaces are decreasing in size. So if you look at a ratio between external CSF spaces and brain volume, you can see that this ratio goes down because the external CSF spaces are getting smaller and brain volume is increasing. And that's exactly what you're seeing also in individual fetal MRIs. You see that initially at 16 gestational weeks, you have wide ventricles, rather fewer brain tissue, quite large outer CSF spaces. They are basically showing their largest dimensions at around 26 weeks, as you can see here, and then they are decreasing in size until birth. So this is a system which is basically in communication, internal and external CSF spaces. So always when you do an assessment, and if you want to do neurosonography and you don't want only to use your prenatal imaging technology to detect ventriculomegaly, for instance, by measuring ventricular sizes, but also to understand the underlying condition, you have to take the whole system into account. Also look always at the third ventricle. That's what you're already knowing. The third ventricle is slit-like between the thalami, and of course enlargements of the third ventricle are always suspicious of some process, particularly process going on at the level of the tectum and of the aqueductus mesencephaly. On MRI, we recommend to measure the width of the lateral ventricles on coronal planes. They relate a little closer to the ultrasonographic measurements, but be aware, MRI measurements and ultrasound measurements diverge from each other. MRI has a lower linear resolution, more partial volume artifacts, and therefore ventricular sizes tend to be larger than on the ultrasound measurements. The definition of ventriculomegaly is clear to most of you, I assume, and you have heard about it. What I'm always struck is that we are calling something severe. So we are calling severe ventriculomegaly with ventricular width of more than 15 millimeters. But still, in literature, we have around 50-60% normal neurodevelopmental outcomes. So a severe, actually morphological condition is leading to normal outcomes in about half of the cases. You see, and coming back to my second slide, it's really hard to talk about severity in a context of then normality. So this is really the problem we are actually addressing. I like to refer to the ISUOC guidelines, which have been revised and in 2023. And there you find a very nice, basically, summary of ventriculomegaly and MRI findings. You see that even in mild ventriculomegaly, you will find some additional findings on MRI, varying depending on the quality of MRI, on the quality of neurosonography. It's hard to basically recommend something here. You see, it's a matter of likelihood. And I'm going to talk about this in a moment. Moderate ventriculomegaly, you see that there are a group of lesions which are very, very well detectable by MRI, and where you might consider MRI and the severe ventriculomegaly, it's basically the same group. Now, let's go to the situation. Physician is talking to the patient, and we are actually in the situation of counseling. There is mild ventriculomegaly detected on ultrasound. And of course, as prenatal medicine experts, you're saying that if there are no any other associated anomalies, I have not seen anything else in your situation, there is a very, very low likelihood, as you have seen by the numbers in the slide before, of neurodevelopmental impairment, we can talk about 7%, sometimes even lower than that. So, but I also have to tell you, ventriculomegaly, mild ventriculomegaly can be the tip of the iceberg of a more complex condition, and that's what you read also in literature. So this is the normal situation, but what is basically happening with the patient? Patient thinks, okay, and hears, okay, the ventriculomegaly may be the tip of the iceberg of a more complex condition. Oh my God, my baby has a problem. They're not thinking in terms of rationality. Is there 7% additional, 3% additional use? They're not just thinking, oh my God, there is a problem. Then you have to take care of the situation. You can refer to websites or they go to the internet and read themselves. They're reading that there is ongoing research how fetal MRI might help. And then you are in the situation to basically argue why or what you can do as a next step. So as a next step, you can say, don't worry, everything will be okay. I don't know if this woman will be okay in this situation. Then you can say, I'm referring you to a dedicated neurosonography. And you know that there are only few people who are really very skilled in that. And I hope that after this course, there will be many more, but because we need many more. Then you will not draw any consequence after an MRI. You will not learn more. Well, this is a likelihood question, only in 7% is said, or it's even too expensive. So all these arguments, of course, are okay. However, probably they will not change anything with this woman. Many patients want to know more, and they are seeking for more. There are some situations where you have to know when you're doing counseling that you should definitely get an MRI. If you feel that the ultrasound was not optimal, if you are in the third trimester and you have shadowing, you have not a good transvaginal view on the brain, MRI can help out. If you're in an environment where the rate of to be sued is very high, if there is an unexplained case why the ventricles are growing and you cannot explain the entire situation of growth of the ventricles, if mild ventriculomegaly is seen in the third trimester, so late, there is a high likelihood to have a vascular event. And why their MRI is very useful, I'm going to present later on the acquired lesions. But of course, I can say right now that MRI has a good sensitivity to blood breakdown products and hemorrhages. I just give you some examples. This is something you can, of course, solve by a neurosonography. So if you look at this case with the thin corpus callosum, this is also already the follow-up postnatally. And this is the prenatal viewpoint, axial plane, sagittal plane. When you see this pattern, you can see that, of course, on ultrasound as well. You're basically thinking about this snake and undulating midline. So think about tubulopathies. Of course, you don't need the MRI here in this mild ventriculomegaly case, but it can be good to have a reassurance of what you've seen and maybe see some other detail. This is another situation. There you have moderate ventriculomegaly. On ultrasound, there was found nothing else, no other additional brain abnormality. We did the MRI. With the MRI, you always have a good look at the hippocampi. You can see them on ultrasound as well. You can also see here this Vermean tail sign. And you see a rather thin corpus callosum, but what you also see is these crossroads as a soft marker. So what's this case? This case turned out to be a AP4B1 mutation. Taking together all these soft markers, the likelihood of a genetic abnormality increases, of course, and you should expedite the genetic findings here. AP4B1 is the reason for a condition called hereditary spastic paraplegia, a severe disease with intellectual impairment, but also with gross motor impairment. Why I'm showing this case in particular is that in the future we are currently working on therapies here. And this is a trial ongoing in the US where they use viral vectors, gene therapy, on this specific condition to treat it very early. And generally with gene therapy, we know the earlier you apply it, the better. And so the better you come up with a very specific diagnosis. In cases of non-specific ventriculomegaly, this is an advantage for the future and opens the windows for these therapies. This requires phenotyping. And I'm a strong believer that MRI is not the tool which is basically changing a lot in terms of how you call a disease, but how to characterize a disease. MRI might make a difference. And often phenotyping is not very precise, it's rather sloppy, and we can really add something here with with characterizing the morphology of MRI and identifying groups of individuals with similar diseases or similar outcomes and optimize counseling in this concept. We are strongly in Vienna following this concept, and really, if you want to learn more, I would like to invite you to the meeting which we are organizing in May in a moment. How can we do it? We can look at lamination, for instance. Here is a case where you see that the subplate is basically not visible in a circumscribed area where we have a cortical malformation. Also here seen on the postmortem. This is a situation, of course, many of you will know in a moment what this is. Just look at the brainstem and you will know it. You should also know it. If you see this kinking of the brainstem and this set shape, this small cerebellum, this abnormal midbrain, Walker-Warburg should come to your head. The more complex name is the alpha-dystroglycanopathy. With MRI, we can now use AI post-processing tools and visualize lamination even in these thin brains better. You see how this improved our visualization of the lamination. But in some regions here, we were not able to see that. And here, this brings me back to the importance not only to look at the size of the ventricles, but also the external CSF spaces. We are 22 weeks. We should have larger external CSF spaces here. They are smaller, maybe because the ventricles are enlarged, yes, but also in this condition, this has a specific reason because there is over-migration of neurons into the meningeal structures around the brain, and therefore the outer CSF spaces are also compromised and smaller. So always think about that concept, take the outer CSF spaces into consideration. Also, if you're looking at cases with spina bifida and Chiari2. In Chiari2, of course, we have the situation that CSF is leaking out the defect. We have smaller outer CSF spaces, but not in all cases to a similar amount. So you see here, the outer CSF spaces are obliterated entirely. There's nothing around the brain left, whereas in this case, you have existing outer CSF spaces still present. There is a difference between those. This group is more prone to intracranial hemorrhages, intraventricular hemorrhages. This is a fact which recently came up that in spina bifida and Chiari2, we have up to 30% intraventricular hemorrhages, and those are due to brain edema. If you look at this weird graphic analysis. This is called network analysis. If you want to learn more about that, again, I will bring up a slide, come to Vienna and have a look at our ultrasound meets MRI meeting. Fetal brain edema in TRA2 has consequences and also functional consequences because cases with this condition and small outer CSF spaces are more prone to hemorrhages, epilepsy, worse motor levels, and white matter loss. And when we characterize cases like this, more specifically, we maybe guide fetal surgeons towards the cases where we get the most benefit. And this is the announcement for our meeting. You see that we have a session on phenotyping where we are going to talk about network medicine and how we can apply that in prenatal medicine to understand the complexity of prenatal malformations. With this meeting will happen on the 2nd and 3rd of May. Yes, and finally, I would like to show a case where the dilemma of ventriculomegaly being a disease or not being a disease is really exemplified. This is a case imaged at 22 gestational weeks. You see one ventricle is larger than the other. Actually, the left ventricle is enlarged. You see some septi. You might think something about CMV. In this case, there was no positive CMV screening. But the question here in this situation, you have basically severe unilateral ventriculomegaly. By definition, what is the outcome going to be? And you see that also the ventricles are not showing the typical shape. There is clearly abnormality, but is there also disease to that? And in this case, we had the chance to even do a more advanced imaging with tractography, where you see that on the side of the ventriculomegaly, the corticospinal tract seemed to be a little bit more diffuse, but they are there. So they are a little bit fewer fibers and more kind of disrupted fibers. However, still they are present. Now, we had the chance to follow up this girl, and she was at the age of 5 years at our neuropediatricians, and that's how she's actually developing from a motor standpoint. You can see there is no hemiparesis, there is no motor disability, there is also no kind of visible neurological deficit. Of course, there are mild deficits, but not really visible. So again, think about what is a disease. And you might think, how is this working in this situation? There was a quite large unilateral ventriculomegaly, and it is basically, even at 5 years, you can see the ventricle is still enlarged. But we did a functional MRI, and we realized that when she was moving her right hand, she was doing that with her right side of the brain. So she basically shut off the left side of her brain, which we usually use to move our right hand, and she actually used her right brain to use her right hand. And of course, you know, this is called plasticity, and this requires some kind of rewiring of our entire brain. This requires also that our corticospinal tract on the one side takes over both sides of the brain, and that's what actually happened here. And this is also confirmed by neurological studies postnatally, and these mechanisms are quite fascinating. We can read into those in these papers. So I think the detection of ventriculomegaly is not enough. We have to phenotype and characterize the situation, because then we will know more. The gross basically classification into mild, moderate, severe is important and good to get an idea about risk, but risk is not equaling the diagnosis of a certain disorder. It makes sense to move towards the specific diagnosis of disorders, because maybe in the future we will have early therapies besides surgical approaches maybe also drug therapies and gene therapies being applied in the late stages of pregnancy. The earlier, the better. That seems to be a concept in this area, which is important. Whenever you're looking at ventricles, and I think this is one of my major points, never forget the outer CSF spaces. They are sometimes narrowed, they are sometimes widened, and in either ways, this is a phenotypic feature which helps you to explain the condition a little bit better. Chiari-2 cases with wider outer CSF spaces have clearly a better prognosis than those with very thin and or inexisting outer CSF spaces. They tend to have a brain edema and are more prone to hemorrhages or worse motor outcomes after birth. And maybe they are the ones which we should take care of specifically with fetal surgery. So I hope this was not too confusing. I hope that I could make a point that it makes sense to include MRI in the process and workup of brain malformations and also particularly in the assessment of ventriculomegaly. Thanks for your attention.
Thank you, Gregor, for this amazing lecture. And I'm so happy that you have addressed way beyond the imaging, because indeed this prediction that we try to make during the prenatal life is quite challenging. And we are going to have time to discuss on these topics and also the parental stress that we just drop on them in a while. And I'm happy to present our next speaker, my dear friend Rabbi Chaoui, that is also known from you all. As I told you, we are here among friends. And Rabbi is going to present the different syndromes in which ventriculomegaly may be a phenotypic part, and also normally the reason that the patient is referred. But then whenever we broaden our assessment, we see that there are additional anomalies found, and he's going to discuss this important topic. Then, as Gregor told, in our search for phenotyping these cases better. Thank you, Rabbi.
Good morning, ladies and gentlemen. Thank you for the opportunity to speak today on ventriculomegaly. I will be focusing mainly on the genetic aspects of ventriculomegaly. Ventriculomegaly is the most common CNS symptom in the fetus. It is can range from mild to moderate to severe ventriculomegaly called hydrocephaly. The counseling is really a headache for the patient and for the doctor, because it can be at the end harmless, but it can be also expressing severe handicap. And the different etiologies, can range from spina bifida, but also many of them can be of genetic origin. The definition, we know, we have heard this several times, is the measurement at the level of the parieto-occipital groove and perpendicular to the ventricular system, and then less than 10 millimeter is normal, and more than 10 millimeter is called ventriculomegaly. And it can be divided into two groups. In the past, we used to say 10 to 12, 12 to 15, and more than 15. Today, we say moderate, mild to moderate is 10 to 15 millimeter, and severe is more than 15 millimeter. But keep in mind that ventriculomegaly is a symptom and not a diagnosis. So this is why when we see this, we will describe what we see and we report the measurements. I will not today discuss the unilateral versus bilateral. Let's assume that unilateral is similar to the bilateral. When we have a measurement more than 15 millimeter, we'll call it severe ventriculomegaly. In general, you will have often an effacement of the subarachnoid space. And in some cases, you have even macrocephaly. In these cases, we'll speak on fetal hydrocephaly. But in general, we'll call it very often severe ventriculomegaly. Now, we know that it is a symptom, and we have heard several times on the workup to be done. So we'll perform neurosonography, transvaginal ultrasound, combined with 3D ultrasound, genetics, infection torch, and performing MR to find out one of these etiologies. But I think the list can be even longer. But typically, the first thing we'll have a look is the posterior fossa to seek for spina bifida, for Dandy Walker, and for other conditions, we'll look for the anterior horns to see Agenus corpus callosum and other, but we'll discuss some of these aspects today. So let's discuss first shortly the role of aneuploidies, because as you know, typically ventriculomegaly was for years one of the hints for trisomia 21. In many guidelines is still existing, but in the age of NIPT is almost disappearing. But you see this is a patient, 25 years old, at 18 weeks have a large ventricular system. You see the absent nasal bone, the short hands, and amniocentesis reveal trisomia 21. So it is still a hint of trisomia 21, especially when there was no first semester scan, or when there is, let's say, a moderate risk in the first semester scan. If we see these hints, we will focus on having amniocentesis and for the karyotype. Now, the next step is the microarray analysis. In this paper, so bit old, it was but one of the first papers on this field. It was shown that ventriculomegaly in isolation, as you see here, has a yield of 3.6%. But if you have a structural anomalies of other system, it goes up to 7.6. So in general, let's say around 2 to 5%, and here 5 to 10% risk. A more recent paper from China analyzed more than 500 fetuses with ventriculomegaly having a karyotype and microarray, and they found an abnormal microarray in 4% of the cases. So you see similar to the report. But if you look at the splitting of the data, and this is quite important to find out, if it was an isolation, it is 2.5%, but however, if it was an associated with other anomalies, it went up to 13%. And the severity plays also a role. If it was moderate, it was 6% microarray abnormal, but it was severe, it went up to 23%. So 1 out of 4 fetuses having severe ventriculomegaly has an abnormal microarray. And you see this is the scheme showing the autosomal chromosomes which were responsible for hydrocephaly or ventriculomegaly in children, and you see they are all possible deletions. I will point out one of these, which is the HP1P36 deletion. It is after 22q11 the most common deletion. It's the most common terminal deletion in humans, and I have learned that 1P36 deletion is responsible for a combination of heart and brain. And I'll show you a case here. This patient referred for screening, and you see here at 16 weeks, we discovered overriding of the aorta with the right aortic arc, and the brain showed already in ventriculomegaly. And you see here how small are the choroid plexus. And we found out that at the end it was deletion 1P36, confirming the combination of heart and brain. Heart and brain, especially for the posterior fossa, can be linked to Cri-du-Chat syndrome. Heart and brain can also be responsible for 22q11, for Char syndrome and others, but this is so typical with ventriculomegaly with a very small choroid plexus. Now we move to the next group, which is quite interesting, and this is the main part of my talk, is on the monogenic conditions and syndromic conditions. I will not discuss the syndromes without confirmed genetic finding, but they are getting less and less. In the past, we used to run a panel of called hydrocephaly, including all these, but today, since many are new detected, when we see in ventriculomegaly or hydrocephaly, we will offer next generation sequencing with an exome sequencing or trio-exome. So in this meta-analysis, summarizing the data, the authors, this Mustafa and co-workers, so including Yuval Yaron from Israel, Ron Wapner from New York, and Asma Khalil from the UK, they analyzed the whole data of many studies performing trio-exome in anomalies, and they picked up 138 cases of severe ventriculomegaly having normal microarray. And they found, all in all, an occurrence, a yield of 45% abnormal exome when you have a severe ventriculomegaly. Remember, severe ventriculomegaly was also 23% of microarray, but here we have abnormal exomes. Now, they split again these in three groups, one with extracerebral anomalies, one with cerebral anomalies, and one in isolation. And this is important to know the data because this is what we need for counseling patients. The one with extracerebral anomalies had 54%, the one with cerebral anomalies associated 48%, and the one in isolation is 1 out of 3. You have 1 out of 4 microarray, and you have 1 out of 3 severe micromegaly with the monogenic diseases. I think if we have to understand what are the genes involved, we need to understand the pathophysiology and the pathomechanism of the CSF circulation, the cerebrospinal fluid circulation. And this is a paper written some years ago on the genetic base of hydrocephalus. And you see there are the different possibilities of pathomechanism. I will summarize them this way. The authors found out that one group can be a more production of CSF, for example, in infection or hemorrhage. So another group, and this is the main group, is the obstruction of CSF flow due to, for example, aqueduct stenosis, primarily or secondary, or in fossa anomalies leading to an obstruction of the fourth ventricle. Let's honestly, for me, is infection and hemorrhage often linked to the obstruction of flow because I assume that when there are clots or when there is an infection, there is an increase of closure of the aqueduct of Sylvius, leading to an obstruction of flow. Anyway, and another way, another possibility was obstruction of flow at the level of foramen of Monro. These are the one having ventriculomegaly without third ventricular dilation. And they put also a group of where the lateral ventricles, they may have ependymal cells which are dysfunctional and the cilia may be abnormal and leading to increased of abnormal fluid turnover, and there are other groups. What's interesting here in all theories, and you see it's almost 10 years old, this paper, that the obstruction is a main feature because this is what pediatrician or neonatologists see when the baby is born with a ventriculomegaly or hydrocephaly. They see it's an obstruction and need to be drained somewhere else. But we'll discuss this later on. But if we pick up now group here, because we said in let's say infection and hemorrhage. Is a hemorrhage genetic actually? Because we know hemorrhage, when you see hemorrhage, it's rarely discovered what is the reason. It's of unknown origin. We'll often discuss the issue of the fetal alloimmune thrombocytopenia. So we test the parents for thrombocytes antibodies. But is there a genetic origin? Yes, there is a genetic origin. Since we are performing routinely exome sequencing, we are discovering these things. And this is the typical two genes, the collagen 4 type 4 with an A1 and A2 unit. So, and I will not pick up or discuss with you all possible papers because we have a really lot of papers on these two conditions. But in this French paper some years ago, the author found out that 9 out of 18 fetuses presenting with hemorrhage or sequelae of hemorrhage, 50% showed a COL mutation. In other words, when you see a hemorrhage, think always on testing for COL for A1 and A2 and don't assume it is an exogenic reason or hypoxic. Now I'll show you here a case referred to us for ventriculomegaly, and we discovered that the fetus had schizencephaly, but luckily here you see that we can see some remaining of hemorrhage, but look at 2 weeks later, it's not so obvious to find the clots, and you see how bigger it is. Performing the exome sequencing turned to found a COL for A1 mutation. So not only hemorrhage, but schizencephaly. And this paper here showed already more than 10 years ago that if you find porencephaly or schizencephaly, think on COL for A mutation because it can be the consequence of hemorrhage. Another case, I learned from some years ago was this one here. The patient was referred for, we had it as a routine patient, and we discovered these issues. We had a clot here suggesting hemorrhage, but we had a lot of echogenic parts here with a small head, and we assumed at that time it looks like a severe infection with a secondary hemorrhage. And but the hemorrhage was not so impressive, but on MR it was so impressive, and the genetic the torch findings, including Zika virus, were negative. But at that time we selected only the 2 genes. It was at the time when we were performing panel, and we checked for the panel of the 2, and we found a call for a 1 mutation. You see, signs of infection may be due also to torch, and this is a recent paper just published, American Journal of Medical Genetics, showing that the related disorders may mimic also torch, and not only the pseudo-torch due to Aicardi-Gouttière, but also think of call for a 1 mutation. When do we think on these 2 mutations? When you have an hemorrhage in the fetus, when you see some ischemic and hemorrhage finding, when you see schizencephaly as a sequelae of a hemorrhage, when you have cataract, there is also COL4 causing cataracts, and you see echogenic spots mimicking torch. Now let's move to the main groups, and this is an overview on all possible causes of ventriculomegaly or hydrocephaly postnatally, including prematurity. But let's focus only on the one we see antenatally. We discussed hemorrhage, and you see in all papers there is also the cilia abnormality. So for me, cilia, the ciliopathy or primary ciliary dyskinesia, is rather a kidney or an heterotaxy. I rarely see very often ventriculomegaly, but this seems to be possibly occasionally found or postnatally. And I'll show you, for example, this case here. And this was a referral of a screening ultrasound. We discovered this cephalocele, and looking more carefully, the kidneys were a bit hyperechogenic, and there was ventriculomegaly. And I assumed, as you see here, this is the typical the molar tooth sign. I assumed that the reason could have been also the accumulation of fluid in the cephalocele. The head was not small, and actually, it is not an aqueduct stenosis. This dilated part, this is cavern vein interposity, and you see the aqueduct is here quite open. But at the end of the day, it turned to be a mutation of the CEP29 mutation, typical for Joubert syndrome. Today, looking back, I would assume, well, the fluid increase in the lateral ventricle may have been due to CDR disturbance. Now, one of the most important groups discussed in many papers are the structural brain disorders leading to ventriculomegaly. So this one here. And this is what in the past, as I showed you in the other paper of the Kusi and co-workers, it was shown the main reason, which is obstruction of the level of the aqueductal stenosis. And this is what we look for in general. We look for mainly 4 things. If there is a spina bifida closing the aqueduct, or there is an evocal malformation, or REM encephalosynapsis in general associated with the de-encephalosynapsis, and 80% will have an occlusion at this stage, and aqueductal stenosis of different origin, including the genetic part. So the spina bifida here is the typical Chiari-2 malformation with the banana sign leading to obstruction and to dilation of the lateral ventricles, and then we see directly to the spine. Look at it. We know this is nothing new and rarely genetic. For the ROM encephalosynapsis, you see in the past we used to call it cerebellar hypoplasia, but since 15 years we know the diagnosis. It is the typical feature of an absence of the vermis with the fusion of these 2 hemispheres with the ROM encephalosynapsis. As I told you, so 80 and 90% are associated with an atresia or occlusion of the aqueduct. And in this paper of Nina Haratz, the ventriculomegaly was present in 80% of the cases, but only very few have genetic findings. In our experience, we had only 1 case showing a genetic abnormality. So it is rather an unknown origin disease, but some of them can be due to genetic. The third group could be the Dandy-Walker malformation, and you know that in Dandy-Walker you may find in 10% of the cases anomaly, mainly in the region of the deletions of 5, 6, and 1 deletion, but also some genetic syndrome. And you see, this is typical finding. Now let's move to the true genetic of the brain. And when I found this paper recently, I said I will present only this paper today. But looking then to the length of the paper, I found it's 135 pages, including 400 references. So it's quite impossible to cover all of these. But it shows that some of the knowledge inside this paper are quite new, and this is why I put at the beginning, it's evolving. And when we are dealing with the monogenic disease of the ventriculomegaly, there are 2 major things we should discuss, we should present, and there are new genes. The 2 main things are the L1-CHEM, the L1 mutation, and the second group is the Walker-Warburg family, what is called the dystroglycanopathies. I find it always difficult to pronounce it, so I will keep it for you as Walker-Warburg. And there are some new others we discuss at the end. So let's discuss, first of all, the L1-CHEM. This is the first thing you should know when you see in ventriculomegaly. You will ask yourself, is it a male, even if there is anecdotal cases of female? But it's wise the most common condition associated with ventriculomegaly. It is on the X chromosome, on the distal part of the X chromosome. It's X recessive. That means the mother is carrying the gene, and the males are affected. Often, if you ask the family history, there is either previous child or a male in the family having some severe handicap, and this is the hint for it. So there are different diseases. In the past, they used to be different. Today, they are merged into one group, like the X-linked hydrocephaly, aqueductal stenosis, Crash, and Mazza syndrome. So this is the first case I had. I remember this was a recurrent case in 96, and when we discussed with the geneticists, they told me, there is one disease you should look at. They have typically the thumb, and this is why I looked at the thumb. I could confirm it looks like an X-recessive hydrocephaly. So you see how long time ago. At that time, there was a lab in the Netherlands. They were trying to find out what is the gene, but today we know straightforward. If you see ventriculomegaly and you see a boy, go for the fingers, because the thumb is in 75% of the cases adapted as shown in these cases. These are other diseases, but the same gene. In the past, it used to be called the Vickers-Adams syndrome, but we don't call it this anymore. It's rather called an L1 syndrome because of the pathogenesis. With the hydrocephaly, you see this condition, but also, and this was surprising for me, that in Crash syndrome called corpus callosum agenesis, it can be the same. So in other words, the phenotype of this disease may differ. It can be simply ventriculomegaly hydrocephaly, but also agenesis of corpus callosum. And this case, the patient came to see us, 150 kilo weight, first child with handicap. She married, she had a new husband, and who's accepting the handicapped child. And then she came, and I found the agenesis corpus callosum and looked at the thumb, and we discovered that she is carrier of L1 mutation. Interestingly, during pregnancy, there was an increase of ventricle to 26 millimeters. So it's unusual if you have a simple agenesis corpus callosum to have quite a ventriculomegaly, but this is typical for the feature of L1 syndrome. So she continued pregnancy, and this is the child after birth, and these are the thumbs. And unfortunately, the husband separated from her, and she has now 2 handicapped children at that time when I saw her last time. So, in other words, L1-CHEM diagnosis, please think of this condition every time you see a male having CNS affection. If you see ventriculomegaly and or agenesis corpus callosum plus the thumb, look at the thumb, but it's not obligatory. If you don't see a thumb, it still can be an L1 diagnosis. And in our setting, when there is a family history of male having brain affection, our geneticists check always fragile X and L1-CHEM in the family. Now, the other group is the family of dystroglycanopathies. And this is more a muscle dystrophy. The more important one to know is Walker-Warburg, but today we have been more. It is called also muscle eye brain disease. In general, we'll have a brain affection in addition to eye affection, but it's not always the case. In the past, there were two main genes, the POMT1 and POMT2, but you'll see later on this is not the case anymore. It is often autosomal recessive in almost all cases. I know they have typically a lissencephaly type 2. We don't see the cobblestone easily, but you will see these are the cobblestone, means there is an overshooting of the neurons getting out of the brain, and this is the surface of the brain. They have very early a severe ventriculomegaly, even hydrocephaly, quite early, even before 20-week gestation. Often you find eye anomalies. Not often they are seen early gestation. They may see later on. They have often posterior fossa anomalies. And if you are very skilled, you can get a sagittal view of the brainstem and you see the typical Z kinking of the brainstem. But you need to have knowledge how to get this. In general, you have already a diagnosis done when you are looking to this. Muscle hypotonus postnatally. Today, we have many other genes. All are responsible for this muscle eye brain disease or dysglycanopathies, but with different severity. So it's not always as severe as the Walker-Warburg syndrome. So this paper published by Laurent Guibault and co-workers, they said if you want to seek for this condition, you can look at the brainstem, but also look at the outer space. The effacement of the pericerebral space is so typical, and this is the white echogenic band. But I saw it in the meantime in many other cases of severe ventriculomegaly without having association with the Walker-Warburg. So the brainstem is typical. You see, this is one condition from our group, and you see here, this is the brainstem in a previous case. And this is a case we have now observed. The patient decided to continue pregnancy, consanguinity, ventriculomegaly discovered. You see the microphthalma developed during pregnancy, and you see here the retinal detachment, and this was the gene found. And this is a follow-up from 18 weeks to 25 weeks, 31 weeks, and you see here how the typical features are present, the effacement of the suprachiasmatic space, even without macrocephaly. So this could be a typical feature. Abnormal brain tissue here, posterior fossa was also abnormal, and the eye anomalies. Now I come to the most interesting part, and this is the last part of my talk on the same group who published the other papers. Here by Jin and co-workers, this group from Harvard, they report on the exome sequencing, and they have a kind, I will not say a new theory, but they are endorsing a new approach to ventriculomegaly. They said in the past, everyone was assuming that ventriculomegaly hydrocephaly was due to obstruction. And they said in the meantime, they have done a lot of genome sequencing, and they found that there are many genes of ventriculomegaly which are regulating the neurostem cell biology and responsible for the neuro and glia cell genesis. And they assume that the genetic disruption in early brain development is the main key for hydrocephaly and not the impaired CSF dynamics, which is new because for many situation after birth, when there's a lot of fluid in the brain, it's always mechanical. They drain it and they say, well, it's obstructive, but it's not. And this is the theory. So, I like these two schemes. I'll try to explain to you. This should show you the ribbon. This is the cortex, and this is the ventricular system, and this is the aqueduct, and this is the CSF flowing here. There is a neural stem cell developing, and the neural stem cell give rise to the radial and neuron glia cells, and you'll find at the end different cells from the neurons to going to the outer cortex to the astrocyte, but also epidermal cells with the cilia here. This is under normal physiological condition. This is the homeostasis. Everything works well. Now, imagine at one stage that you have a gene responsible for an abnormal development of the neuro stem cell. This leads to less neurons and a disturbed neuron, and you have less brain here. And this is primarily a cortical hypoplasia and dysgenesis. You have abnormal neurons here, and you have more space where the fluid will flow in. You may have also disturbed development of the ependymal cells with the cilia, and this turnover of fluid in the brain will accumulate, and this is why the fluid in the lateral ventricle, the CSF, is not due to obstruction, but rather to a less brain and to abnormal fluid turnover. And this is another approach also. It can be due to the abnormal development of the, let's say, of different cells, even to cells lead to obstruction here, like closing the aqueduct or denudation of the cilia. So in other words, the less brain can be an issue in ventriculomegaly. And this is something we have seen prenatally, but we see because we see the fetuses during the evolvement of ventriculomegaly, typically for Walker-Warburg, for example, while the postnatally they see the final result 20 weeks later. So I show you now a case I learned from, because it fits exactly what I saw, even it's not one of the common genes. So this is a patient non-cancer. When it's coming for a second opinion for ventriculomegaly, you will do, okay, we'll do this. A typical issue, you see the lateral ventricle dilation here. There is no typical finding, cerebellum or small, but looking more carefully here, if there are additional findings in the brain. First I thought it looks a little bit echogenic, but looking more anterior to the CSP, I found out there is no CSP. So is it an agenous corpus callosum? But it's not typical, because the agenous corpus callosum, they have in general compressed anterior horns. So what happened here? Now what's happening here is we have a type 2 agenous corpus callosum. Type 1 is defined that the axons are formed, but they are unable to cross the midline. What happens here, they are accumulating here and they go backward as a Probst bundle. But in type 2, the definition is that the axons and their parent cell bodies, the neurons responsible for them, they fail to form the cerebral cortex, like at the early stem cells. And this leads to this picture. You have not compressed because you don't have accumulation of neurons here, or axons because you don't have axons. You may have even less neurons. And looking more carefully here, I saw it honestly afterwards. You see some cysts here in the germinal matrix. You see one is here and one is there. And look, this is here again from the 3D, where you can observe quietly one cyst here and one cyst there. So it is ACC type 2 with a ventriculomegaly, which is unusual. And looking to these details, it showed these cavitations. After exome sequencing, it turned to be a pyruvate dehydrogenase deficiency. In general, it has more cysts if we have waited more late into gestation, but it's not always associated with an agenous corpus callosum. And in the paper written by Egloff and co-workers from France, if I remember well, they found that 80% of pyruvate carboxylase deficiency had ventriculomegaly. So you see, it confirms the theory that less cells in the neurons are responsible for ventriculomegaly. But keep in mind, and everyone has similar cases, you find ventriculomegaly, hydrocephaly, you assume it is A, B, or C diagnosis, L1 CAM, or this and that. It turns to have a normal exome sequencing. And this is why I'll tell you, wait, because in some years from now, what you have not solved 5 years ago will be solved. And this is what I want to finish my talk with. There are new genes discovered every year, and this was given me by my geneticist. I said, are there some new genes that you will not believe? He showed me at the beginning of year 24, there was this number of genes, and only within 1 year at the end, they had 100 new phenotypes and 74 genes. He said, today we may also retake cases 5 years old and reevaluate them because there are new knowledge. And this paper here by the group of from Harvard, from Yale, they showed also some new genes. I'll show you one case, which I assume it's quite crazy and rare, but I think the future would not be as rare as. So the patient, again, non-consanguineous, one healthy girl, nuclear since he was normal. At 21 weeks, the fetus was male, and we found this ventriculomegaly with macrocephaly, typical picture of hydrocephaly. Now, you see here the measurements showed that we have ventriculomegaly, we have effacement of the supraarachnoid space, we have macrocephaly as shown. So this typical picture of a hydrocephaly as a severe ventriculomegaly. What is the reason? Look at now the videos here. You see the aqueduct is obstructed, and you check the torch, it's negative. You check the genes, and I assumed it is a kind of L1 CAM with normal thumb, because looking here to the face was normal, the eyes were normal, there was no cardiac anomaly, the thumb was normal. But we'll say, well, let's see and wait. And then it turned to be what is called a SMARC-C1 mutation. Nina Harris will know this case or similar case, because look what happened here. The father has this mutation, but he's healthy. Today we know that SMARC-C1 may be responsible for severe hydrocephaly in the fetus, and they may also cause mental handicap, but also cardiac anomalies and so on. So, and looking to the literature, I found that 1 year ago, 1 year before, the SMARC was reported by the group from Israel, from Yuval Yaron, Nina Haras, Gus Abumani, and so on. And they found, in their case, the fetus and the mother who was healthy had the mutation. So is it accidental to have this SMARC? How old is this SMARC mutation? It's quite new. It was first reported in 2018. And now more and more cases are raising up. The abbreviation is for this SWIFT-related matrix-associated actin-dependent regulator of the chromatin subfamily. So it sounds very complicated, but they found out that the development or the pathomechanism of this disease is a key in similar to other diseases. They are now calling it bafopathy. To bafopathy also belong the group of Coffin-Siris syndrome. And the same group I showed before, the Yale group, they analyzed 8,000 exomes over 7 years to define, in 6 cases, the different genes of SMARC-C1 mutations. And they suggest to call this entity SMARC-CC1 associated development dysgenesis syndrome. I'm sure the more you will do this, you more will find these findings. And I'm sure one of these days we'll have this as one of the shortlisted genes responsible for hydrocephaly. And I can imagine that if I take my old cases, some 7-8 years ago and older, and check them again, probably they may have this gene. So let me finish now to be on time. In summary, ventriculomegaly and genetics, we used to focus more on the obstructive factors and on the typical conditions, but more and more there is a theory of neurogenesis and the discovery of new genes. I showed you the aspect of karyotype, the microarray analysis. We discussed shortly the role of bleeding. So hemorrhage can cause different features with ventriculomegaly, like isolated or with clots or with schistoencephaly or with infection signs. But the typical 2 conditions are L1-CAM and Warburg syndrome. But I could have discussed tubulinopathy or more in length the cilia issues and other. But it's more important to know that there are new mutations responsible for neurogliagenesis and leading to an abnormal development of the neurostem cells, leading to a less cortex and then to a dilation of the ventricular system, and not due to obstruction. I thank you very much for your kind attention, and if you have questions, I would love to answer them.
Thank you, Robbie, for an amazing lecture, as always. And I'm very sorry that you cannot join us for the discussion, but we will have a very nice Q&A and discussion panel together with Lisenda and Gregor and Ritsuko. And I wanted to share my screen because ventriculomegaly has a very hot spot in my heart. I have started studying neuro, working with ventriculomegaly in São Paulo, and this is my first publication on the morphological evaluation of the lateral ventricles with ventriculomegaly. And I'm not sure that I am able to. Let's see if I can show the pictures. I think so. I think you all see the screen. And we have used vocal to reconstruct the 3D aspect of the ventricles, and we have compared to the T2 sequences of MR in order to try, before we really understood how to scan the brain deeply and how to diagnose and make the differential diagnosis of the abnormalities, but to understand what you, Gregor, was showing us in the beginning of your lecture. And I think this is very important also for the sonographer, that it's not very expert and will not enter into the very deep details of the fetal neurosonography. So looking at the morphology of the ventricles, to the extraaxial space, to the other brain structures, and then trying to correlate the findings that you see are a key feature for the workup in these fetuses. Not less important that using very advanced genetic techniques and also advanced MR. So you can drop my share. So indeed, this is a very important and topic that we should discuss. And I will begin with a question for Lisenda that we have from the public here. I don't know who sent, but do the statistics presented apply to the diagnosis of ventriculomegaly in the second trimester only, or both second and third trimesters, Lisenda?
So thank you, Karina, for the question, and also for inviting me to participate in this session. I'm really happy to be here, and all it's really incredible, the level of the presentation. So I think that we are going to learn a lot along the way. So the question is that if the incidence and the diagnosis about the ventriculomegaly only in the second trimester, this was the question? Because
yes. So if like the rate of associated abnormalities can be applied, and I think it would be interesting for you to explain and to how we can do a critic lecture of the literature, because it's tricky.
Yeah, no. So sometimes it's difficult. I mean, when you look at the literature, it's not easy to see if they are talking about the 20-week scan or the third trimester. But I think that the main message, and this is my opinion, is that we have to think about ventriculomegaly as something that can appear along the pregnancy. So, I mean, the numbers that I give you are not only related with the 20-week scan. So I think that it's very important to keep in mind that even you have a 20-week scan with a complete normal lateral ventricles, ventriculomegaly can appear later, and this can be associated with other things. Indeed, sometimes the third trimester ventriculomegaly are signs of major abnormalities, for example, for cortical development. So I think that the numbers, I don't know what do you think, but because it's different, it's difficult sometimes to disentangle in the papers if these are only 20 weeks or is third trimester. So sometimes it's not easy, because sometimes we merge the cases from both trimesters. But I think that the key message is that ventriculomegaly is very important. You have to check ventricles in each ultrasound that you are doing, even though the patient is 36 weeks, because sometimes it can be the sign of something else, as we have seen in the presentations as Gregor and Chawi and Rabbi Chawi have shown.
Great, and I think this is an important point yet for the public. I know that the methods part of the papers are very boring, but it's super important that you go to the methods and you see where did they measure the ventricle. Is it a longitudinal or a cross-sectional paper that they have only scanned the fetal once, so you can understand what was applied, and then how you can try to do this at home.
And I think that especially, Karina, if you want to give counsel to the patients based in a manuscript, so if you have some, for ventriculomegaly or for any of the conditions that we diagnose along pregnancy, sometimes we have to look at the literature and see, well, this is the prognosis based on in this series, but you have to, as you say, go to the methods, see which these series are. They have genetics, no MRI, yes, no transvaginal ultrasound, only transabdominal. So I think that is very, very important. And of course, in the case of any malformation, and of course in the ventriculomegaly, that is one of the most common anomalies that we are going to identify. As I say in the presentation, is a sign, and it's what worries more us when we see it in ultrasound, because it's telling us that something is happening in the brain in a high number of cases.
Thank you, Elisenda. And our next question will be for Gregor about the limitations of fetal MR in evaluating ventriculomegaly. This is a great question, because sometimes also people think that they send the patient to the MR and this is the golden eggs chicken. So, and it will respond every question and that's it. And many times I know also that there are places that the sonographers or the sonographer are more experienced than the radiologists that perform the MR, and then we need to work together. So I wanted you to address what can make MRI questionable and how can we improve it?
Yeah, thanks a lot for the question. I also think it's very important. MRI is not like, Starship Enterprise, where you put somebody into a machine and push a button and you get a brilliant image. Of course, there is technology behind it. Our major issue with fetal MR has been and still is fetal motion. We are fortunate that fetuses are moving and happy about that. But in order to get good images and good image quality, it's really important to speed up your sequences and optimize them for fetal imaging, for fetal MRI. So motion is certainly always and has been always a challenge. In the third trimester, babies cannot move that much. Mothers are feeling a little bit more uncomfortable in the MRI because, the womb is larger and our gantry, the size of the MRI, is relatively smaller. Then we often have the image in the lateral decubitus position, where the quality is also not optimal because our scanners are built for people lying in there in a supine position. However, these are limitations we learned to deal with. However, if you, as Karina, you mentioned, if you have an inexperienced radiologist at the start of his fetal MRI career, these are truly challenges. Now, in terms of the question, are there limitations more specifically to ventriculomegaly or in the assessment of ventriculomegaly? Well, yes, we need the ultrasound information because we are still very poor in picking up calcifications. We are still lacking a good visualization of the choroid plexus. So ultrasound is much better in seeing the choroid plexus and particularly or also choroid plexus cysts. So if you have asymmetric ventriculomegaly and one ventricle is larger than the other, there might be a cyst, and we mostly don't see those cysts on MRI, and you brilliantly see those on ultrasound. So both informations are really, really important.
And if you could comment a little bit on the artifact of movement of the fluid within the ventricular system, I think also for the more experienced, it could be an interesting point.
Yeah, so if you perform a T2 weighted sequence, that is our working horse in field MR, but also postnatally, we are performing a lot of T2 weighted imaging in neonates. And when we are addressing a neonate with obstructive hydrocephalus, we want to see how the flow of CSF is happening. And we don't have Doppler on MRI, but we can see slow and also faster flow on T2 weighted images by a dark artifact. So if fluids are in motion, this leads to a dark artifact on the T2 weighted images. So we are looking at the aqueduct and we are looking if there is a flow artifact through that aqueduct in neonatal MRI. In fetal MRI, this artifact is so little, is so subtle that most of the times we cannot use it as a good let's say marker. But still, it's good to know whenever fluid is in motion, it causes an artifact on T2, which is visible, which you can use to your advantage if you're looking for flow, but also is a disadvantage when there is too much of it.
Thank you, Gregor. And I'll send the next question to Ritsuko. So they have asked, what if you have an unilateral ventriculomegaly and hyperechoic large kidneys in the third trimester? And so often we have like early ultrasounds that the ventriculomegaly seems isolated, and then we have other findings found later on in pregnancy. So how do you manage these cases? How can you investigate them, Ritsuko? I think you are muted.
Sorry. The first of all, the unilateral ventriculomegaly, sometimes, it might be the normal variant. Sometimes, the unilateral atrial width is about 10 or 11 or sometimes 12, but it is a completely normal variant sometimes. And so you have to think about that first. And also still, that you think the unilateral ventriculomegaly, most probably, that is something, the reason behind that it might be some kind of the cause, like the hemorrhage or tumor or cyst or something like that. And so maybe that you have to go for the further examination, the neurosonography or MRI, and also the hypoechoic large kidneys. That means, the multiple cysts inside, or I'm not sure, what this participant is going to say, but the bilateral hypoechoic large kidneys, and sometimes, it is very pathogenic, and I'm not quite sure, the relations between the unilateral ventriculomegaly and the kidney disease. But I think kidney disease is much more seriously. Sometimes because of that the oligohydramnios occur and the kidney function less and less. So I'm not quite sure do you have any idea, Nina, that the unilateral ventriculomegaly with hypoechoic large kidneys?
I don't have a specific idea, but I think you pointed to important facts, and I will pass also to Elisenda to address the topic. First is especially very mild ventriculomegalies in large-headed male fetuses sometimes, and then you see another another finding, and also automatically leads us to think on a syndrome or a multi-system entity. And sometimes it's really a variant of the norm. So, and it's a confounder more than helps us in order to make the differential diagnosis. So remembering the fact that sometimes very minor ventricular dilatations may be borderline and not necessarily part of a syndrome. I think this is an important fact because we see it quite often, as ventriculomegaly is a common finding. So we see it quite often. But on the other hand, so here in Israel, we perform then late third trimester amniocentesis, and then we do full workup whenever we see an associated finding or any abnormal finding that raises the chance of a genetic abnormality. So we rather perform a third trimester amniocentesis and then run full workup. And sometimes, many times, it happens. And then the importance of the third trimester anomaly scan in these cases. Elisenda, you want to address this topic?
Yeah, I partially disagree with you, you know, that I'm a bit more in favor of investigating all cases. I fully understand what you are saying. I already know that part of ventriculomegaly, mild ventriculomegaly cases that are isolated are going to be normal variant, or maybe are secondary to a grade 1 or grade 2 hemorrhage that we are not able to identify by ultrasound, or that's all. But I think that it's important to investigate, because there are a lot of cases that the only sign that have something is even a mild, not mild ventriculomegaly, a borderline, so an atrium between 9 to 10. And we have some data on that, and we are trying to collect all the data on that. But I think that it's important to understand that even though you only have 10 millimeters or 10 to 12, it needs a male fetus, big head. But I think that's important to do all the workout and to see that is isolated, and also to explain to the parents. So the most probable thing that if everything is all right, if everything is isolated, is that your baby is completely normal, and you have to explain this to the parents. But I think that as a doctor, we have to keep in mind that this can be a sign of something that is going to appear later. And I think that we have to have this duality. So to explain to the patient, okay, it can be something that it's normal, but we have to follow you up and to see what is coming there. And because if we start to do these things that between 10 and 12 it's male, I think that you can do an amniocentesis. I mean, nowadays the proportion of, if in your media is possible, but the proportion of complication is very low, 1 in 1,000. So I think that this is a good idea. And in this case, that the question, that ventriculomegaly with large and hyperechogenic kidneys, in my opinion, an exome sequencing should be offered.
I agree completely. Yes, Gregor.
May I add something? As you can imagine, in Vienna, we would do MRI.
Of course.
So
Why not?
hyperechoic kidneys and asymmetric ventriculomegaly or unilateral ventriculomegaly, I want to see one thing, and that is the brainstem. Because this is a combination always good for ciliopathies. If you have not described fully and characterized phenotype the brainstem, you cannot really exclude it. Of course, you can never exclude it without genetics, but this is an important information. If you can get it with neurosonography, good for you. If you don't, do an MRI.
As here in Israel, we have no mercy, as we say. So all of these cases, although male, although big head, although whatever, so we recommend also from the medical legal point, if we do not, we have a big problem. But I think this is good medical practice to explain to the patients what we can offer them. And many patients in the third trimester, they come with the taboo of the amniocentesis because they think it will lead to a loss of pregnancy. And they do not understand that late amniocentesis maximum will lead to preterm labor, and it's very low rate, but it will not course with a pregnancy loss, and they do not understand that. And sometimes we need to explain it and state it because they come closed. I don't want any invasive procedure. And then when you explain to them, many of them, they cope and they are willing to investigate. So I agree with you, Elisenda, completely. And Gregor, you answered before I questioned you. So in this case, also, it would be nice to expand the indication of MR also to check on the kidney. Are there contributions also from imaging the kidneys in this setting from the MRI?
There is one aspect maybe which is helpful where we are using the added or complementary value of MRI. We are running diffusion-weighted sequences, DWI. On DWI, the kidneys of babies are bright, which means the architecture of the kidney is very organized, and it appears, and we have not systematically studied this, but is certainly a study which needs to be done. We have the impression that the DWI information prenatally well corresponds to the scintigraphic information of the pediatric urologists postnatally. So it tells you a little bit about kidney function. Of course, there are other parameters to do that, but this is some aspect what MR can contribute besides, let's say, confirmation of the kidney changes.
Thank you. Next question I will address to Risuko, at least for beginning. Any comments about the diagnosis of ventriculomegaly in the first trimester?
Actually, I have several cases with the cases with ventriculomegaly around the 12 weeks of gestation, and the some of them, the ventriculomegaly disappeared spontaneously. But I have the very the one case that the ventriculomegaly at 12 weeks, and gradually it improved, and everything seems to be okay. But the only thing was the lateral ventricular wall irregularity at around 20 weeks of gestation. And we discussed about, the continuity or termination of the pregnancy, but, they continued. But later on, after birth, at birth, everything was okay. The normal birth, everything was okay. But, later on, several years later, the parents told me that, there's a very, very severe handicap, in that boy. And after that, that we now still, investigating the genetics. And there's some, I forgot, the details, but, that we found one of the genetic variant, but now still, the VUS. So maybe, that we have to investigate more the grandmother and the grandmother's, the genetic findings or something like that. But, sometimes, that we have such kind of cases. And so I don't have the very, very good case of the ventriculomegaly in early pregnancy. So the most of the cases, that they are deteriorated later on, and we found some of the genetic variants.
The thing is that there is a window of opportunity in many places. I think when you see the fetus in the first trimester, then you're going to see the patient only later on. So if we do not address or at least ask the patient to come back, so we are probably going to diagnose it later. And although I know the response, but I think from the ones that are listening to us, do you do the assessment transabdominally or transvaginally in these fetus in the first trimester?
Definitely transvaginal.
Transvaginal.
Yeah.
Yeah, so this is an important message every time that we suspect on whenever, but especially in the first trimester, because assessing transvaginally, it's very important. And even when you refer like a patient with a nuchotranslucency of 7, okay, sometimes it's very high, so the chances that we have very bad outcome are very high. And I know there are many patients that then they go for curettage, for termination of pregnancy, only for that. But if you can, maybe you, Elisenda, can tell a little bit about the importance of checking the anatomy in these patients for the sake of the investigation and the counseling.
Yeah, I think that is very important, Karina. Is a point that at this point that you raise is very, very important. I think that in these cases, especially in those with increased nuchal fold, if you don't have even diagnosis, I mean, I think that it's important to investigate which is the cause, because maybe it's something that is going to repeat in the next pregnancy if this is a genetic anomaly. So I think that whenever you identify an anomaly in a first trimester scan, and an increased nuchal fold is an anomaly, then you have to check the anatomy. And of course, you have to check the anatomy transvaginally, because, I mean, it's like a complete different ultrasound. So if you want to check, especially the brain, but I mean, the brain, the kidney, the heart, everything. But if you want to check the brain, I mean, it's like seeing is completely different. So you can identify all the structures, and you, Karina, your group, you have a very nice data about how to show these evolving structures that you can identify, and you can nicely see how the brain is normally developing or not. So in an increased nuchal fold, increased nuchal translucency, I think that it's very important in our center. And when we have a baby with increased nuchal translucency, we do the genetic study, and this is completely normal. And sometimes the patients going on with the pregnancy, we always recommend to do also a neurosonography later in pregnancy. We do an early one, but also later in pregnancy to see if there is something that comes up later. So very important. And I think that first trimester, I mean, we need to move to the first trimester. I think that is very important. It's an important message. We know, all of us know, and all our audience know, that the brain is completely changing. And I think it's true that it's an organ that is going to evolve during the whole pregnancy. But I'm fully convinced that there are some signs that in the first trimester at least can raise the red flag that be careful, this is a high-risk patient. Please follow up closely and diagnose as early as possible the condition.
And on the same topic, I will ask Gregor. Gregor, we can do 1,000 ultrasounds whenever we like, but you can less do 1,000 MRIs. But if we would do a sequential, or let's say the opposite, if we will do the earliest MRI we could to get more information, and specifically in cases of of ventriculomegaly, when would you like to invite the patient? If you could, okay, we saw in early second trimester there is ventricular dilatation. An important point, in the early pregnancy before 18 weeks, the measurement of 10 millimeters is not a cutoff. So it will be more a subjective assessment than an objective measurement. But if we saw an early ventriculomegaly and you need to invite the patient the earliest, when would you like to see her, Gregor?
Yeah, so I think that's a very good question. So let me answer that in the way that we are doing a trial in Vienna where we are starting with MRI prior to 18 weeks. So this is really, really early. If you're not used to do MRI, don't do that. It's really, really, it requires a lot of imaging skills. You have to adapt your sequences. The fetus is more moving. So that is an absolutely experimental use of the technology. So this is something for the studies. We will see where this is going. Otherwise, in the early, after 20 weeks, well, the time point we would do before 24 because due to our forensic environment here. People want to know early as possible. Of course, if you have ventriculomegaly diagnosed after 30 weeks, we would do it right away. One thing I would like to also mention, and in your discussion, which I believe is an important point, which is often not seen from the prenatal medicine perspective. I'm seeing as a pediatric neuroradiologist a lot of kids after birth. And in more and more cases, we are wondering if we see something abnormal, how prenatal diagnosis may have looked like. So we try to get that data, and it's a sort of an unusual path to go back in history to maybe see if there are hints in prenatal imaging for what we see postnatally, because in some cases even, we have the impression that the phenotype, the prenatal phenotype, is even more suggestive or more telling than the postnatal phenotype. So for everybody who can do neurosonography or a detailed visualization of the brain, it's good for the entire perinatal medicine community if there are images available where we can go back and look at the ultrasound images, and maybe there is one or the other abnormality which makes sense in the context of the postnatal findings. Just shortly, sometimes we see hydrocephalus, obstructive hydrocephalus, and we may wonder why was there normal prenatal scanning, and you go back, and if there are indeed normal findings during prenatal medicine evaluations, you can assume that something happens after birth, maybe a small hemorrhage, and you put that into a total different perspective than if there were findings existent already prenatally.
This is very important topic. We have discussed it also in the first session, the evolving phenotypes, and also from the medical legal point of view. I think we have also many colleagues being sued by peripartum complications or things that were related to bad obstetric care, but they have in fact occurred earlier during pregnancy. So I think from the legal point of view, it's important, and from the medical point of view, even more. I think one very good example is tubulopathies, because for many years we have known the severe tubulopathies, the A1A with severe lissencephaly, and many patients with the mild types, as far as they are almost normal clinically speaking. So they never seek for assistance, and we didn't have a lot of imaging from the postnatal point of view. From the prenatal point of view, sometimes these brains, they look very abnormal, and they really frighten us. So when you see a distorted interhemispheric fissure and this gyria and asymmetric ventricles, whatever, what look like a very severe abnormality. And then when we discover that it's inherited from the mother, and the mother has the same or similar findings, so all our interpretation of what we see changes. So I completely agree with you, and I think also that having third trimester imaging done more and more will also help us to have these data sets and doing the reverse engineering that you are proposing. So learning from what we can see. And I think I want to address one last topic before we end, which is what you have spoken about, the human side of all we are doing, how we can stress our patients out, showing or seeing something that not necessarily is translating into clinical abnormalities, and also the opposite. And I'll start with Elisenda, because here in Israel, if we show the patients that the 11.5 millimeter ventricle will lead to poorer cognitive performance, we will be in very, very big trouble.
Yeah.
So, how do you address it in your daily, from the human perspective? How do you have support for your patients? I think I want to ask you three how you deal with this part of support for the patients that we take care.
Okay, I will start then. So I think I also understand your point, Karina, your point in your country. I mean, I think that each reality has its own way to work. I mean, I can explain what we can do in Spain and how our patients deal with this information. When I have the diagnosis of a ventriculomegaly, I explain to the patient exactly the same that I explained in the conference. So I explain to them the most important thing is to identify that this isolated. I propose to you to do these three things: ultrasound and follow up, and amniocentesis for discarding genetics or infection. And if everything is okay, your baby, if I support in the literature, I have to tell to the patients that in 90-95% it will be completely normal. And I also explain to them that we have some data that in our population we have observed that these babies have some problems in the language, especially, and that for us it's a patient that should be follow up, and that's all. I mean, I think that it's not a severe thing. I think that it's an important thing. So because the evidence that we have provide in this point of the ventriculomegaly is to explain to the patients that it's not a severe anomaly, but it's something that you can intervene early in the childhood. So if you have a baby that you know that it's a high risk of having learning problems or like especially in the language or in the lecture, you can intervene this early and you can solve all the problems that this baby is going to have. It's the same with IUGR or with congenital heart disease. So the idea is not to give negative ideas to the patient, is to say, okay, this is a high-risk patient and not high. It has some statistical risk to have these problems, but the good news is that we can intervene that. So you can do postnatal stimulation to prevent that these things are going to evolve. So, but if you explain that to the patients, I think that they receive in a good mood. But I fully agree that once you diagnose ventriculomegaly, some other conditions also, but ventriculomegaly, I think that it's an important issue, and you have to have this personal, also this human point of view, and to explain to the patients everything very well, and also to explain that you also can discover things later. And I think that it's important to tell them that probably if maybe it's isolated, it's mild and non-progressive, the proportion of something happens later in pregnancy is low, maybe between 10% or less. But you have to tell that to the patients because they have to know that something can happen, but also telling them that it's not a high risk. And the idea, this is how we work in Spain. So we explain to them everything.
This is amazing because also we need to offer them the support. So then they need to have the pediatric neurologist follow up after, and because sometimes they deliver and they just get lost. So I think this is a very important message. Gregor, your final message on this part?
Well, thanks for giving me the opportunity on that. What I wanted to say from my radiologist perspective is I also need to know where my limits are. My environment here at radiology is certainly not a counseling environment. So I'm not going to speak much to the patients. I'm communicating to them, but I'm not telling them, not giving them a counseling communication in a counseling setting. For that, I'm not prepared. So this is really in the hands of those who are really having the full information coming together. And these are the prenatal medicine specialists upstairs in our hospital. So this is the setting. But one thing I wanted to add to Alessandra's very important comment also on the follow-up and early support of individuals with an abnormality or a finding on prenatal imaging. So callosal agenesis is a totally different chapter, but I just report one phenomenon. We have we are looking after our babies with callosal agenesis here in a physiotherapy, ergotherapy, and supportive setting. And it turned out that at some stages of early development, they're doing better than the normal controls who don't get that support, where overall probably they will have problems, but still with that support, you're really affecting their development. And that's something to keep in mind. And this is a really positive, very positive comment, and should be also included in your counseling. I'm absolutely pro that, and thanks for the comment, Elisenda.
Itsuko.
Yeah, actually, no, I completely agree with Gregor, and thank you very much, Elisenda. And I learned from you, and that encouraged me, and because every day, every patient, I encountered, the counseling, the patient communication, I took time to be with the patients, and but sometimes, it is quite difficult. And also in Japan, the 22 weeks is the limitation of the termination of the pregnancy. So that is so before, usually, my research work is almost, concentrated on the between 18 and 20 weeks of gestation. So therefore, the communication, the counseling, I don't want to threat patients. But the too much encouragement is sometimes, not good. And so, sometimes, I feel dilemma. And so, I think I thought, the many things, from Elisenda's comment, and also I learned from Gregor and Nina. Thank you very much.
Okay, so I think we should end our session. Thank you for this great discussion on this important topic. And we are going to continue with our next session about then the third trimester. Do we threaten the patients with late findings? So let's see in the continuation. Bye-bye. Thank you.
Welcome everybody again. It's a great pleasure to introduce the next session. It's going to be exciting because we're having a deeper look also in the third trimester. The first speaker is Dr. Brusilov, who will talk about tips and tricks on neurosonography during this challenging period.
Good day, everybody. Congratulations for annually neurosonographic meeting. Thank you for Tatiana and Nina for invitation. I will talk about third trimester screening of the brain, how to screen in the third trimester, tips and tricks. Neurosonography, it's not trick, but I can give you a lot of tips in my presentation. We have 4 different situations. Baby may be in head presentation, in the bridge presentation, and time of the pregnancy may be up to 26, 28 weeks, and after 28 weeks. Actually, all 4 situations absolutely different for examination. What transducer to use? In transvaginal ultrasound, up to 26, 28 weeks, my preference is high frequency probe, because I need in this step high resolution with low penetration. After 28 weeks, in most cases, I need low frequency probe because I need high penetration of my probe. Before the start of the TVS study, we need to explain that the study is not dangerous for the pregnancy and there may be discomfort. The insertion of the probe should be slow and gentle to avoid painful sensations. 2 rules of the thumb. To be as close as possible, stand correctly relative object, the main brain. Technical aspect of the neurosonography. We must know that the 12 weeks of the pregnancy not equal pregnancy in 32 weeks, because in the early steps of the pregnancy we have large acoustic windows, and in the third trimester acoustic windows are narrow. What we have as acoustic windows? We have anterior fontanella and coronary sutures, posterior fontanella and lambdoid sutures, and mid-sagittal sutures. As I said before, close is better. Anterior part of the brain, a good choice for examination is anterior fontanella, and the posterior part of the brain is the posterior fontanella. The probe must stay perpendicular to the brain. Here you can see 24 weeks of normal brain. My probe close to the brain. You can see mid part of the brain, corpus callosum, anterior complex, sulcation, sylvian sutures with operculization, anterior complex. Because my probe on correct position and close to the brain, all part of the brain we can see absolutely clear with good quality. You can see here my probe is RIC 612, the high frequency probe, the good choice for examination in this step of the pregnancy. This is a case of lissencephaly in 24 weeks of the pregnancy. Again, my probe close to the brain, on the correct position relative to the brain. You can see abnormal anterior complex, abnormal sulci, sylvian sulcis, with abnormal operculation. Again, close as possible. This is the same case on the 4D reconstruction. The A, you can see here, abnormal operculation of the temporal lobes and abnormal anterior complex and abnormal corpus callosum. Corpus callosum is thick with high echogenicity. This is a case of lissencephaly. In cases of the bridge presentation, my recommendation to use convex transducer C2-9 and the correct position is straight back of the patient. On the straight position of the patient, we have more space for maneuver, and I'm not limited with my examination. I can to put my probe on correct position and close to the brain. Again, correct position is straight back. This is a case of bridge presentation in 33 weeks. Now the patient in supine position. In supine position, I start exam of the brain from the axial view. We see normal skull, normal midline. You can see here cavum septum pellucidum. The posterior part of the brain, cerebellum, cisterna magna. Again, now this patient in supine position, and I have limited space for maneuver. It's not good visualization. In this step, I ask my patient, take a seat, please. And now the patient is sitting. We can see all anterior part of the brain, good visualization of frontal sulcation, midline, anterior complex. We can see here olfactory sulcus and closing of sylvian fissures, normal operculation. Midline, my probe above the midline on the sagittal suture. I can see here corpus callosum, massa intermedia, tectum, part of aqueduct, but visualization of the vermis is not good. And here I'm moving my probe on the posterior part of the brain, about the small fontanella, and I can see here clearly vermis, primary, secondary fissure, fourth ventricle, and here I can see good brainstem, pons, tectum, aqueduct. So sitting position help us to do good neurosonography in the cases of the bridge presentation of the fetuses. Here you can see the same patient, three different images of anterior part of the brain, most anteriorly part with the olfactory sutures, anterior complex, and sulcation of the frontal lobe. Little bit posteriorly, we can see here anterior complex without olfactories and good operculization of the temporal lobes. And most posteriorly images on the level of the thalami, and we can see here on the coronary plane closing of the sylvian on the both sides. Now, it's the same patient on the sitting position. We can easily to see temporal lobes, left and right, normal temporal lobes, without any malformation, without cysts. And we can see here occipital coronal view focus on the cerebellum, two hemispheres, different echogenicity of the vermis on the coronary plane, and here focus on posterior sulcations. Now, I want to show you example of two different examinations by transabdominal and transvaginal in the same patient. Now, in almost 30 weeks of the pregnancy, you can see here normal skull, lateral ventricle, midline, cavum septum pellucidum, posterior aspect of the brain, cerebellum, cisterna magna. Now, a patient in supine position. It's not good, not so good visualization of the corpus callosum. Absolutely obscure posterior part. I can't see here vermis, and here vermis not so good visualization of the vermis. And now the patient is sitting, much more clear. I can see corpus callosum, off part of the corpus callosum, massa intermedia, third ventricle, and in the posterior aspect, I can see clear the vermis, pons, and brainstem tectum, aqueduct, tegmentum, and again, pons. On the coronary view, focus on the vermis, two hemispheres, and different echogenicity of the vermis. And here on the coronary plane, focus on hemispheres. And the same patient, in the anterior aspect of the brain, we can see bilateral periventricular pseudocysts here and here. This parasagittal view. As I said before, the patient now on the sitting position. Here we can see coronary plane on the level of the olfactory sulcus with the periventricular pseudocysts. It's not anterior horns. This is a cysts. We can see here olfactories and midline, cingulate on the coronary plane. And little bit posteriorly, we can see here lateral ventricles, anterior horns, fibers of corpus callosum, cingulate on the coronary plane, and operculization of the lateral or sylvian fissures. After 2 weeks or 3 weeks, the patient referred again, and now the fetus was on the head presentation, and now you will see examination of the supine position by TVS 3 weeks later. We can see here absolutely another quality of the examination, much more clear echogenicity, much more clear structure of the brain, Additional finding in this time, I saw LSV. You can see here white spots. This is LSV and area of calcification in thalami. Now we will switch for the technique of the late neurosonography. Always we start from the abdominal examination, axial plane, normal skull, normal midline, Sylvian fissure, distal Sylvian fissure, lateral ventricle, and posterior aspect cerebellum on the axial plane. Now we start transvaginal examination. My right hand with the probe and my left hand, with my left hand, I make maneuver for movements of the head of the baby. Now we can see anterior aspect of the brain. For this examination, I need the position of the baby in the extension to achieve anterior fontanella, because anterior fontanella is largest acoustic window. We can see here clear midline, two hemispheres, initial step of development of the olfactories, anterior complex, corpus callosum, anterior part, and posterior part, parieto-occipital sulcus. On the anterior aspect of the brain, what we can see in this step, 28 weeks of the pregnancy, superior frontal gyrus, middle frontal gyrus, anterior frontal horns, cingulate gyrus, cavum septum pellucidum, and olfactory sulci, olfactory sulcus. In the cases of the lot of fluids around the brain, we can see much more clear sulcation in the frontal lobe, anterior, middle, lower, and olfactory sulcus. Again, my probe close to the brain, on the correct position about the object, about the brain. One more technique, another technique of examination with 3D reconstruction. It's good technique for orientation in the space. Now I do 3D. The best image actually is image A, and the second one, the image B. We can see all part of the brain from the left to the right, the parenchyma, corpus callosum, insulus, and the left and the right side. Why it important to achieve all part of the brain? Because extremely parasagittal areas, it's maybe difficult to achieve, but it's areas with in the cases of CMV, we can see cysts in the temporal lobe. Okay, so it's important to achieve all part of the brain. It's maybe in the 3D reconstruction or in the clip during examination. Temporal cyst in the case of the CMV, and here normal temporal lobe. Now we do scan from the anterior to the posterior part. We can see here a frontal lobe with normal sulcation. Now the baby in 28 weeks of the pregnancy. And to reach posterior part of the brain, I need to put the head of the baby in the flexion position and my probe now above the posterior fontanelle. We can see good visualization of the brainstem, vermis, fourth ventricle, tectum, tegmentum, pons, and in the posteriorly part of the brain, we can see all this as a black spot, is a shadow from the occipital bone. And what I can do for a optimization of visualization posteriorly part, I can changing the position, and this allow us to prevent the shadow. Posteriorly part of the brain, on the coronary plane, we can see a parieto-occipital, so it's the end calcarine. And a foot switch, it's equipment very helpful for our neurosonographic examination. Thank you.
Thank you, dear Michael, for your great presentation. And I know that 1/3 of you guys that have been listening to us have already listened to Michael speaking also in your mother language. And he's really an artist, and he like dissects the brain with the transducer. And you could see some of the challenges and the tips that we can use in order to access the fetal brain, the importance of coordinating 2D with 3D multiplanar imaging, and how we can like obtain the most from our probe. But still there are many things that we can't obtain from our probes. And I think one of the main important fields of contribution and of the extra sequences of MR is in the field of brain damage and acquired lesions. And so we'll have the great opportunity to hear Gregor Kasparian from Austria speaking and dissecting this topic on how can MR really contribute not only early but also in late pregnancy in cases of acquired lesions of the brain. Please, Greg.
again, it is a great pleasure to talk again on another topic here during this neurosonography course. I'm going to touch on the acquired central nervous system lesions, vascular insults, and brain masses. I think this is an ideal topic to show the complementary nature of MRI to neurosonography. Well, I would like to talk in the next couple of minutes about the vascular insults, which are mostly hemorrhages and ischemia. We are going to talk about that. And of course, brain masses. That does not only include brain tumors, but also vascular malformations. So if we talk about a vascular insult, in postnatal medicine, that's a stroke. And the stroke is defined as an acute onset, permanent neurological deficits as a consequence of ischemic or hemorrhagic brain pathologies. This is actually the definition of a stroke. And as you can imagine, that is very hard to translate to prenatal medicine because actually we don't know the onset, and that's our major issue here. We actually do not know exactly the permanent nature of neurological deficits when a ischemic event is happening to the fetal brain. So for fetal or prenatal definitions of stroke, we have to think a little bit differently. We don't know the onset. We don't know really if there are deficits. And we have to deal with the fact that fetal stroke really produces detectable maternal or fetal symptoms. So where could be the role of MRI? I have already mentioned it's ischemic or hemorrhagic, or even both. For this reason, we are seeing an MRI hemorrhagic lesions, ischemic lesions much less frequently, porencephalic clefts, and all the other sequelae, and we are going to talk about them. When we want to talk about them, I want to familiarize you again, and I'm sure most of you are aware of this concept, with the nomenclature of malformation, disruption, deformation. So be aware that we are here not really talking about a malformation where we have abnormal genetic information leading to a structural change or functional deficit. We have actually a normal genetic, basically, disposition, and then something happens, which is a stroke or ischemia or hemorrhage, which then changes further development. Let me give you an example. This is a case at 34 gestational weeks, referred to us because of there was a atresia of the colon, and we thought there is a atretic colon segment. You know, this is mostly pointing towards some also vascular origin of this atretic condition. Now, we also realized in this fetus that there were multiple brain lesions at different sites, and those we would classify as schizencephaly. So your nose schizencephalic clefts are bordered by bony microgyria and are basically clastic defects of the fetal brain. Now, what we also actually came across during looking at our images, we noticed that the mom of this baby already had an MRI in previous years. And that's how her brain looked like. And she was a 34-year-old young woman. And this brain definitely does not look like a brain of a young woman. You see there are defects in this brain. There is a white matter abnormality displayed here very nicely. So this looks like also a vascular leukoencephalopathy, and you should not have that at 34. So what was the origin here? And we noticed in her history, which we did not know up to this point, that she has a history of anti-phospholipid antibody syndrome. Now, we missed something here evidently, and we did not really look closely at the placenta, and we noticed that late but though the placenta was thick, we saw an increased globulation, and also the signals were quite inhomogeneous even for 34 gestational weeks. So what's going on here? So what is going on is probably the condition of fetal vascular malperfusion. Be aware that pathologists have redefined this condition again. So they have actually formed an Amsterdam International Consensus Group, and they agreed on a nomenclature of placental pathologies. And on the fetal side, there were different possibilities, and fetal vascular malperfusion is one term you should basically use with a very distinct definition, which we are going to talk about in a minute. What's going on in antiphospholipid antibody syndrome itself, you see basically there is a deficit of invasion of the trophoblast in the decidual, and for that less cells are basically invading here in the decidual plate, and we have a less mature formation of these spiral arteries, meaning that, of course, there is reduced blood flow from the mother to the fetus. So reduced maternal blood flow as a consequence of this remodeling of the placenta, which is part of this syndrome. But the syndrome also does a couple of different other pathophysiological things. We have coagulation disorder. As said, there is an abnormal formation of the placenta and also death within placental units. But we also, and that explains the high risk of miscarriage, preterm birth, preeclampsia, and fetal growth restriction. And also this explains the formation of thrombi. And sometimes these thrombi, they just occur and disappear. They are transient. You don't always see them later on also at placental pathology, but they may be the reason for some fetal brain ischemic lesions. And this is such an example. This is not a case of an antiphospholipid antibody syndrome, but this was the case of a fetal growth restriction, quite severe with declining Doppler values. If you look at these T2-weighted sequences, you are aware that they look quite normal. You don't realize that there is any kind of change here. Particularly, look here at the frontal area, compare the cortex. You don't see a lesion. You don't see a clear-cut abnormality. And now the question is, this is probably what you see on ultrasound as well in this case. And the question is, what can we add with MRI? And now if you go to an AI tool at ChatGPT, which is Consensus, and just simply ask the question, what is the best method to detect acute and early changes of brain ischemia in fetuses? And you will realize that the answer is very, very clear here. It's diffusion-weighted MRI. Moreover, there was a direct comparison here of the literature to ultrasound, and clearly this shows that DWI, MRI has the highest sensitivity for early infarct detection, higher than CT, of course, but also higher than cranial ultrasound, which has its merits at bedside screening in neonates, but only has a moderate sensitivity for these early infarctions. So from a physical standpoint, if you consider physics, purely MRI has a tool which is the most sensitive in detecting these infarcts. In this case, shows that very well. You see that here we have this diffusion restriction in a otherwise totally structurally normally looking brain. So please use this technology. It helps you in detecting things you cannot see structurally on MRI T2-weighted sequences and or ultrasound. And of course, always image the placenta. In this case, we did that, and we found the thrombus. Usually you don't see these thrombi, as here in a normal placenta, meaning that here a thrombi went to the fetus and as a consequence to the fetal brain, or indirectly it caused malperfusion to the middle cerebral artery and caused this infarct you have just seen. So what is very important to note here, and that's what pathologists realize very well, is that fetal vascular malperfusion is a condition which is, of course, permanent, is caused by thrombi and also necrosis of villi, that you end up with these avascular villi. But these thrombi are not always present, of course. They form, then they disappear. So you will not find all of them during pathological examination, but you may find them when you do imaging, and particularly when you do imaging with MRI. We use this advantage in a cohort of SARS-CoV-2 infected mothers, and we found a quite high incidence of cerebral abnormalities in this subgroup, and most of them were going along with changes to the placenta, and you can read that in this 2023 published study by Patrick Tinas. Let me come back to the original problem we have at prenatal medicine, and that is timing of the insult. We have the problem not to really know when that happened. Rarely, as you have seen, we can encounter a stroke as early as we did with the DWI. Usually we are later because there are no symptoms. So prenatally, the ischemic strokes, the neonatal arterial ischemic strokes, we cannot really see and detect. It's just by chance. Also, the apparently perinatal ischemic strokes, these APIs, they also do not really show signs prenatally. You might see them postnatally in the acute stage, but not prenatal. What we actually can see from all these ischemic lesions is PVI, periventricular venous infarction, and let's dive into that a little bit. So you all know brain hemorrhages are a problem in preterm neonates, but also they can occur in fetuses. And if they are severe, they might compress veins around the ventricle and might lead to venous stasis and venous ischemia, leading as a consequence to these poor encephalic defects of the brain. This is a postnatal example of a PVHI. I'm mentioning that also in the concept of our well-known grading system of brain hemorrhages. You all know the Papille grading system, but there is some problem with this system, and I would like to point it out. It is based on a very old study from 1978, and Papille did a great job in that, but the images she was using were CT images. So this grading is based on neonatal CT images, and you can imagine a lot of things kind of improved in the last years in MRI and ultrasound, and we should rethink this grading system to some extent. One way to do that is the approach used by Bassam to really divide the brain into different lobes and different areas, because they have a different chance to lead to, for instance, motor symptoms. A more complex way is the new classification system, which is still based on the grading system by Papille, but introduced the periventricular hemorrhagic infarction term for grade 4 hemorrhages in venous infarctions ipsilateral to the hemorrhage. And so the parenchymal involvement was mainly associated with this venous infarction, and this term was introduced as basically describing the consequences of a grade 4 hemorrhage. Now, Efrat Hadi and the group of Tali Lamansagi was really working on that in the previous years a lot, and basically put out this paper that there is a need for a new classification system. This is a continuous process, and there are different people working on that. But what they also state is that MRI might have the potential to really anatomically see the extent of the lesion a little bit better and may provide more accurate anatomical localization. Why is this important? This is from neonatal MRI. All these things, all these images you see here are grade 4 hemorrhages. This is a grade 4, but also this is a grade 4. And you can imagine this baby will do totally different functionally from this baby. And we also attributed to that in a neonatal scoring system. And just to point it out, we actually looked at many different brain regions, hippocampus, white matter, cerebellum, different brain regions, looked at how severely they were affected. And you can see a more severely affected baby might have a totally different outcome in terms of Bailey scales after birth than a baby with less involvement of these structures. So this makes a huge difference, and it's worthwhile to include anatomical locations of hemorrhages into your prospective scoring. This is again an example. At 30 weeks, we might see only the tip of the iceberg. In this very same case, you can see here, this little hemorrhage here has been as large as this, what you can see here. This is the initial examination at 25 weeks. So the later examination might be pretending that there was a subtle lesion, but initially these lesions could have been quite big. And in this case, they even led to intrauterine functional compromise. As you can see, one of the extremities is basically used much less infrequent. So there are signs already of a hemiparesis at prenatal stages. FRTD, while working with us, was looking at the use of tractography in particularly the higher grade IVH grade 2, 3, and 4s. And what she found was that if the corticospinal tract are involved by the hemorrhage, there is a 6-time higher chance to have a motor deficit. So you can use tractography as a tool to even further characterize the anatomical involvement of intraventricular hemorrhages. This makes sense and is also contributing to the prediction of motor outcomes. Now, in PVHI, you have this involvement of the periventricular region here, and that might sometimes involve corticospinal tract parts or not. And if you look at this case, it's really hard. Is the corticospinal tract hit by this hemorrhage initially or even at follow-up, or is it spared? And actually, what you see here, this is the side of the hemorrhage, and you see basically that partial involvement of the corticospinal tract is there, so there is definitely a higher chance of having motor symptoms, but there is a still standing part of the corticospinal tract which might be useful for plasticity mechanisms. If you want to know more about DTI and the use of advanced techniques, particularly also placental perfusion techniques, high-end MRI methods, which you cannot cover within some hours of an online course, you really need personal interaction. You need to talk to the people who are doing the one or the other technique at a very high level. And if you want to understand how we can introduce that in the clinical practice, we have a very small meeting. It's only space for 150 participants in Vienna at the 2nd and 3rd of May. Let's go back to the concept of disruption. Disruption you will find in fetuses with large ischemic defects, as in this case here, where there was a middle cerebral artery infarction. And here you can see very nicely the consequence. Adjacent to this infarction, there was polymicrogyria in the neonatal brain. Of course, there was no corticospinal tract detectable prenatally nor postnatally. So polymicrogyria is the reaction of these insights, and it's a classical example of a disruption in this case. Another example of a disruption is the lesion to the cerebellum, which some people might misclassify as Dandy-Walker syndrome. But often if one part of the cerebellar hemisphere is lesioned, and also the vermis is partially involved, it might be the consequence of a hemorrhage. And cerebellar hemorrhages have a very peculiar appearance. They are basically sitting on the surface of the cerebellum because they are underneath the cerebellar PL membrane. So the PL is sitting on top of these hemorrhages, and the hemorrhages are actually occurring in the granular cell zone outside in the cerebellum. So they are basically not spilling into the fourth ventricle many times or into the posterior fossa. That's a pathological specimen, and you can see they're basically sitting within the cerebellum. It's important to know that these changes, these hemorrhages, they disappear quite quickly on ultrasound, within days, as you can see here, and then they leave this hole. And now you have not much proof to say this has been a hemorrhage if you have not the previous or initial images. And here MRI can help because the residuals of hemorrhages can be seen by MRI very, very sensitively. In this case, you see there is a defect. You cannot say anything about the hemorrhage if you're using only T2. If you're using the EPI T2 star image, you find the blood degradation products here. And this was the initial appearance of this subfield cerebellar hemorrhage. And this is Sophie. Despite this was a quite significant lesion initially, she's doing quite well, as you can see, even from a motor standpoint. Now, what we learned from postnatal imaging is that we have a very high sensitivity of MRI in detecting subtle lesions. We have a high sensitivity in detecting the consequences of these hemorrhages, the extent, and this both together can be used in grading systems to optimize our outcome prediction. I want to stress again, please, your MRI sequence protocol is incomplete if you only use T2 weighted images. You have to use T2 star. If you don't use it, you will miss up to 30% of hemorrhages if you only use T2 alone. You might also miss those hemorrhages in Chiari 2. Many of you are probably not aware that up to 30% of all Chiari 2 fetuses have intraventricular hemorrhages detectable on MRI. This is, I think, things which are not known from ultrasound, which just exemplifies the high sensitivity of MRI to these blood degradation products. I already touched on DWI. DWI is sensitive in showing early infarction, but it's also sensitive in showing large amounts of cells. Large amounts of cells are often in tumors, and sometimes you have these cystic tumors where you might consider lymphangioma, but if you do DWI, you suddenly see that within that tumor there is a diffusion-restricted part. There are a lot of cells, and those cells are tumor cells in this case, and these were cells of a teratoma. You see also again another image here at 21 weeks with the diffusion. You see that there was also some abnormal layering here within the brain and also here. So this was a very rare case of a teratoma plus cortical dysplasia. Don't ask me how the pathophysiological combination of both is actually working, but this is what can happen. This brings me to the intracranial masses. So you see that very, very small amount of pediatric brain tumors may even occur prenatally. So this is really a really rare event. Interestingly, this event happens rather late or are detected rather late in pregnancy. Often they are basically happening in fetuses with genetic predisposition syndromes. Most frequently, we find teratoma, but also gliomas like astrocytoma are seen. The term PNET is not active anymore. We are currently talking about medulloblastomas here. So what you find is a macrocephaly. In many cases, they are space occupying, often go along with hydrocephalus, cause hemorrhages. And often when you only do ultrasound, you might misinterpret some features in these tumors. So if you complement MRI, you get a really more complete picture of these lesions. This was a really huge calcified, partly calcified lesion of the brain at 34 gestation week, compressing the rest of the brain. We did also DTI and looked at the corticospinal tract, which were pushed to the other side, also the corpus callosum, extremely pushed away by this tumor. So this tumor was evidently not invading the brain, it was pushing the brain away, and that is more typical for a teratoma than for a glioma, which is actually sitting within the brain, as you can see here in the brain stem, and actually destroying the tracts because it's infiltrating those tracts. Sometimes you can even do prenatal or try to do spectroscopy with a very high choline peak of these tumors, and on tractography, you see that the tumor is basically destroying these tracts at the site of invasion right here. Now, finally, I want to stress one thing which I found to be a very, very common mistake and often overlooked or insufficiently characterized. You see here a case at 30+3 with a huge mass intracranially. You might ask yourself, what is this? And always, in fetuses, always consider also vascular malformations, because if you do the MRI, it's very clear. You see that this mass is actually sitting within or involving the straight sinus and the sagittal sinus. There is a thrombus within that, which is T1 hyperintense and T2 also slightly hyperintense, mostly diffusion restricted. And if you look at the coronal and sagittal planes, you realize how this lesion is pushing away the brain and also compressing the posterior fossa and the cerebellum. Fortunately, up to this moment, there is not much of ventriculomegaly going on with it, so no real obstruction, despite the aqueduct is quite basically stenotic due to this lesion. So you might think, oh my God, this is a catastrophe. First, you have to do the correct diagnosis, and the correct diagnosis here is a dural sinus malformation. And second, you might think these lesions are catastrophes. And I have to tell you, they are not always catastrophes. They often, to the opposite, they are even more frequently leading to kind of good outcomes. I show you the postnatal course. We did not do anything to this baby. Baby was delivered at term. This is the postnatal imaging, and you could see this dural sinus malformation was growing smaller. So it was getting smaller, less compression on the cerebellum and on the aqueduct. And the outcome was really good. The baby is doing absolutely well right now. If you go into the literature, you will find that many of these grade 1 dural sinus malformations, and these are the ones with less feeding vessels and low flow, and often those with the thrombus, they are doing very well, and a little outcome is very rare in this group. However, if you have many feeders, and particularly, and those are the grade 4 lesions, if you can detect a brain lesion by MRI, hemorrhage or a clastic lesion, the outcome is really poor. You can, in addition to the structural images, also use EPIT to start dynamically. If there is a high flow, you see a bright signal within the vascular malformation. If there is low flow, this is static blood, and it's not causing a bright signal within that malformation, indicating that there are not a lot of feeders here. And sometimes you have these examples of vein of Galen aneurysmal malformations, and with more newer sequences, multi-vein, propeller, or blade, you can identify how these anastomoses are forming here between both the posterior cerebral artery and the choroidal arteries to the vein of Galen aneurysmal malformation. Of course, we can do that nicely with 3D ultrasound as well, but I feel that MRI is very nice and complementary in guiding also our interventional neuroradiologists postnatally in the treatment of these lesions, and this is successful very frequently. If you can embolize these anastomoses, the vascular malformation basically goes away. And that brings me to the end. I hope that I could show that MRI and ultrasound are very nice complementary tools in prenatal diagnosis of vascular insults and brain masses. They combined, they provide a maximum of information which you can use also for prognosis and maybe also for planning your treatment. And finally, you know, the month of May is a very nice month, and particularly in Vienna, this is a very nice month. And on the 2nd and 3rd of May, we will stay right in here in this building. This is the building of medical history in Vienna, which opened 2 years ago, and we will have our meeting with these topics. So I would be happy if I can see you in person in Vienna. Thanks a lot. Okay, let's continue with this exciting topic. We're still going through our journey of the 3rd trimester brain. And now we're looking at the particular challenge. That challenge is that sometimes you will find mild abnormalities in the 3rd trimester. And the first question, of course, is, are they mild or not? How can you detect them? Well, you will get the answers now from Dr. Antonio Mendez from Mexico. We're looking forward to Dr. Mendez's lecture. Thank you.
Hello, everybody. I am Dr. Antonio Mendez, a fetal doctor from Mexico. Nice to meet you. The topic that I have to talk is mild CNS findings and 3rd trimester ultrasound, how to deal with them. First of all, I want to thank Dr. Karina Crackten, Professor Gustavo, for the invitation to participate in this symposium of fetal brain, which is incredible. Thank you very much for your invitation. It should be noted that I have no conflict of interest to give this talk. The first thing we have to do is define what is mild in 3rd trimester. There are problems in the central nervous system that we consider to be mild. For example, ventriculomegaly. For example, mild ventriculomegaly. For example, choroid plexus cyst. For example, subependymal cyst. Sometimes. For example, megacisternal magna of 11 millimeters. For example. But in the long run, they lead to fetal death or neurodevelopment delay. Therefore, the first message is that if mild findings are found, it must be reviewed by an expert in neurosonography to rule out more serious problem. And this is my first message, and it's very important. If you find something mild, refer to an expert in neurosonography to rule out more serious problems. The second thing we have to do is know what is the best time to perform the third trimester ultrasound. In 2024, the ISWOG published the clinical practice guidelines for performing third trimester ultrasound and give us the following recommendation. The timing of the third trimester scan, if indicated between 32 and 36 weeks, should be decided based on individual maternal and fetal characteristics, the risk level of the pregnancy, and local objectives and resources. Also, this guideline shows us that the most common fetal anomalies diagnosed in third trimester scan are urogenital in 55% of the cases, CNS in anomalies in 80% of the cases, and cardiac anomalies in 40% of the cases. Maybe the screening for CNS anomalies is better at 32 weeks of pregnancy for technical reasons, maybe, and growth screening it's better in 36 weeks of pregnancy, as Kypros Nicolaides showed us recently. This study in UK. They performed the third trimester scan at 36 weeks of pregnancy. In my country, for example, we can perform at 32 weeks of pregnancy and 36 weeks of pregnancy. Professor Gustavo Mallinger 20 years ago showed us that a normal second trimester ultrasound does not exclude intracranial structural pathology. And there are cases of late diagnosis, for example, hydrocephalus or ventriculomegaly, posterior fossa anomaly, corpus callosum anomaly, signs of infection, intrauterine infection, CMV infection, for example, cerebral cyst, hemorrhage, macrocephaly, microcephaly, migration disorder, and one case of brain atrophy. This study was very important. In a tertiary public hospital in Italy, in Genoa, in Italy, Professor Dario Palladini has shown us this graphic. It's a very beautiful graphic to show, for example, the blue bar problems in first semester, the pink bar problems in second trimester, yellow bar problems on third trimester, and in gray bar problems in neonates. We need to focus on yellow bar. For example, in yellow bar in third trimester, some cases are ventriculomegaly, some cases are cerebellar hypoplasia, some cases of malformation of cortical disorders, some cases of microcephaly, vein galen aneurysm, arteriovenous malformations, hemorrhage, and tumors. You have to remember this graphic always. And we have to do the third trimester scan, and to perform, we have to be able to perform a neurosonography on third trimester. But neurosonography on third trimester is difficult. It's not the same that second trimester. Some of the disadvantages to perform a neurosonography on third trimester are difficult anatomical examination, there are more things than in second trimester. There is no consensus on when to do it. And normal parameters can change between second and third trimester. And there is no legal elective termination of pregnancy, at least in my country. I know that in some countries, like in Israel, there is a legal elective termination, but in my country, it's not possible that. In Colombia, there is legal elective termination, for example, but in Mexico, no. And there are some advantages. This advantage could be assessment of cortical development, follow-up to assess progression, detection of late onset malformation, like I said, principal, urogenital, CNS malformation, and cardiac anomalies, and decision of birth planning and long-term follow-up. And this is very important. And this last point saves lives. Below, I want to present some clinical cases that occur to us in daily life and that help us a lot to deal with brain problems. This is my experience here in Mexico with some cases on third trimester. I want to show you these cases, not all, but some of the most representative cases in this topic. Let's go to the case 1. It's a patient who is referred at 32 weeks of pregnancy with the diagnosis of ventriculomegaly with a normal first and second trimester ultrasound. The first step is to perform an abdominal ultrasound, axial cuts, to describe the anatomy. What we see in this video is bilateral ventriculomegaly, dilation of posterior horns, anterior horns, and dilation of third ventricle. The next thing we have to ask ourselves is why the fetus is presented ventriculomegaly on third trimester. What is the reason? You know that ventriculomegaly, it's a finding, it's not a diagnosis. So we have to think what is the reason. Some of the fetal experts we have in the audience have probably seen the lesion inside the brain in this video, this axial view here. But the second step consists of performing a transvaginal neurosonography to make coronal and sagittal cuts. What we observe in this video is that the same lesion located in the left hemisphere, in the left occipital temporal lobe, and which is probably compressing the Sylvian aqueduct or the midbrain. The next step is to request another study. If we apply color Doppler, we can see here some vessels inside this echogenic lesion. The fetal brain MRI delimit perfectly the same lesion in the same place. At the end, the MRI told us that there is an obstruction of the Sylvian aqueduct close to the fourth ventricle caused by a heterogeneous lesion on the medial surface of the left occipital temporal lobe of 14 millimeters in diameter. In the follow-up, in the week 34, the diagnosis was on week 32. 2 weeks later, the echogenic lesion is bigger. Okay, that's an important finding. The head here is, there are ventriculomegaly, bilateral ventriculomegaly, but the head circumference is in percentile 2. And that is not checked for the brain. We can see here Ventriculomegaly, increase a little bit. Third ventricle, the same. Anterior horns, increase a little bit. This is a tomographic ultrasound imaging. We can see here a dilation of the ventricle, but even adhesion here. And this is the echogenic lesion is bigger than 2 weeks ago. And this is a very important finding. At 37 weeks of pregnancy, decide to do a C-section because the baby will have a fetal growth restriction, and the baby was born with a normal Apgar, normal breath. After 3 days of birth, neurosurgeon performed a neuroendoscopy. You can see here the tumor here in neuroendoscopy. He performed a biopsy, and histopathological result is next. A typical teratoid rhabdoid tumor. It's a common in fetus tumor. It's rare, but it's a common in fetus. We can see more tumors in fetus than in newborns, for example. But this is a bad prognosis. If you diagnose this tumor, normally the baby dies in the next year, in the next months. And this was the case of this baby. The second case is a patient referred in third trimester of pregnancy with apparently healthy baby in whom we observe an increased head circumference and cystic image in the back of the skull. In the video, here, in the video, we see a homogeneous echogenic lesion inside the cystic image. To know if this image corresponds to a supratentorial or infratentorial level, the coronal sections are very useful, as you can see in this video. And this image is infratentorial. The sagittal section helps us because it also allows us to delimit the lesion. In this case, we continue to observe an infratentorial image with significant compression of the brain stem, an elevation of the dentorium, and inside a fluid in the interior of this cyst. The diagnosis at this moment, maybe a lot of you have the diagnosis too, was a thrombosis of the torcular aerophilus, which has a good prognosis in 80% of the cases, but in 20% of the cases, a certain delays in neurodevelopment may occur. And in this case, the baby died inside the uterus. We don't know why, but maybe it was the compression of this fluid, of this sinus compression of the brain stem. We don't know why. The next case, the third case, is a patient who refers to 28 weeks of pregnancy to her first ultrasound. As you can see in this axial section, there is nothing abnormal is observed. The face can be seen perfectly because there is a normal amniotic fluid. And later we go down to the heart. What we observe is a normal four-chamber image with a slight pleural effusion in one side. The abdomen shows a echogenic bowel, and hepatic congestion is also observed. When we go to the image to the skull, what we observe is an increased superior sagittal sinus with a turbulent flow inside, a heterogeneous brain parenchyma, absence of the vein of Galen and straight sinus and torcula, and a false dilated sinus here. This is a false sinus, a false sinus, drained to the superior sagittal sinus. And this baby has no torcula, vein of Galen, straight sinus is absent. And the next step, the diagnosis at this moment is Bain-Galen malformation, one of the variants of Bain-Galen malformation. The next step is to perform a fetal echocardiography, because in these cases we can observe a pseudo-aortic coarctation, as I show you here. And this is for the brain, for the blood inside the brain. It's a sequestration inside the brain, and the heart fail sometimes, and the baby sometimes die. And this is a pseudo-aortic coarctation. Days later, magnetic resonance imaging was performed, observing a bilateral pleural effusion, ascites fluid, and probably interventricular hemorrhage, bilateral. This baby eventually died, probably from heart failure due to fetal sequestration inside the brain. This is what happens, no? There is a sequestration here, and the heart fail at the end. Some babies die. There is a treatment now, but in selected cases. The case number four is a patient reference at 32 weeks of pregnancy with diagnosis of ventriculomegaly, probably secondary to hemorrhage. As we can see in this video, in this sagittal section, an echogenic image is observed whose origin is not known exactly on this imaging. In the parasagittal images, it is observed that the origin of this echogenic lesion comes from the choroid plexus, and the differential diagnosis is papilloma of plexus choroid versus carcinoma. At birth, a diagnosis of choroidal plexus papilloma was confirmed, and laser neuroablation of the plexus papilloma was performed, and the baby progressed perfectly and is currently stable. As you see in this publication in 2011, it's the same image that I showed you before, and accounts in 42% of cerebral tumors. Fortunately, 96% of the cases are benign, but 61% of cases are carcinomas. The following case is a patient who refers at 29 weeks of gestation with diagnosis of ventriculomegaly plus cerebellar hypoplasia. Amniocentesis was performed with a Ray study, which came out normal, and a sample was saved to perform maybe an exome. Magnetic resonance imaging was performed, showing the same diagnosis of ventriculomegaly plus cerebellar hypoplasia. As you can see in these images, the only thing we see is a decrease in the transverse diameter of the cerebellum and mild and lateral ventriculomegaly. And the foreventricle looks normal, and it's a very important finding in this case. Transvaginal neurosonography is performed observing the cerebellum with these characteristics, with the folia attached to each other, and in the sagittal section, 4 ventricles, perhaps enlarged and or round. The ultrasound phenotypic diagnosis at this moment is rhombencephalosynapsis. At this moment, however, the clinic exomas study obtained a genetic mutation that is the following. Why would talk rhombencephalosynapsis? Because this is the sign of rhombencephalosynapsis, is the Donald Duck sign. Folia are attached one each other. And this is the genetic results. It's a heterozygotic variant of the gene CYP290 associated to Joubert syndrome, Bardet-Biedl syndrome, etc. But the sonographic molar tooth sign in the diagnosis of Joubert syndrome is very, very characteristic. And the gene here is the same that the baby was present. In case of rhombencephalosynapsis, it's a middle brain malformation characterized by missing cerebellar vermis with apparent fusion of the cerebral hemisphere. Rhombencephalosynapsis can be seen in isolation or together with other central nervous system and extra central nervous system malformation. The most common is syndrome Gomez-Lopez-Hernandez with alopecia. The baby underwent a perfectly normal cesarean section, normal Abar score. A month later, normal movements were observed, and today he's perfectly fine. Subsequently, the genetic study was performed directly on the newborn, and the result was normal. The genetic study was carried out on the parents, observing that the heterozygous mutation is present in the mother, which tell us that maternal contamination of the sample was occurred. And this is a real-life case. The mother has the mutation, not the baby, but the baby has this fusion of folia in the cerebellum and cerebellar hypoplasia. But at this moment, the baby is normal, but maybe in next years, the baby probably has a neurodevelopment delay. Maybe. We don't know. Case number 6 is referred because an echogenic image is observed in the cerebellum in one of the hemispheres, as we can see in this coronal section and in this sagittal section. In the axial section, the lesion is perfectly delimited, and with the color Doppler, an increase in the vasculature is observed. An MRI is performed confirming hemorrhage, and genetic study was performed, surprisingly, shows a mutation of dominant hereditary pattern. Mutation of this gene COL4A that is associated with other vascular brain problems and is dominant. So the next generation will present, and maybe the parents has one parent has this mutation. Interesting case. The case number 7 is a patient referred with a diagnosis of mild ventriculomegaly at 34 weeks of pregnancy, the first time that I see this patient, with a history of 4 pregnancy, 1 live birth, and 2 stillbirths. The examination shows cerebellar hypoplasia, decreased head circumference, periventricular heterotopia, and ventriculomegaly and severe ventriculomegaly of the proximal ventricle and dilatation of the third ventricle, as you can see here. normal phase. In the coronal and sagittal view, the diagnosis was agenesis of corpus callosum, an abnormal sulcation, and an abnormal brain parenchyma. This case is not mild, and the prognosis is poor. It is referred as a mild finding, but is not mild finding. There is definitely a pattern of inheritance, and genetic study is necessary in this case for malformation of cortical development. The next patient, the following case, is a patient referred with a fetus with macrosomia and suspected gestational diabetes. Significant polydramnus is also observed. Neurosonography is performed, observing a subtle increase in the subarachnoid space and enlarged cavum septum pellucidum, as you can see here, in 8.4 millimeters at 39 weeks of pregnancy. And gestational diabetes was ruled out, and a study was done after birth, diagnosing Soto syndrome, characteristic of fetuses with macrocephaly and overgrowth, with certain characteristics in facial findings. This was a very interesting case in which the principal, you can see here, exchange different view of this brain, and the count of septum pellucidum is above the 95 percentile at 40 weeks of pregnancy. So this is a Soto syndrome. Very interesting. Confirmed for a exome sequence SND1 mutation. The last case I'm going to present is very interesting. Let's look at a patient referred with a diagnosis of multiple intramuscular ventricular septal defects. Later, a neurosonography is performed as in all patients with heart disease. It is one of the indications. An absence of the olfactory groups is observed, which leads us to the diagnosis of Church syndrome. The olfactory groups should be assessed from week 28, and it is characteristic phenotypic finding. In future publication, you will see this association in White Journal. Church syndromes is an acronym. C is from coloboma, H from heart defect, A from atresia aquana, R from retarded growth and development, G of genital hypoplasia, E of ear anomalies and deafness. Mutation in exome sequence is found in 75% of cases. This CHD7 mutation is not common. At the end, and conclusions are: you suspected a brain abnormality in the third trimester, refer to a neurosonography expert. That was the first measure. Mild finding can result in a serious pathology, as I show you in the last cases. Statistics help, but in medicine, anything can happen. Prepare to assess the fetal brain on the third trimester. It's difficult to perform neurosonography in third trimester, but it's possible. And thank you very much for your attention. I hope that this will be useful for you. Thank you very much.
Thank you, Antonio, for a great presentation. It's an honor for me to have you here and to get your voice also into other places we have known and worked together. And I'm very happy to have heard your experience in Mexico. It's also an opportunity to present our next speaker, Dr. Rachna Gupta from India. Rachna is a great friend, also has worked with us here in Tel Aviv in the fellowship program. So as we have repeatedly said throughout the course, we are here among friends, and having you the opportunity to hear new voices and new experiences in our field. So let's go for the questions from the audience, and the first from Shetal, radiologist from India, and she asked Professor Kasprian, do you use DWI in dural sinus malformation to look for diffusion restriction to help prognostication?
Very good question, Shetal. Yeah, we use DWI. It's a part of our standard protocol. So I would consider DWI as well as T2 star both very important in vascular malformations in general. You know that parenchymal damage is one of the crucial prognostic factors in those conditions. We have seen cases where the normal T2 weighted sequences structurally were basically looking normal, and only with DWI and T2 star we could pick up parenchymal lesions, which were then also representative and determining the prognosis in those cases. In the dural sinus malformation, DWI has another very interesting characteristic. If you have a thrombus within this enlarged sinus, the thrombus is on T1 weighted images bright, on T2 star, of course, it's dark, and on DWI, it shows diffusion restriction. So these are the very typical characteristics of thrombi on MRI. And you can pick up the thrombus, and the thrombus also, we believe, tells us a little bit about the prognosis as well, because those dural sinus malformations with a thrombus have a lower flow. And if you have a lower flow, there are less anastomosis and less abnormal AV connections, and thus the prognosis is a little better.
Thank you, Gregor. And indeed, I think is one of the greatest contributions of MR, and as you said, like how the MR complement ultrasound in the investigation, and is, in our experience, one of the reasons that we do early MR, also in cases of malformation, whenever we suspect on the possibility of an insult or a damage in the brain, and we know the capabilities of the MR for the differential diagnosis of the lesion that we are seeing. And I wanted to ask you, so what's the gap that you think we can detect blood products? So like if we had a bleeding 6 weeks ago, what are the odds that we are going to find these blood products? And the opposite way, so what would be the gap to see in tractography the consequences of a damage in order to prognosticate the motor function?
Yeah, very good question. So on the basically follow up, the gap in hemorrhages are seen at the very first moment very well on MRI, and then they show a very typical timeline. And this timeline is known very well on adult and postnatal MR cases. We know that there is a sequence of signal changes a hemorrhage undergoes, and from that we can even basically tell something about the time point of the initial hemorrhage. Problem in fetal is that we are looking at fetal hemoglobin, and this is different from adult and postnatal. So the timeline there seems to be different from postnatal. To my impression, everything goes very fast in fetal. So hemorrhages can be initially quite huge, and then they can be basically resorbed quite fast. But still, the T2 star detects the hemosiderin, these dark changes on the T2 star, for quite a long time. So they are there at the very first moment, and then they stay there for a very long time, for weeks and months. And that's the good property of the T2 star sequence. And that's the reason why I'm basically mentioning it, and why it's also included in the minimum protocol as recommended by ISOC. In terms of vascular malformations, the question when to image is also very interesting. As you know, these are very dynamic lesions. They are hemodynamic dependent lesions, so these things can change. The hemodynamics can change. So I think it's difficult to put up a good guideline and reference in these intervals you should image. With ultrasound, that's easy. You can do that anytime. With MRI, as soon as you have the impression on ultrasound, something changes. It would be also wise to do the MRI to just have a look at the parenchyma and basically see if there is a so-called melting brain condition, where the brain is basically taking injury from the hemodynamics which changed in those malformations.
Thank you. And my next question will go to Rachna about the ultrasound, also in screening and the characterization of the lesions in the third trimester. And I know, like, there in India, you have, from the physiological point of view, many times stature that it's lower than in other places, and also had measurements that are different. So how do you deal with your references and your daily practice in the third trimester fetus, in which they manifest more the familial traits?
Thank you, Karina, first of all, for having me here, and Professor Caspian. So as far as ultrasound, we know we have a lot of ethnic variations in the third trimester, and we see a lot of our head circumferences, they show a falling trend towards the end. So later we have the scans in the third trimester, say closer to 37, 38 weeks. We definitely have lower head circumferences. And we don't have any good local charts to refer to. We are still using Hadlock or Chervenak to calculate the centiles or the standard deviations. But we also look at the parental head circumferences and see if they have a large head circumference or an average or lower than average. And this, along with that, the anatomy, the neuroanatomy, apart from the circumference, if we are seeing anything different in the brain as what we expect. So all these things, the anatomy, the rest of the growth of the fetus, the parental head circumferences, any history of fever in the pregnancy, all these we take into account as a whole, and the experience that yes, our head circumferences tend to fall towards the third trimester. Accordingly, we counsel the patient about the prognosis. And it is not very common to have the ultrasounds at 37, 38 weeks. Most of our scans, the last scans, are being done between 34 to 36 weeks. At that gestational age, we are still okay in our references, like the head circumference is not too small. We face more of a problem closer to 38 weeks.
Okay, and in the same topic, a question for you too. So when do you send the parents for an assessment? So Rachna, you from the when you indicate imaging the parents, and Gregor, your experience with what we call the MRI trio. So we have spoken about genetics. So when do we include the imaging the parents as part of our investigation? We start with Rashna.
So, like if I give an example, I had a case where father had polydactyly, post-axial polydactyly in the hands and pre as well as post-axial polydactyly in the feet. Similar phenotype was seen also in the fetus, but we also observed corpus callosal partial agenesis in the fetus. And here it was very strong indication for me to image the father, whether he also has any corpus callosal abnormality. So when you have an overlapping phenotype or a history of intellectual delay in one of the parents or history of epilepsy, that gives me a very strong indication to image the parents.
Greg.
Yeah, actually, what Rashna said is also applicable to the trio imaging approach. So there are two ways to approach it. First, we know the gene and we know basically the genetic abnormality and the mode of inheritance, and basically calculate the risk for the parents. And of course, we would ask for brain imaging in those as well. This has the disadvantage that they have to come again into to the MRI and have another MRI appointment for themselves. The other thing is that when you're having a field MR, you can do easily both. You just have to change the coil from an abdominal coil to a head coil, and then you just go for brain imaging. Is usually one sequence for structural abnormalities. You can check the corpus callosum, the main structures, posterior fossa, just structurally, easily with one 4 to 5 minute sequence. So that's basically easy, but I think it's not, I mean, it's too much if you do it in all of the cases. You could also handle it individually. So if you see a malformation in the fetus, you talk to the parents right afterwards, and you can, if you have time, propose to have a 5 minutes additional sequence. And that's what we very frequently are doing in the setting Rashna was describing.
Sometimes also here in Israel, we do as part of segregation studies. So if we have an autosomal dominant inheritance, and then we want to try what would be to understand what would be the expression in other family members, a part of the parents. So then we broaden up. One good example would be the COL4A1 and 2 variants, and we have several examples of that like the patient did an amniocentesis for her request or because of her age, and then we have discovered variant in these genes, but the parent, the carrier parent is fine. Then we check other family members to see what would be the expression of the variant in the family. Although we know that especially in these variants, that can be the next case that will bleed without explanation, but many times it would help us to counsel these difficult cases, because if we start from a finding, so whenever we already have the hemorrhage is a little different, but sometimes it's also an accidental finding, and then we need to deal with all the consequences. So in our experience also we broaden it up even more than the parents. But from the perspective, I think from the corpus callosum would be in our practice the most frequent cause of sending parents for MR in order to check if we have callosal correspondence in the family. Last week we just had a case of Noonan syndrome, and the fetus was investigated for short and thin corpus callosum, and also had a cardiac rhythm abnormality that resolved throughout pregnancy. And then at 35 weeks, we discovered that it was a Noonan syndrome inherited from the father. And then we had a parental imaging. So we use it as a tool for late investigation, and I think it could it's very hard to compare the phenotype from the early pregnancy to the parent, but the third trimester phenotype would be more comparable, and I think we could recommend this practice in many cases. So as far we have gone far from our timeline, we're going to end the discussion, and thank you for your participation, and we are going to continue with the next session about the head size. Does it matter? Macro and microcephaly, and Rachna will start speaking about how to investigate the small heads. Rachna is from Sonipat in India and also from Apollo in New Delhi. And I don't know, Tatiana, if we start straight ahead or if we have a couple of minutes interval, but this will be our next. Okay, so we have a couple of minutes break and then we are going to be back. Thank you very much, everyone.
Hello everyone, I'm Dr. Rachna Gupta from India, and I'm going to talk about how to investigate the small head 2 or more standard deviations below the mean. I'm thankful to the organizers of this conference and the chairpersons Dr. Karina Kraden-Heratz and Professor Gregor Kerspren for giving me the opportunity to present here. I have no conflict of interest to declare. Let's begin with the definition of microcephaly. It is interesting to know that the postnatal microcephaly is defined as head circumference 2 standard deviations below mean, whereas prenatally it is defined as 3 standard deviations below mean. Even then, the diagnosis of microcephaly per se does not always correlate with the neurodevelopmental outcomes. And even with 3 ST below mean, the diagnosis of prenatal microcephaly lacks the specificity or the positive predictive value for microcephaly at birth. And we will see in the presentation why is this so and how we can improve it. It is also important to know why microcephaly, the pathological microcephaly happens. And the primary microcephaly will usually happen in the very early embryonic period when the neurons are proliferating. If there is less neuronal proliferation or increased apoptosis, then the head will be measuring small. And if there is a problem with the neuronal migration, which happens in the second trimester, or there is a problem with the post-migration neuronal development or the cortical organization, or because of the fetal infections, then these cases are going to present late. Most of the cases of microcephaly, they present late in the pregnancy, or they can present even postnatally. It is important to standardize the measurement of the head circumference, and we need to be very specific in the plane of the measurement for the head circumference. So let's just revise these points. The head should be symmetrical. Both the hemispheres should be roughly equal across the midline. And in the anterior part, you should see the frontal horns and the cavum septum pellucidum. You see the forks anteriorly between the two hemispheres. Then you see the thalami. And posteriorly, again, you see the forks and some part of the lateral ventricles. Also important to remember this area, which is known as the Embeke cistern. So you see a triangular-like shape of the meninges here, which is also one of the landmarks to measure the head circumference, to make sure that you're measuring at the base of the head. Now, we have different methods described in the literature to measure the head circumference. You can use either 2 dimensions method, measuring the biparietal diameter and the occipitofrontal diameter, and then use a formula to calculate the head circumference, or you can use an ellipse to measure the head circumference. The same fetus at the same setting, measured with 2 measurements, 2 different methods, gives us different measurements. So using the ellipse, it's about 279, and whereas using the 2 diameters, it is 277 millimeters. So by the fact of using different methods to measure HC, we can have different measurements. Also, some literature is also tells us to measure the head circumference at transthalamic plane, whereas there are other studies using the transventricular plane. So this brings in the ambiguity of measurement of the head circumference, and hence this excuse. Also, we need to remember that there is a growth trend. So there may be a normal head circumference in the second trimester, but a small or microcephalic head as the gestational age advances. So we need to start thinking about the causes or start the workup at 2 standard deviations below mean, even though the definition is described as 3 standard deviations below mean. But you need to start thinking about whether this head is going to develop further small, or is it going to develop pathological microcephaly later on. Another thing we see that in this picture shown is the prenatal head circumference, the postnatal head circumference measured on the same day, just before delivery. And the prenatal HC measures 32 centimeters, whereas the postnatal is 34 centimeters. And what is the reason behind this? The prenatal HC measures mainly the bony skull, and the postnatal includes the muscle and the skin here as well. So that brings in the discrepancy of the measurements. Also, when we are looking at the prenatal head circumference, we are usually not taking into account the gender or the ethnicity, but the postnatal, it is usually you have the population-specific graphs or the gender-specific graphs, and the sex scores are taking into account the gender and ethnicity. So we have, as we discussed before, we have different studies giving us different mean and the standard deviation, and they have much more variation towards the date of gestation. Also, the plane of the measurement of the postnatal HC is not strictly the same as that for the prenatal HC. So it is slightly different, and we will see how to measure the postnatal HC in the next few slides. And let's look at this study by Professor Lebowitz and Dr. Karina Heras, Professor Malinger. In 2016, they looked at 42 fetuses which measured 3 standard deviations below mean as per Cherbonak's study. But postnatally, the microcephaly was confirmed at birth only in 24 cases. So that gives a positive predictive value of about 57%. They also looked at 2 other growth charts, the intergrowth by Papichiotchi et al. And one Israeli study. And they saw the positive predictive value was maximum with the Israeli study, which was about 67%. However, there was no statistical difference in any of these positive predictive values. So one can use either, and we know that using just by the hex circumference measuring 3 standard deviation below mean, we are going to predict only about 60% as true microcephaly, and 40% will be falsely labeled as microcephalic prenatally. They also looked at the criteria that they could use to improve the diagnosis of microcephaly, and they saw if there was an association of fetal growth restriction below 3rd centile or structural abnormalities, then you improve the positive predictive value to about 70%. If there is also a history of familial microcephaly, or the head circumference measures too small, that is 4 standard deviation below the mean, the positive predictive value approaches almost 100%. Another fact that was studied by the same group was that many cases which measure the HC measure small, it may be because of the vertical elongation, something called as molding, where because of the compression or the uterine factors, the head is elongated vertically and the circumference measures small. So they thought of including a new diameter called as foramen to cranium distance to measure the vertical dimension as well. So for this measurement, a multiplanar approach is used, and you have the sagittal plane with the genu and the splenium of the corpus callosum at the same level. And in this plane, a line is drawn from the lower edge of the clivus to the lower edge of the occipital bone. And from the center of this point line, from along the posterior border of the brainstem, a vertical line is drawn to the inner border of the cranium. And this distance is known as foramen to cranium distance. And they found that if they had, along with a small head, also a small foramen to cranium distance, that means you are more likely to be dealing with the true microcephaly. If you have a long foramen to cranium distance within 2 standard deviations of the mean, then you're less likely to be dealing with the microcephaly. And they have given an Excel in this paper, which is supporting information, can be used to calculate the Z scores for the head circumference and the foramen to cranium distance. So this is an additional parameter which can be used in the cases of HC measuring below 2 or 3 standard deviation. So coming to the workup of HC to ST below mean, the first and the most important step is to confirm the gestational age. And the best parameters that we have is the CRL in the first trimester, crown rump length, or the conception date in the infertility treated patients. It's also important to look at the head circumference of the parents or the siblings and how we measure the head circumference. We use a non-elastic tape which cannot be stretched, and you go 2 centimeters above the glabella, and behind you go to the most prominent part on the occiput and behind the ears. You always overlap the endpoints of the measuring tape to make sure that you are not under or over measuring. And why is this important? If you have a fetus with a small head, also the parents and siblings have a small head, but the neurodevelopment outcome for those relatives is normal, then you think that this fetus is more likely to have a better outcome, although you're still going to watch the pregnancy closely for the further growth of the head circumference associated findings. But this is something we always need to look at if there is a familial microcephaly. And if the relatives have a good neurodevelopmental outcome, then you think favorable prognosis. But if the relatives have also a neurodevelopmental delay, the sibling has a neurodevelopmental delay and a small head, then you think of a recurrence of the cause, which could be genetic. So another step is to measure the foramen to cranium distance, as we already discussed, and calculate the Z scores for the head circumference and foramen to cranium distance and decide whether you are dealing with a truly small head or not. So you have to take a detailed history for familial microcephaly, any neurodevelopmental delay in the family, detailed anatomy survey, biometry of the whole fetus, a detailed neurosonogram, infection serology for CMV, cytomegalovirus, and Zika, if that is endemic in the population. Now, if we have association of the structural findings, we will offer amniocentesis for chromosomal and genetic abnormalities. And depending upon the serology, infection serology, PCR for cytomegalovirus or Zika will be done at the same time. If you don't have any structural abnormalities, but the fetus is small, evaluate for the Doppler and the placenta. However, even in the setting of uteroplacental insufficiency, we cannot always rule out infection or genetic causes because about 20% cases of FGR will have some genetic cause, and hence amniocentesis needs to be discussed there as well. But you need to also evaluate the placenta and manage for the fetal growth restriction as per protocol. And if we have affected family members, then we also simultaneously need to work up the family members by MRI and genetic investigations of the affected members. And for the fetus that we have in question, we also consider fetal MRI depending upon the associated findings, suspicion of the genetic abnormality, gestational age, and availability of the technique. If we don't have any associated structural abnormality, no growth restriction, no family history, and you are between 2 to 3 standard deviations below mean, then it is recommended to follow up by ultrasound every 3 to 4 weeks, followed by fetal MRI at 32 to 34 weeks. If the fetus is already 3 standard deviations below mean, it is good to investigate for the genetic causes and offer amniocentesis, even if there is no association with the structural abnormality or growth restriction. So let's summarize what we have already discussed. You have already a head circumference below 2 standard deviations below mean, and you have confirmed the gestational age, and you took the history, measured the head circumference of the parents, done a detailed anatomy survey, neurosonogram, infection screening, measured the foramen magnum to cranium distance. Now, if we have associated findings on the scan, and the associated finding is only fetal growth restriction, we look at the Doppler, and if we have abnormal Doppler findings, we will follow up as per the Doppler protocol, but also discuss the genetic workup. If you have associated structural findings with or without growth restriction, you will straight away go to the genetic workup if there is any structural finding associated with a small head, and also the infection screening. And if you have a positive family history, then exome sequencing should come as the first line step instead of chromosomal analysis. Now, if you don't have anything on the ultrasound, but there is a family history of developmental delay, then you have to also work up for the affected family members at the same time offer the genetic testing. Now, you don't have any structural findings, no family history, and the head circumference measures between 2 to 3 standard deviation, then we need a serial HC measurement, a serial follow-up by the neurosonogram, and review of the anatomy every 2 to 3 weeks with plotting of the growth trend on the reference charts, and offer MRI at 31 to 32 weeks. Let's look at these application of these steps according to the case. So here we have a second gravida patient with previous healthy child, and she's 35 years and non-consanguineous marriage with a low risk on the first trimester screening. In the second trimester, on the routine anomaly scan, bilateral ventriculomegaly is noted, which is measured within the range of 10 to 11 millimeters. And the cavum septum pellucidum was poorly visualized, and she was referred with these findings. So at 19 plus 1 weeks, we note here that the growth overall is on 23rd centile. Head circumference is well measuring on the 49th centile. We also see that cavum septum pellucidum was nicely seen, and there is bilateral mild ventriculomegaly. We also saw that. We also note that there is no parieto-occipital fissure appeared, though she's already 19 weeks. The frontal horns are prominent. You have the cavum septum pellucidum properly seen. Also, the sylvians are a bit flat. They are delayed as per the gestational age. In the mixed sagittal views, on the detailed neurosonogram, we don't see any other associated abnormality. No family history, and the parental HC was normal. Obviously, here we are not even talking about the head circumferences yet. So We discussed the possibility of chromosomal problems, genetic syndromes, cortical malformations associated with lissencephaly because you have delayed sulcation, and possibility of infections, particularly cytomegalovirus. So she underwent amniocentesis, and chromosomal analysis here came normal. CMV-PCR was normal. DNA was stored for if exome sequencing was needed later on. And she was advised serial follow-up every 4 weeks throughout the pregnancy. So we followed up at 22 weeks. Now the growth was slightly lagging behind. It was on 12th centile, hex circumference on 31st centile. We see the ventricles have become quite normal. They are no more measuring in the range of 10, but measuring within the range of 5 to 6 millimeters. The parieto-occipital has appeared. The Sylvian has improved. So we were quite happy with these improving structure of the brain. And we again called her back at 26 weeks. At 26, growth is maintained at 11th centile. However, when you see on the reference chart, the hex circumference is slightly coming down. Every time you measure it, interval of 3 to 4 weeks, the hex circumference is not growing, it's not maintaining its percentile. And structurally, the mixed sagittal view, again, everything looks perfect. The posterior fossa, the corpus callosum, brain stem. There is an asymmetry of the ventricles here. The cavum septum pellucidum looks a bit broad, but sulcations were quite kept. At this point, whole exome sequencing was offered because of the declining trend of the head circumference. And to our surprise, there were 2 likely pathogenic variants in the PCND gene, confirming the diagnosis of microcephalic primordial dwarfism type 2. By the time the results were obtained, she was 29 plus 3, and this was the scan post-exome report. And we see that there is further decline in the head circumference. The X score is still minus 1.9 standard deviation. So she's not even 2 ST below the mean, but we have a diagnosis of microcephalic primordial dwarfism. And the growth was further down on the 5th centile. The humerus was less than 1st centile. So it's almost fitting into the diagnosis clinically as well. So it's important to remember that the growth trend matters a lot. You have these patients appearing, measuring truly small, very late in the gestational age. So you always need to keep an eye, particularly like this patient presented with mild ventriculomegaly. So there was already a small suspicion that something could be there. But although the ventricles normalized, it is important to follow up every 3 to 4 weeks and look at the trends of the growth. And also on the scan at 29 weeks, we noted that both the ventricles had again become prominent, and there was absence of one of the septal leaflets. And yet the sulcations in this baby, they were quite normal for the gestational age. So that was mainly to highlight the importance of the growth trends. Another case we would like to discuss quickly. This is a patient at 23 weeks and 5 days. HCSX score is again like -2 as per Chernak. But we also have a small cerebellum here, a little bit small corpus callosum with CSP which is not cavitated. We see the Sylvians are quite lagging as per the gestational age at 23 plus 5. There is also a note made of coloboma of one of the eyes and irregular ventricles suggestive of heterotopia. So all these findings tell you that this is not just a small head, but you have probably a syndromic association like lissencephaly with cerebellar hypoplasia, and multiple genes are implicated here which have both autosomal recessive or dominant inheritance. So these cases, they have a poorer outcome and they need genetics to counsel on the recurrence risk. So to conclude, HC 2 standard deviation below the mean is not microcephaly. The definition is 3 standard deviation below the mean, but even then, only 60% of these cases will be true microcephaly at birth. If there is an association of growth restriction, structural abnormalities, family history, small foramen magnum to cranium distance, or head circumference 4 standard deviations below mean, the positive predictive value of microcephaly at birth can be increased. We need to keep in mind the genetic or infectious causes, even at head circumference 2 standard deviations below mean. And growth trends are essential to predict microcephaly. Thank you. We are open to questions now.
Hello again. I think we had an exciting day behind us, and we are approaching actually the last lecture of this day, followed by a discussion. And as you know, the discussion is as lively as you make it for us. So please don't forget to put in questions. Everything you are interested in the field of neurosonography, we are happy to discuss for this final discussion. And now it's my honor to introduce the next and final speaker of this day, Professor Gustavo Mallinger. I think he is very well known to you, most of you. He is a superstar in field neurosonography, a pioneer. He has actually introduced many of the things we have been talking about today to the field. He is actually a senior physician of the obstetrics and gynecology ultrasound division at Liz Maternity Hospital in Tel Aviv. And he was previously the leader and co-director of the fetal neurology clinic of Wolfson. So I'm really excited and honored to introduce Professor Mallinger.
When we speak about malformation of cortical development, the first classification implies that we have malformation due to abnormal proliferation or apoptosis, malformation due to abnormal neuronal migration, and malformation that are due to abnormal cortical organization. Macrocephaly forms part of the malformation due to abnormal proliferation or apoptosis, and the increase in the proliferation or decrease in apoptosis is what it calls megalencephaly or macrocephaly. I'm going to use megalencephaly and macrocephaly as synonymous during this lecture. The prenatal diagnosis is a big problem because many of us have large heads. So size matters. So in some cases, we can have a fetus that have a large fetal head that is completely normal. Other cases will have only macrocephaly, only large abnormal head. But there are also cases where we have brain overgrowth in association with other malformations. Why is this a problem? If you have a fetus with other abnormalities, other malformations, or we have an abnormal microarray or a pathogenic or likely pathogenic exome sequencing, usually this is not a problem. It's not a problem because you know that something is wrong. But why is truly a problem? It's a problem because most children and adults suffering from macrocephaly are born with normal head circumferences. Fetuses with large head circumference are at increased risk than those with normal head circumferences. 2.3% of the normal population have a large head circumference, larger than 2 standard deviation. And there is a very poor concordance between prenatal and newborn head circumference. Head circumference larger than 2 standard deviations are rarely diagnosed during the routine second trimester ultrasound examination. In many cases, one gene may have an abnormal mutation, or a mutation in one gene can have different mutations, have different phenotypes, and some phenotypes may be associated with two different genes. Mutations in the same gene can cause loss or gain of function, so producing a mutation in the same gene can produce, in some cases, microcephaly, and in other cases can produce macrocephaly. Somatic mutations causing macrocephaly has been described. What's a somatic mutation? Is the case where you have only abnormal variants in one system or one part, let's say, of the brain, of the skin, or any part of the body. I'm going to start trying to explain what the diagnosis is problematic. First of all, it depends on the nomograms you use. I strongly recommend not to use Hadlock for the diagnosis of macro or microcephaly, and here I can show you why is that, because the two standard deviation of Hadlock is very slim. It's only 1.8 standard deviation plus minus. If you use others, the standard deviation is bigger, so the chance that your measurement will fall between the abnormal range is smaller. Now, as I told you, many persons are born with large head circumferences, or may develop head circumference during early life and being completely normal. In this case, you can see a child that has a very large head. Children that have large head are more prone to accidents, as you can see here. But actually, this guy did quite well. And are images of myself as a young boy. And I was born with a head circumference of 39 centimeters. This is 3.1 standard deviation, and by now I am 71 years old. My head circumference is 61 centimeters, that corresponds to 4.1 standard deviation. So it can be difficult. And I was lucky actually that at my time there was no tool. Now I'm going to show a case, a quite recent case, but we managed to publish it. The patient comes to us. She was 29 years old, gravida 1, and we saw her for the first time at 35 weeks and 4 days. And he was referred for a second opinion because of macrosomia. She came to us with a fetal brain MR that was considered normal, and also the CMA was normal. But what you can see here in the images is that it was not only the head that was big, the whole fetus was quite big and was more than 99 percentile according to Hadlock. But look at the head circumference at 35 weeks. The head circumference was huge. And what I did is to look at for the growth of the head circumference using the measurement that I have until now. And here you can see that at 29 weeks, the head circumference was 1.9 standard deviation, completely normal. At the 34 weeks and 4 days, and this is why the patient was referred, the head circumference was 2.7 standard deviation, and 1 week later, it turned out to be 3.2 standard deviation. Again, the head was large, but there were not any clearly associated anomalies. It was not ventriculomegaly. The corpus callosum was not very big, and you should remember that also the MR was considered normal. But we decided to ask for an exome, and the exome came quite later at 38 weeks, and by this time the results were of a VUS variant, a variant of unknown significance, but the interpretation was that this is a variant that was identified in a gene that is called CHD3, and the genetic diagnosis of a syndrome that at this time it was for me unknown, called Snyder's-Lobel-Campeau, was considered possible. So when you see something like that, what you need to do is to go, what is this syndrome? And by this time there was only one paper published in Nature Communication about this gene that present with a neurodevelopmental disorder with macrocephaly and impaired speech language. And when you can see here that 60% of the children in this study presented with macrocephaly, and there was also something else, was also widened CSF spaces that were diagnosed on MR. And this is the picture of the syndrome, of different children with the syndrome, and you can see there is nothing very particular, but head. And this is the 3D ultrasound image. The nose a little bit flat, but nothing else. As you can see also in the stillbirth, because the family decided to go for termination. But when you look at the MR, you can see that actually, truly, the subarachnoid space is very, very, very wide with a lot of fluid around the brain. And we published this case as prenatal diagnosis of Snyder-Bloch-Campeau syndrome, a fetus with macrocephaly. Another issue that's important to remember is that there is a difference late in pregnancy, a difference in the size of the fetal head between females and males. The difference around 0.5 centimeters. 0.5 centimeter is more or less one week of growth. So most of the children that we suspect of having macrocephaly are actually boys. Now, the prenatal diagnosis rarely report. In a PubMed search we performed today, we found that macrocephaly in the title with prenatal diagnosis was only diagnosed or published in 29 papers, megalencephaly with prenatal diagnosis only 10 papers, and if we look for hemimegalencephaly with prenatal diagnosis, there are only 16 results. Now, what we did before the next generation sequencing, we published in 2011 one study of our cases of children that have a large head, and there were two groups. One they don't have associated anomalies, and the other group B, was fetus would have something else, and the difference were not very big. Mainly the size of the head. In group A, the head circumference was in the range of 2.3 standard deviation. In the group of syndromatic macrocephaly, the head circumference was 2.9. The mean head circumference was 2.95 standard deviation, and this was significant. The gestational age at diagnosis was also a factor, but it didn't result to be statistically significant. So what happened? Most of the children were in group A was isolated macrocephaly, and in this group the children were delivered with high weight, large gestational age. In 43% of the cases, 68 of the children have a parent, or a father or a mother, were also macrocephaly. Most of them, as expected, were boys, and almost all of them have normal development. No cases of mental retardation. There was one child with autism spectrum disorder, and 3 need physical therapy, but not in particular. And one asked for termination of pregnancy without any other finding. In the group B, most of them, as I told you, have by definition something else. Many of them have mild ventriculomegaly. Almost all of them have callosal anomalies. We were able to find some kind of malformation of cortical development in some of the cases, large subarachnoid space, large CSP, an open operculum, and other anomalies. 15 of them have non-CNS anomalies, have anomalies that were not associated with the brain. And we were able to make the diagnosis prenatally in a case of 3q deletion, one case with Verbian dysgenesis that by now we think that most probably was a case of Schubert. We had a case of achondroplasia, one of hemimegalencephaly, and one of what we call MPPH, or actually it can be MMPH or MCAP. Postnatal diagnosis was done in another brain findings, yes, in Banyan-Riley-Rubalcaba syndrome, one case of MCAP that was diagnosed postnatally, one case of SOTOS, and the others have associated anomalies but not a specific clinical diagnosis. And this is one of our cases, a very large head circumference with nothing else. And actually, this girl turned out to have a macrocephaly capillary malformation syndrome that was diagnosed only later on because of the rectal bleeding. And this girl should be around 20 today, and she is doing well. She's attention deficit disorder, but she has a very, very large head. And here we have another case where we saw mild ventriculomegaly. We didn't like the shape of the face. It was a large amount of subarachnoid space were large, and a very large corpus callosum. The head circumference was as defined macrocephalic, and we were also able to see polydactyly. We performed an MR at 32 weeks that diagnosed polymicrogyria, and this was confirmed at the age of 3 months. And this is the child with the polydactyly, the presence of an hemangioma that was not observed during pregnancy, but actually was here. And this child suffered from severe mental retardation. You see here also the hemangioma in the face, macrocephaly capillary malformation syndrome. The conclusion at this time of our paper was that fetal macrocephaly with a head circumference between 2 and 3 standard deviation and not associated anomalies usually carries a good neurodevelopmental outcome, in particular when there is a family history of benign macrocephaly. Fetal macrocephaly associated with other CNS anomalies or non-CNS anomalies implies syndromic macrocephaly, and the prognosis depends on the specific syndrome and the association of brain malformation. A genetic diagnosis can be suspected based on these findings when you have a general overgrowth, short limbs, or polydactyly. Syndromic macrocephaly is usually diagnosed only in the 3rd trimester. Usually there is seldom time for genetic confirmation. Today we are obtaining these results much more faster on. An acceleration in hair growth in the 3rd trimester usually implies syndromic macrocephaly. It will reach more than 3 standard deviations. Chromosomal anomalies may be present as macrocephaly. At this time we have only CMA. Underdevelopment of the operculum is poor prognostic sign, and we have a very thick corpus callosum is frequently in these cases, and as expected carries a poor prognosis. And this is perhaps the largest head I found during my work. Is a case of extreme macrocephaly with polymicrogyria. The head circumference was according to our curves plus 6.4 standard deviation, but if you look here, the head circumference according to Hadlock was 9.1 standard deviation. It was a very thick and short corpus callosum, very abnormal, and a quite large cerebellum. But what is important is that we were able to using transabdominal ultrasound, we were able to see the polymicrogyria. You can see it quite nicely in the video, but also in the still pictures. Very early in pregnancy, 21 weeks, you should not have sulci, and they have multiple very, very small sulci, and eventually this family decide to go for termination of pregnancy. It's a case that I saw years ago during a course in Singapore. Now we turn now to the next generation era, and with the next generation era, what we add to our flowchart for diagnosis of macrocephaly is the possibility to perform exome sequencing, and in no time there are places that can perform by now genomic sequencing. So if you have a fetus that have associated anomalies, okay, you can suspect that have syndromic macrocephaly, and here it's quite clear that the exomic sequencing is indicated to confirm the diagnosis. But even if everything seems okay and there is no other findings, we add to the neurosonography and the fetal brain MRI, we are at this step also the possibility to perform exomics. And today we can have results of exomics in around 10 days to. And in 2015, we saw our first prenatal diagnosed case using or with the assistance of exome. The patient was referred at 31 weeks before because of macrocephaly, gravida 1, no amniocentesis, the alpha fetoprotein was normal, early ultrasound screening normal without normal biometry, but by around 23 weeks, the fetus present with a very large head, and here you can see the profile showing something that is quite useful to be sure that there is a large head is to compare between the size of the distance between the menton and the nose, and from the nose to the vertex. And here you can see that this distance is much larger than this one. Okay, these are the transvaginals, and what's quite clear was that the corpus callosum for 33 weeks was very large, 3.7 centimeters, and if you put it in the curve, you see that it was a very large corpus callosum that went unobserved. And here you have the image at 28 weeks, and again you have a very large corpus callosum. By now, there is no ventriculomegaly. The shape of the lateral ventricle is quite particular. Here you can suspect that something is going wrong with the sulcation, but the physician that performed the examination was not sure about that. But when you put the size of the corpus callosum, okay, here you see that it should be around 35, 36, and you see it's almost 5 centimeters, a huge corpus callosum, and here's how the head circumference grows until we saw it for the first time. And this is the head circumference and the measurements at 30 weeks and 5 days after termination of pregnancy. It turns out that the patient the fetus has a AKT3 variant. And here you see how it continued to grow with quite a lot of sulci at 31 weeks. Again, the very large corpus callosum, and what we saw at 23 weeks was here much clearer the presence of severe macrocephaly. In this case, we have also a post-mortem examination that the weight of the brain was 4.6 standard deviation, although the head circumference was only 2.3. There was deep narrow sulci in cerebral hemispheres, fossio-cerebral cortical dysplasia, cerebellar polymicrogyria, and they found also visceral vascular anomalies, multiple facial dysmorphism with depressed nasal bridge, wide nose, protuberant lips and tongue, and cupid bow. Here, the head circumference at 23 weeks and 4 days was 2.5 standard deviation. We saw the patients 3 weeks later at 26 weeks, and by now the head circumference was 4.3 standard deviation. The weight estimation was up to the percentile 97, and here what you can see that there is a difference in the size. It's not very prominent. There's a difference in the size of the hemispheres. You see here that you have the presence of sulci at 26 weeks that in this size are not present, a very large corpus callosum, and again a very abnormal shape of the lateral ventricles that are not only asymmetric, but the shape of the lateral ventricles and also the shape of the basal ganglia is abnormal. And here again we have a mutation in the PAK3R2, and also here we have pathological studies with a head circumference of 3.6 standard deviation, brain weight that was 6 standard deviation. And the pathology confirmed the presence of polymicrogyria that were multiple and bilateral, alternate with 6 layers of normal cortex, facial dysmorphic features, high wide forehead, depressed nasal bridge, short nose, and everted nostrils, hypertrophy of the first two that was bilateral. And this patient again was referred to as 24 weeks and 6 days because of mild ventriculomegaly. Again, here you can see that at 24 weeks you don't expect to see sulci, and you don't expect to see this serrated pattern of the cortex with a large corpus callosum. Okay, but the ultrasound at 28 and 30 weeks, where the head circumference was within normal range, the corpus callosum was considered normal, and the left ventricular width was also within normal range. We saw the patient at 34 weeks and 6 days. By this time, the head circumference was 3 standard deviation. The corpus callosum was well up to the percentile 97. The patient was referred for MRI, okay, and the exome was expected only to be obtained after delivery. And this is the MR that was not very good in quality. The patient opted for termination of pregnancy, and the exome showed again a PIK3R2 mosaicism de novo that was found in fibroblasts in the amniotic fluid only in 8% of the cells, but in the brain tissues that were obtained after termination from biopsies in 20% of the cells. Now this is the last case, 32 weeks. 32 years old, gravida 2 para 1. The examination at 15 weeks is normal. At 23 weeks, there is ventriculomegaly. The vermis is not present. There is dysgenesis of the corpus callosum, and is referred for termination of pregnancy due to severe brain anomalies. And these are the images with the head circumference. That's 3.6 standard deviation. The weight is in percentile 76. And here you see that it's clear that there is a very severe malformation with ventriculomegaly, the abnormal vermis, and very abnormal sulcation. Here you have the vaginals. Again, it's quite clear that something is wrong. The corpus callosum stops more or less in the middle. And there is also polydactyly and a very, very particular and abnormal thumb. You can see here also the thumb in the 3D image. Okay, so the patient decided for termination. The pathological diagnosis confirms all the diagnosis. Okay, but at this point, our pathologists have experience in the diagnosis of these conditions. So in the diagnosis, an autopsy differential diagnosis that considers megalencephaly, polymicrogyria, polydactyly, hydrocephalus syndrome. We spoke about this syndrome before, or it also can be a variant, a mutation in the PIK3R2 genes, or it can be a megalencephaly capillary malformation. Our pathologist good intention was very good intention and tried to help us, but what helped us was the exome. It turns out there was not one of the characteristic or more common forms of macrocephaly, genetic macrocephaly. We found a pathogenic variant in the gene that is OFD1 gene that has not this variant was not described previously in the general population, not in ClinVar, but mutations in these genes are associated with Joubert syndrome 10, orofacial digital syndrome, Simpson-Golabi-Hamel syndrome, primary ciliary dyskinesis, and the phenotype is compatible with all the Joubert-related syndromes. And we went to look to the literature, and actually has been described, these variants in this gene has been described with macrocephaly in children. So in conclusion, if you have a case with macrocephaly with associated malformations, you can consider termination of pregnancy followed by exome. If there is apparently isolated macrocephaly, the decision in most cases should be based on exomic sequences. But what I can tell you, if you have a suspicion today, exome or genome sequences for all. So in many cases that you have you don't have any suspicions and you want to do an amniocentesis, perhaps we need to start by doing an exome or genome if you have the possibility, and not waiting until 35 weeks to make the diagnosis. This is very controversial because of the huge chances that you can find the VUS variants or likely benign variants that will produce problems in diagnosis and problems in prognosis and problems causing unnecessary stress to the family. But the question will be, what are you going to do to when your daughter will be, or the wife or your son will be pregnant? Thank you very much.
Hello there. Thank you, Gustavo, for your amazing and comprehensive lecture. And we are now open for discussion of this last but not less important session. So I'm going to start with question from the audience to Rachna. Is it better to use the cephalic index than the head circumference to suspect of fetal head size abnormality?
Well, for the size, the best parameter remains the head circumference, but cephalic index can tell us about the shape and whether it is dolichocephalic or brachycephalic. And again, it is helpful to correlate the shape with the parental head shape. And we also know that breech fetuses, usually they are more dolichocephalic. So if you have a larger OFD compared to the BPD in a breech, that is probably a normal variant. And but for the size, the head circumference remains the best parameter.
Thank you, Rachna. And Gregor, we didn't have time in the session to address properly the MR, but we would like to hear about some of the contributions of the MR studies in cases of small and big heads. The main challenge is that normally from macro is less, but I think from microcephaly, we are normally not getting to the -3 standard deviations. Either we are going to go to MR in the meanwhile, when here in Israel, the protocol is whenever the fetal head is below -2 standard deviation, or there is already a suspicion on the abnormal trend. So if you could speak about what would be the points in which you think that the MR could contribute the most?
Well, as you touched on this topic several times today, I think that it absolutely depends on the quality of neurosonography. I mean, if you really have excellent neurosonography and you see all the details you want to see, the diagnostic yield of MRI will not be very large. I remember very well a case we saw where there was a microcephaly basically measured, and we looked at the MRI, totally structural normal MRI. We without biometric measurements of the head circumference or the different brain and head diameters, we would have thought this is a normal brain. But in the end, while I was talking to the patient and said we did the examination, I got a call from the referring doctor, and they said they just found a really devastating microcephaly genetic abnormality in this totally normal brain. So it's really you need everything, genetics, ultrasound, and if you have any doubts, you don't see some structures very well, do the MRI, and that's either true for macro and microcephaly, and particularly also in the third trimester, if you actually do not have insights to all parts of the brain, it certainly makes sense to use the MRI.
Yeah, a point that I think particularly difficult is whenever we have enlarged extracerebral spaces, sometimes it puts an additional challenge to speak about the sulcation. And sometimes like simulates, or I've even more developed or underdeveloped sulci. So whenever we have a more fluid between the sulci, sometimes, and I see my radiologists really struggling with cases like that. Of course, that if we have a very small head and an enlarged extracerebral space, so the brain will be even smaller. But in cases of big heads, it can be quite difficult. So sometimes we do a series of scans, trying to understand what are the progressing patterns of the sulcation.
I believe that in the future, in a couple of years, there will be sort of a disruptive development on MRI when we have more confidence on our automated brain segmentation methods, where you have post-processing, you put in your MRI data, and you will ultimately receive numbers on the volume of the entire brain, the cerebellum, brainstem, cortex, and basal ganglia. And all the measurements we have been used to do on the diameters of the bone and the skull, we can now apply to the brain. This, of course, will open up new discussions. What is then a too small brain? What is too large? But these things we need to find out in the upcoming years, because the technology will come.
Yeah, we'll start struggling with the brain volume nomograms then. Probably. Rachna, can you speak about the frequency of follow-up examinations? Here in the question, so the participant asked if there is no access to MR, but independently of MR. So how frequently do you follow these patients up?
So it depends on the first examination when we have seen, like if it also depends on the law of the country. For example, if I have seen a patient around 21, 22 weeks, and the law says you cannot terminate beyond 24, I would like to follow up this patient within 2 weeks to see if there is a further decline in the Z scores. But if you are already beyond 24 weeks and it does not make much of a difference to the management, then it is ideal to have a gap of 3 to 4 weeks to see the trend better and follow up every 3 to 4 weeks.
Yes, and they are asking which charts are the best.
At the moment, we are sticking to Chervenak because we saw that there is no statistical difference using any other charts, and it has a wide standard deviation as it was explained in the presentations. So it makes you less likely to have a false positive diagnosis. So at the moment, we are using Chervenak. Any other comments?
We are using also Chervenak also for big and small. So we are using Chervenak Z scores. And it's very, very important to state the trend. And I think another interesting topic would be to explain to our participants. So in ultrasound, we are going to measure the cranium. And Gregor, you use different measurements in order to estimate.
We use a reference tool by, and that's a difficult name. It's a Greek name, Kyriapoulou. This is a paper on brain structure and function. And if you just put that in to PubMed, you will find with the paper an Excel sheet where all these reference values are there, and I find it very useful. You can look at the MR2D measurements, but also you can put in volumes. So that's out of practicability, we are using that currently. And for the posterior fossa, we have our own, still own reference values we are using. But as said, these values and references in MR will be more complete. Please also be aware that our MR data is usually enormous, based on a very small sample compared to ultrasound, where you actually base your measurements on thousands of subjects. And MRI reference data is usually normative MRI data is based on hundreds. At maximum 100 or 200 subjects.
And this is another aspect which is important when speaking on the biometry. Not always the biometry is made in the same spot. We have also addressed this aspect speaking about the ventriculomegaly. I always explain to my patients, I'm not sending you to MR to check if there is a ventriculomegaly. I'm sending you to MR to see whether there are associated findings. And then she comes out of the ultrasound with 10.5 millimeters. And then she comes back with an MR that says 12.5. So for them is very, very threatening. So it's also important to explain to the patient that the biometric references are different. And another important contribution, Gregor, I think it's also, especially in the so-called isolated microcephaly or small heads, the minor abnormalities of the cortical development. And is there any benefit from DTI in these cases?
I would not expect it from DTI. You could look a little bit better into white matter development, but I don't think that DTI, as you are using it currently, which means we are looking at individuals. But in the future, particularly the Boston group is working on a DTI brain atlas, which means that you can compare individual brains to this atlas and see if in which regions the brain is different from, let's say, normative standards. This is something also under development and to come in the future, but just of current simple tractography to understand the connectivity will not really solve that problem. Cortical abnormalities are often subtle. I find it personally very hard to look at polymicrogyria after 33, 34 weeks. There's a window between 34 and birth. I find just as a subjective evaluation, it's hard to really be sure that this is polymicrogyria or is not polymicrogyria. I find this a very challenging period, and I'm a little bit more confident to see that on postnatal MRI, because there is a certain weakness and limitation in prenatal MRI in image quality.
And this slight limitation about the lack of myelin, which poses a challenge for fetal MR, that I think it's quite important. I think I'm going to end. Rachna, this is for you. Is it better or worse to have an IUGR fetus with a small head?
It is usually worse, actually. Normally, what we have experienced, that if you have an IUGR fetus also with a small head, that means it is quite a severe affection. We expect the head to be spared if it is only uteroplacental insufficiency, but you also have smaller head, that means smaller brain volume. The chances of insult are quite high in these fetuses. So there is no study to say that, but in general, it appears to be a bit worse.
Yeah, indeed. I think it's also a science in development, and I will take the opportunity to invite you guys to join Gregor's event on May. I'm going to be there speaking about that, the microphenotyping of the brain in FGR fetus, and there will be many other amazing lectures, very high quality, also on fetal phenotyping, and I think these very subtle abnormalities that we can see, especially in FGR fetuses, may be the clue for sending them to genetic investigation, not only about insults, but also about the presence of genetic basis for that. So if we have a genetic abnormality in the placenta as well as in the fetus, many times the placenta will be dysfunctional, leading to growth restriction, and then also being part of the another organ that it's involved in the syndrome, but many times with only subtle morphological findings. So I think the important message for the high risk doctors, as you have showed, is to use the differential, not only to check on the fetal estimated weight centile, but what's the size of the head, the size of the long bones, because sometimes the clue to suspect on an abnormality, on a genetic abnormality, will be in the differential measurement, and not only is in the which centile is the fetal weight. And if you wanna have one last comment, and we are going to call it a day.
Oh, I always think that the follow-up of the fetus is much more important than single moment estimation. If we have abnormal findings on the first scan, it is fine. But even if you don't have abnormal findings, you must follow up very regularly using the growth charts, and not only the head, you have to see the entire fetus. It is not just the brain. You have to look at the heart, you have to look at the kidneys, you have to look at the growth of the long bones, as Nina said. And it's not just focusing on one aspect of the fetus. You have to see fetus as a whole, including the placenta and the family as well. So if you have a wholesome view, you're in a better situation to catch the abnormality.
Gregor, your final observations?
Well, fully agree what Rachna said, and I find it interesting that sometimes brain measurements are quite predictive of outcomes, an association which is frequently underestimated, I find, and we find it quite confirmative, that if you have a reduced transverse cerebellar diameter in the setting of FGR, this is often a very bad sign.
Yeah.
And it's interesting that just one organ, one measurement is very predictive, where others are not so predictive. And I think this is the exciting part of measuring different things. And I think, as just noted previously, in the future, we will have even more numbers and even more headache to find out what is relevant and what's not relevant.
So you say that AI is not going to take our jobs?
I think AI will never take our jobs, but it basically will create other demands, because you always will need to have a person to decide, and for these decisions, Gustavo is always nicely showing that with his own image of himself when he was young. So as a boy with a relatively large head, he is not macrocephalic. It's our decision how to define a disease or a finding, and that's nothing you can kind of make AI decide. This is a philosophical question, and it linked to human values.
Thank you very much. And on this interesting last topic, I would like to invite you guys to to answer example survey that we are going to receive on your email on other interesting topics that you are willing to see in further courses. And the recordings will be available for you all for the next month. Thank you so much for being with us this long Saturday, and I hope that it would have been it had been profitable for you guys. I have enjoyed a lot, and see you next time. Bye bye.
Bye bye.
Bye.